and labor. No single test, no single treatment. Any progress? The answer is no. Why? Because you and me know this is the list of the causes of preterm labor, which is the student, which is the undergraduate, which is our colleague. These are the lists been there for the last 40 years or so. But actually, it's very deceiving because there is now a lot of work being done here, and that's why I'm talking to you today. Infection, there has been a lot of progress in terms of infection as the cause of preterm labor. And I must put this man picture up there because he contributed significantly to our understanding of preterm labor and infection as the cause of preterm labor. What do we know so far? So far we know that the bacteria invade the uterus. These bacteria came from the lower genital tract and gain access to the uterine cavity and causes infection. This infection affects the amniotic fluid and the baby, and there is evidence for this, microscopic evidence of this, invasion of the amniotic cavity. What are the organisms? Number of them, but the most important organisms are these one, ureaplasma and mycoplasma humanos. These are the two organisms which we believe are the main causes of preterm labor. That's what happens. If this gain access to this cavity, it will affect the uterus, will contract, it will affect the membrane will become weak and will prolapse in the vagina. And we're going to see the end result of this. What's going to happen? You get the contractions, preterm labor with intact membrane, cervical insufficiency, and ruptured membrane. They are the possible scenarios after invasion by the bacteria. So, what I'm trying to tell you today is that we should be moving towards personalized medicine, personalized treatment. When a woman comes in preterm labor, A is different from B is different from C, and C is different from D. They are not one condition, and you have to find out what is the cause before you embark on treatment. Otherwise, we will not progress. Ultrasound has played a major role in our understanding, and I'm going to discuss these three things. So what about women who come with preterm labor with intact membrane? I told you about this woman at 28 weeks of gestation, having contraction, but the cervix is closed, and the membranes are intact. So what is new? What is new is that you have to make a diagnosis whether they have an intrauterine infection or not, because that is one of the main reasons for preterm labor in more than half of these babies. And the argument is very simple. Let me show you this slide. If a woman here complains to you with a severe headache and fever, you suspect brain infection or brain abscess. It is serious disease, it is fatal, and that's why we do lumbar puncture. But if the woman comes to you with the preterm labor and she's contracting, and we think it may be infection, we don't do amniocentesis. I don't do it very often, and I'm sure you don't do it. And there is a good reason for this, because we used to believe that there is no treatment. Now, what's happening now, we know there is a treatment if there's an infection. What do? You do amniocentesis, and you look for glucose, white cells, neutrophil, and gram stains. But something happened in the past few years, in the past 2 years exactly. 2 tests developed, and that's why I write new. One is interleukin-6, and the other one is MMB8. These 2 tests are simple tests done at bedside and give you result instantly. So you give the sample, immediately you give it to the lab, and they give you result. There's infection or there is no infection. So that is a major development in the past few years. And this paper is a landmark paper by the group from South Korea, where they have shown clearly that if you use antibiotics, you are going to clear the intraamniotic infection and inflammation. The drawback is simple. They rely on IV medication, which include cephalosporins and metronidazole and a family of erythromycin. This treatment has to be IV. We do not know for how long, but we have evidence that it clears intrauterine infection completely. What about cervical insufficiency? Those who came with cervical insufficiency. Cervical insufficiency is defined as inability of the cervix to maintain pregnancy in absence of uterine contractions. And this has been easily to diagnose with ultrasound. We made a big progress in vaginal ultrasound, and we can now see with doing a vaginal scan in 1 minute whether the cervix is closed or open. So what is the next step? If you have a patient with cervical insufficiency, you can make a diagnosis. And you can see these pictures like here. There is a herniation of the membrane and there's a short cervix. And sometimes you can also see material in the cervix here, and that's what we call the sludge. So the presence of sludge, breast short cervix, breast herniation is the indication of intra-amniotic infection. And if you want to do cervical circulage, like you and me, then you have to make sure that there is no infection. If you put a circulage for this woman, you are simply not only not helping her, but you are adding to her problems. So if you want to do cervical circulage, before you do cervical circulage, make sure there is no intrauterine infection. Now, circulage is a big issue. And you and me do circulage on a regular basis, although I don't do it very often, but for these three reasons, either based on the history, or because the cervix is short, or because of the rescue and emergency circulage. That's what we do. What is the good news? The good news is we have two types of circulage. One is McDonald, and the other one is Shorotka. And the good news is that they are both very effective, and there is no argument. In medicine, when there is no argument, I'm very happy, because at least we have this one. We do circular, we do McDonald, we do Shorotka, it's all the same. They are both effective if done correctly. So you know that McDonald will do simple stitches, while Shorotka will make an incision and push the bladder away. So what about those who got a history of cervical, of preterm labor? If you do circular in these women, there is no any benefit at all. But if you do cervical circulage in women with preterm labor, whose cervix is being shortening with time, there is benefit. So if you have a woman, you have got doubts about possibility of preterm labor, that a woman is candidate for regular cervical surveillance. Why I'm going to do all these details? Because again, circulage is not easy. Circulage is an operation. You have to go to theater, go to general anesthesia. It has its own complication. It can cause rupture of membrane, vaginal bleeding, preterm labor. It can cause death. So it has to be done rationally. Now, the last thing I'm going to discuss in this regard is rescue circulage, which is a big, big problem. You are sitting in the clinic or in the outpatient clinic, and then you have a woman who came to you with slight lower abdominal pain. You put the scan, you find there is hardly any cervix, and the membranes are bulgy. And you may also saw a material here, what we call sludge. So what do? You plan what we call rescue circulage. If you ever think about rescue circulage, and you do not exclude intra-amniotic infection, you are not doing your patient any service, because more than half of these patients will have intra-amniotic inflammation or infection. And doing rescue circulage is adding oil to the fire. So this herniation of the membrane and short cervix is just a marker of intra-amniotic infection. So make sure that you got an infection, and this is what you do every day, a rescue circulage. What is new? What is new is this one. A group in South Korea, again, developed this very, very nice balloon, which will help you to push the membranes inside before you put your circulage. I remember you and me, probably you are the same like me. We used to struggle to put the membrane with the gauze or something. But this balloon is developed by South Korean group. It's a really very effective balloon, and I wish you can use it because it's really helpful. Now, what I've been telling you so far, and I want to repeat again, that if you ever consider rescue circulage, then you have no other option but to exclude intra-amniotic inflammation or infection. And remember, you have two simple tests. One is interleukin 6, and the other one is MMB8. These two tests are available now commercially, and they're done at the bedside and give you instant result. So far, I've been telling you that we are moving more towards personalized medicine. Cerclage is effective in cervical inefficiency where there is no intra-amniotic infection. So these are two tests which I insist again to show it to you, to repeat it again for you too, so you can remember them. And as I repeat again, please don't do it unless you exclude intra-amniotic infection. What about ruptured membrane? What is the new development regarding ruptured membrane? Again, there is a development of a new catheter which can help you to collect the fluid non-invasively. So if you have got a lady with ruptured membrane, you apply this catheter and you collect the fluid and you test the fluid for infection. You start treatment, repeat the test again, and then the fissure is clear, you can do it. So it is a very, very effective way of collecting fluid in case of ruptured membrane. So I want to conclude by saying this part of the lecture that antibiotics can eradicate intra-amniotic infection and inflammation successfully. The treatment described here, as you can see in the slide, given is IV fluids, IV antibiotics, and it can be very effective in removing the infection. So what about local experience? What do I do every day in my practice? The IV therapy is quite expensive and it needs hospital admission. So we decided to do the following. Instead of the IV, we decided to give oral cephalosporins, oral erythromycin, and vaginal metronidazole as our own protocol. And I'm going to give you some example. This patient here, she came with labor, with no slight pain, and we just gave her the protocol I told you, cephalosporin orally, erythromycin, and vaginal metronidazole, and she's still not delivered. I have a global patient now, a cohort of patients now who respond very well to these local oral and local antibiotics instead of IV antibiotics. And hopefully, inshallah, with my friend Muhammad Kamal and Ahmad Khatib and colleagues here, we can repeat this protocol at a bigger scale, and hopefully, maybe next year I come and tell you our experience with oral treatment. Now, I like this slide very much. What is our strategy? What are the opportunities we have for preterm labor? I'm going to stop you, and I want you to sing with me because I like this very much. Professor Jackson Osborne from Sweden, he developed a very interesting concept that he described preterm labor very close to fatal car accident. If you have a fatal car accident where people die, he said complex phenomena, and preterm labor is the complex phenomena. A preterm labor is just like a fatal car accident. But he said in car accident, the volume of the traffic increases all the time, but the fatal car accident decreases all the time. And he said this is because of the number of the intervention we did, not because of single intervention. And he said we could do the same thing with preterm labor. So you can see here the number of deaths from the car accidents coming down, traffic going up. But we are failing. Preterm labor is the same. So what they suggest is what we did here, the whole world, is introduce seat belt, no alcohol, don't drive with the mobile phone in your hand, speed limit, etc., etc., and that make a difference in the incidence of fatal car accident. The same thing can be applied to a preterm labor. I like this word very much. A low hanging fruits. يعني ايه low hanging fruits؟ يعني ما يسهل قطفه. ايش الشيء السهل؟ What is the easy thing? What is the low hanging fruits in preterm labor? The low hanging fruits are the following. Number one, ART. We do ART, all of us. The aim of ART should be single cycle, single baby, full stop. What is the other next low hanging fruits? Infection. If you have a patient, risk of preterm labor, make sure before pregnancy she got no infection. Dental care, vaginal infection, take everything out. These are low hanging fruits, easy to do. Again, avoid an intervention. Please don't do induction of labor unnecessarily. the best way to avoid induction of labor is to make accurate diagnosis of the expected delivery and use the law of 5 and 7. What does that mean? If you do a CRN in the first trimester, use the law of 5, which means that if the difference between the menstrual period and the age is more than 5 days, forget about her periods. Take the dates from the scan. And second trimester, use the 7 days rule. If more different more than 7, forget about her period and put her date from the scan. And please, please, I pray for you. One of the main problems I have in Doha, and maybe I'm sure here, people don't know the date of delivery. Tell the woman that your due date is so and so, and that will not change. What else? A voice on public health issues. What is it, public health issues? For example, simple things like omega-3, multivitamins. Some women are deficient in this before they enter labor. And I come to the concept. Instead of using seat belt, avoid alcohol, maintain the road, no mobile phone, we do these low-hanging fruits. And with these low-hanging fruits, we can make a big difference. Because I repeat myself again, preterm labor is not a disease, it's a syndrome. I'm going to end my lecture by talking about this for 2 minutes. I believe for everybody in this room, gynecologists, obstetrician, remember the vaginal 3D ultrasound is a very, very powerful tool. 3D vaginal ultrasound is a very powerful tool. And I like this word, it is the GPS of the uterus. What does it mean? It means if you use a vaginal probe with 3D, you can see every single millimeter of the uterus in great details. And I mean it, every single millimeter of the uterus will be in front of you in 2 minutes. What do I mean? If you look at this case, this is the patient. I'm scanning her, you can see here. And you get a sagittal view of the uterus. You put your 3D on to collect the volume. So I'm just scanning the sagittal view of the uterus. Once I'm very happy, you put the 3D, and then you wait until you obtain a volume. And you just wait, I'm obtaining the volume now. The trick here, do not move fast. Just wait, you have to wait, take it very slowly. Now you're acquiring the volume. Once you acquire the volume, you get this picture. Then you put the probe, you don't need the brain anymore. You're going to use the computer now. So you're going to manipulate this volume. And we use something called OmniView, which is simply, you just draw a line across the cavity with the mouse. And that will draw for you the entire intrauterine cavity in great details, as you're going to see in a minute. And you can see now I've got it now. Now I can make it single, and I can change the color. And you can see here, you can see the uterus, all details of the uterus, the cavity, and you can see even the ostial end. So we have a tool which will tell us about details of the uterus. Why do I say this? I'll show you this the next example. Here's the normal patient. Take the example. These two patients here. And notice what I'm going to do. I'm going to repeat what I told you just now in these two patients, one on the right and one on the left. They are both going to show you something now. So you just acquire the volume and you wait until you are settled. You look at the cavity and then you apply the 3D box. It's coming now. The advantage of the 3D 4D is non-invasive and it takes only 2 minutes. This is a 3D box, and you make sure that you capture the whole uterus, and then once you are happy and relaxed, you acquire the volume. And now I'm acquiring the volume. Once I acquire the volume, you put your probe, and now you only need the mouse to use. And you get these sort of pictures. And you work on the pictures. All what you need is this one, OmniView, which I use every day, which means drawing through the uterine cavity. Just draw a line. The uterine cavity. You can see here. On the left side, you can see already that the pathology appearing that there's a unicornate uterus, the unicornate, which was not clear from the 2D, but with the 3D is very clear. And on this side, there is a complete separated uterus. Why I say it's a powerful tool? Because all what I did now is finished in 2 minutes time. And you can train in 1 day. It's not chemistry. It's one day you can learn this technique. It's a very powerful technique. So, take home message. I'm sorry, I've been talking for a long time. One, that preterm labor is not a single disorder, it's a syndrome, and intrauterine infection inflammation can be treated successfully. So what does the future hold for us? I've just been telling you all morning that these sets of antibiotics, you can be used, but you have to make amniocentesis to make sure the diagnosis is cured, because you cannot stop the treatment until you make another amniocentesis to confirm that the dose is clear. So you and me will not be happy because we don't want to put the needle all the time on this partner's woman. So what is the future? There is now a lot of work being done on CRP, excision age at presentation, cervical length, and fibronectin. These 4 factors are going to be put together to predict those women have got intrauterine infection. If this works, it means that we can now make a diagnosis of the infection, we can treat the infection, and we can stop when the infection is cleared. Thank you very much.
Thank you, Dr. Badreddin, for this very nice lecture. We'll have discussion after the end of the 3 presentation. Now it's my pleasure to present you Professor Katia Bilardo, Professor of Fetal Medicine at UMCG in the Netherlands. And she's an expert on ultrasound and invasive prenatal diagnosis. She's going to give us her experience on change in paradigm in prenatal diagnosis from NT to NIPT. Thank you.
Sorry, we are just trying to make the connection working. I want to make my compliments to the previous speaker, who really gave a wonderful overview on prenatal, on preterm labor. It was a very, very nice and comprehensive lecture. Nikos, may I use your connection? Sorry about that. Not quite right. It's a bit too small. Yeah, okay, perfect. Okay, let's start. It is my pleasure today to discuss with you this change in paradigm that we have seen from the nuclear translucency measurement, the first trimester screening by the combined test to cell-free fetal DNA. Well, let me just remind you the principles of screening. The condition we screen should be an important health problem. There should be a good screening test for the condition which is acceptable to the population, and that should have a high sensitivity, specificity, and positive predictive value. Well, usually when we screen a population, we set a certain cutoff to define the screen positive group. And then we have the false positive rate, which is in actual fact the percentage of euploid pregnancies in the screen positive group, and the false negative rate, which is the percentage of aneuploid fetuses in the screen negative group. Well, the first screening for Down syndrome was in actual fact maternal age, and it was already identified by Shuttleworth in this book that he wrote in 1909, which suggested that the majority of these children were born from women who were already approaching the climacteric period. So this association is known already for a very long time. And then with time, new criteria much better than this one were promoted, because obviously, although we know that maternal age is a risk factor, we also know that the majority of children with Down syndrome will be born to young women, very simply because young women are getting more children than the older ones. So after maternal age, the main turning point has been the nuchal translucency, and we know that it's very important that we perform a correct measurement like this one, and this is a little video clip that shows you what should be the right movements that we have to make in order to get to the right image. This is a very good method, but if used correctly. And we also know that according to the type of trisomy, there will be differences in the appearance of the nuchal translucency, very large in Turner syndrome, and sometimes very subtle in trisomy 13. We also know that if you don't use the correct mid-sagittal view, you may incur in mistakes in a deviation of 15 degrees over 25 degrees may really mean a underestimation of the true NT, and therefore bring to a test which is not accurate as you would wish. These are two different operators, and you can see the effect of a slight deviation with respect to the mid-sagittal section that should always be used. If used correctly, the nuchal translucency alone has got a detection rate of about 75%, due to the fact that not all Down syndrome babies or fetuses in this case have an increased nuchal translucency, or this may change. Maybe it was increased the week before and then it normalized, and therefore the method cannot pick up all fetuses with Down syndrome. The addition of the two serum markers has been very important. We know that the serum markers 3-beta-ICG and PAP-A have an added value. 3-beta-ICG is slightly higher in Down syndrome pregnancies, but the discrimination is not that good, whereas with PAP-A, which is lower in fetuses with Down syndrome, the discrimination is much better. And then you take some blood from the mother, and you measure the nuchal translucency, and a computer program knowing the CRL and other risk factors of the pregnancy will calculate a risk for you. And so we did this with the combined test. Usually we draw in blood earlier at about 10, 11 weeks, and measuring the nuchal translucency at about 12 weeks. And well, this test gives a very good detection rate, about 92% when the serum screening is done earlier. And then we also saw in the literature that new markers were proposed to make the detection rate even better. And these markers are the nasal bone, which is absent in 70% of fetuses with Down syndrome, tricuspid regurgitation, that is evident in about 60% of fetuses with Down syndrome, and then ductus venosus, which is changed to the normal waveform. It tends to be changed in fetuses with Down syndrome. What we can do by using these markers is that we lower our cutoff for the false positive rate to 2.5% and still maintain a high detection rate of about 90%. So less women will have to undergo an invasive procedure. We see here an overview of the performance of the markers in these papers by Oliver Kagan, and we see that hypoplastic nasal bone about 63% for trisomy 21, tricuspid regurgitation 56%, and reverse ductus venosus flow about 66%. The way we can use these markers is that we do the combined test. If the risk is very high, we will do an invasive procedure. If it's very low, we will not do anything at all. And the intermediate risk, we may send these women to a clinic where there is enough experience with these markers that I must say are sometimes quite challenging to measure correctly. These detection rates have been validated by this large study from the Fetal Medicine Foundation with the conclusion that the first trimester combined test can detect 90% of Down syndrome, 97% of trisomy 18, 92% of trisomy 13, and more than 95% of all cases of Turner syndrome and triploidies, and more than 50% of other chromosomal anomalies at a false positive rate of 4%. And this is not only true in the hands of the Fetal Medicine Foundation, but also, for instance, in the place where I worked in Amsterdam, at the Free University of Amsterdam, the same detection rates, very high, were achieved. This was the age where the serum screening was done, the nuchal was measured at about 12 weeks, and these were the respective detection rate. So as you can see, extremely high. And this is also supported by the Cochrane Library, which says that ultrasound markers with serum screening should be the standard of care for the detection of Down syndrome nowadays. Another advantage of the nuchal translucency is that while looking at the increased nuchal translucency, and even if the karyotype is normal, you know that you will detect a subgroup of fetuses at a high risk of other complications. About 20% of these fetuses will have other complications, and this is a table, and you can see from the table, according to the different degrees of nuchal translucency enlargement, which is the chance that you will find structural or genetic anomalies in about 12%, but obviously this changes dramatically according to the initial degree of enlargement. Altogether, 20% will have an adverse outcome, and fortunately 80% not. And if at 20 weeks you don't see any structural anomalies, the NT has resolved, and you see that the fetus is for the rest normal, the heart, and there are no stigmata of genetic syndrome, then you can reassure parents and tell them that in spite of the association of an increased nuchal translucency with a lot of conditions, she may be confident that her fetus will be normal. So the first trimester combined test is very good performs very good in good hands, experienced hands, is cheap and readily available, is more than a screening for trisomies only. We look at the fetus, and therefore we also assess the anatomy, and we pick up major structural defects, and it could also be a platform to screen for other conditions, such as, for instance, preeclampsia, morbidly adherent placenta, and also possibly preterm labor. Well, and still we were not happy enough, and we wanted to go further, because obviously the dream of all practitioners is to have a test which, with a very good detection rate and a very, very low false positive rate, which determines how many women will have to undergo an invasive procedure. And this complies with the Hippocratic oaths and with the principle primum non nocere. And we know that invasive procedures bring a risk of iatrogenic abortion, although recent data have indicated that this risk may be really extremely low and negligible for amniocentesis 0.12% and for CVS 0.11% if the invasive procedure is done by experienced operators, which is becoming a challenge nowadays. So the search for the perfect method led us to this cell-free fetal DNA and IPT. This search started a long time ago. In 1997, there was the first publication by Danny Law. In actual fact, a Russian scientist had already described this 2 years earlier. And this is what it is. We take blood from the mother, and in the blood of the mother there are fragments of DNA of her own chromosomes and also of the fetal chromosomes. We make staples, and obviously if there is the fetus has got a trisomy, one of the staples will be higher, and that's the way we can detect the chromosomal anomaly in the fetus. There have been a lot of validation studies in high-risk pregnancies, and they all indicate a very good performance. But if you really look carefully, what happens is that the data that are published, they indicate extremely good performance, 100% and, or almost 100%, but they don't take into account the fact that some of the cases didn't bring to a result. That we had some failure of a result. And sometimes in this failure of a result, we have some trisomies that will then actually lower what is the real detection rate of the test. In this case, for instance, 93% instead of 100% if we take also into account the failure of the result. Anyway, we know that the detection rate is very, very high, 99.7% for trisomy 21, 97.9% for 18, and also for trisomy 13 it seems to be very high, although we are still a bit doubting about this data. Large data sets are still missing. But what is very important is indeed the false positive rate is extremely low. So this test allows us to identify fetal DNA in the maternal blood. We know that the fraction increases with gestational age, and we have different methods to analyze these fragments of DNA and determine therefore the chromosome quantity. And it's important to have an ultrasound prior to the blood draw to know exactly the gestational age. So this is an ideal test for older women, for women who have abnormal first trimester screening or that have markers of aneuploidy, for women who have an NT of less than 3.5 millimeters, because if it's more, this test is not sufficient. We want a far better test, like for instance RSCGH, and also for women with structural anomalies, we shouldn't do this test, and also for women with a previous pregnancy or a child with aneuploidy, this is an ideal test. So when the test gives a high risk, we have to counsel these women properly. We have always to confirm the result by a diagnostic test, and we have to use in counseling the positive predictive value. I will tell you later why. And we should never perform irrevocable obstetrical decision, like for instance terminating a pregnancy only on the basis of an IPT result. So the major benefit is that fewer women will need a diagnostic test. We will have an early result. There is no miscarriage risk. We will detect the most common chromosomal aneuploidies, especially 21, 18, and 13. And there is a very high detection rate and a low false positive rate than by using the first trimester screening, and the positive predictive value of the test is also extremely high. However, there are some limitations. The test cannot detect other chromosomal anomalies than the 3 trisomies, although this is also changing. I will discuss this later. It cannot give you 100% reassurance that the fetus is normal, that there are no aneuploidies, cannot detect single gene disorders, and cannot detect congenital anomalies. We need an ultrasound for that. And there is also a 2 to 6% chance that the test will give a no call, a so-called no result. If we repeat the test in about 2/3 of the cases, we will get a result. And also that we must be aware that there are some false positives and false negatives. And although now there is evidence that it can also work well in dichorionic twins, this is still quite recent. False positives are due to the fact that in case of a low fetal fraction, which is considered below 4, some fetuses are erroneously detected as having Down syndrome, whereas they haven't. Regarding the test failure, we know that this is especially encountered in fetuses with trisomy 18, 8% of all the cases of test failure, and in 6.2% there was a trisomy 13. It doesn't seem that much the case for trisomy 21 or in a much lower percentage, but in the other case, yes. So if you have persistently failed NIPT, you may consider doing an invasive procedure unless you don't see absolutely any anomalies and the woman is happy that way. There are some factors affecting the performance of the test, and these are the fetal fraction, the depth of sequencing, bioinformatica mistakes relative to the kind of test that is used to do the calculation, and then biological factors, like, for instance, vanishing twins. The mother has got herself a mosaic of confined placental mosaicism. We know that in about 5% of the cases, there is a low fetal fraction. We will get here no results. And in 30% of the cases, there is a low but still acceptable fetal fraction. And these may be the cases where we may have some false positive. There are also some false negatives, and these are also due to the low fetal fraction, whereby some fetuses with Down syndrome will not be recognized by the test. Low fetal fraction is also encountered very often in women with a larger BMI. You can see that the percentage of no result increases dramatically with increasing maternal weight. So maybe if the woman has got a high BMI, it may be better not to offer a cell-free fetal DNA. And the confined placental mosaicism is also responsible for false positive cases, because the mosaicism may be only confined to the placenta, whereas the fetus is normal, and that may give us a false positive result. What we are investigating in the placenta, which releases from apoptotic cells fragments of fetal DNA, is in actual fact, and this is what NIPT is investigating, is far away from what we are investigating with the CVS or with the amniocentesis or with the fetal biopsy. It's really the very superficial layer, and that's why there could be some abnormal cells that are not present in the fetus. According to the depth of sequencing, you may get a better discrimination between normal and affected fetuses, but the more sequencing you use and the more time and expensive test you will have to have. So, and now a couple of words about the positive predictive value. There are some tools on the internet to help you in explaining what is the positive predictive value. So in this case for trisomy 21. And we see that this is a woman me see, of 40 years, she has got a positive test, and the probability of a false positive result in her case is only 7%. So she has got 93% chances that this result is accurate. Whereas if we have a woman who is 30 years old and has got a positive NIPT, the chance that this is a false positive result is almost 40%, so which means that the positive predictive value will be 60%. So we should explain and convey this message to the women to motivate them to undergo an invasive procedure. So what has happened after the wild introduction of NIPT? That women, it's very difficult to inform correctly women. It's difficult for them to understand, but also for us to give the right message. And there has been a very heavy marketing from the industries, and some health professionals have jumped into this test too quickly. And sometimes they do an IPT without, after an early scan at 10 weeks, and without looking at the fetus properly at 12, 13 weeks, which means that major anomalies can be missed and only discovered at 20 weeks. There has been a dramatic drop in invasive procedure, which means also a dramatic drop in the experience of practitioners with the invasive procedures. So it's really an advice that I give you to concentrate the invasive procedure in a few centers so that they will at least maintain experience. And also some rare chromosomal anomalies that are detectable by microarrays only or by WES will not be detected by this test. And to be very honest, although the majority of fetuses will be normal and only 5% may have an anomaly, if we look at the distribution of these anomalies, they are mainly structural defects, copy number variants 20%, which are the rare chromosomal aberration, genetic aberration, which are detected by microarrays. And if we look at the real coverage of an IPT, this is not more than about 11% of all problems that a fetus may have. And women sometimes think that if they did an IPT, they have sorted out all their problems. How should this test be implemented? As a first or second tier screening, which cutoff of the first trimester screening in the case of a second tier should be used? Should we also use microdeletion screening? Should we use the genome-wide approach? So we could start with NIPT offered to everyone at 10 weeks and then do a scan later, or we could start with a scan with a combined test and then give the NIPT as a second tier option in the intermediate group. Again, the same principle. If the risk is very high, do directly an invasive procedure. If it's very low, don't do anything. An intermediate group, you could offer an IPT. Or we could use the first trimester ultrasound as a triage. And if we see that there is an increased leukotranslucency of a major structural defect like holoprosencephaly, of omphalocele, of a megacystis, then don't do an IPT in those cases. But what it boils down to, it's all a matter of money, of how money your health system has, how much money your patient has. And yes, so it's also very important to be aware of the fact that there are some cost implications according to the strategy you use. And this is again from a very interesting paper of Kagan. If you use an IPT as a first tier, which means you start with an IPT, the cost will be much higher than if you do it as a second tier. And therefore, we should take that into account. Also, our policymakers should take that into account. What's happening in the world? So, in the majority of countries, it's offered as a second tier. We start with the combined test, and then there is a selection of women with a risk of more than one in 100, in 1 in 500, or in 1 in 2,000. I mean, it really depends on how rich is the health system. And you can see here the different countries and their cutoff chosen. Other regions haven't got a national policy. And then there are two exceptions, the Netherlands and Belgium, where NIPT is offered as first-tier screening, genome-wide, to all the population, with the difference that in Belgium, the cost is much lower, 8 euros, as opposed to the 175 euros that Dutch women have to pay for. So now we will discuss expansion of the NIPT. So do we want to include also microdeletions? Well, obviously, in the press, there has been this, let's say, announcement that this magic test can detect a genetic disease early in pregnancy. We know that these microdeletion syndromes are all rather rare, apart from 22q11, the D. George, which is one in 2,000, one in 4,000. And they are serious problems. But the question is the technology good enough to exclude or to detect these anomalies? Well, the arguments for is that these conditions are severe, the incidence is independent from the maternal age, and the cumulatively prevalence of these disorders is about 1 in 1,000 if we take the 5 more common one. And less women are expected to have invasive procedures, and we offer microarrays. So these conditions should be added to NIPT. But we know also that microdeletion are by definition less than 5 megabytes, and that the current NIPT versions has got let's say, a filter of about 7 megabytes. So which means that 77% would not be detected by the usually applied targeted approach. The arguments against NIPT for microdeletion is that it's still a little bit too premature, there are no guidelines, there are no sufficient published clinical validation study, false positive results are inevitable, and also to get an informed consent to explain all these conditions to the family is quite of a problem. And if we are dealing with a family with a high risk of a nested deletion within the region 22q, NIPT will not be able to detect this one. So what happens when more items are added to the menu? Well, that's the positive predictive value goes dramatically down. It was very high for trisomy 21, a little bit lower for 18, a little bit lower for 13, but you see that down the line, it gets really extremely low. So what happens is that the more we add chromosomal sex chromosome anomalies and microdeletion panels, and the less the advantage of the test becomes. The advantage of the test, which was a high detection rate, a high positive predictive value, and it's also very, very complex to counsel women for this. So this is again the same concept. The sensitivity goes down from 99% to 60%, and the false positive rate goes up from 0.14% to more than 1.5%. What about genome-wide? So I'm from the Netherlands, so I work in the Netherlands, and I can tell you what happens there. This study, the Trident study, has been published 2 years ago, and on a large set of patients, 80,000 patients, we were able to give results. Regarding the 3 trisomies, very high detection rate, very high positive predictive value. But if we look at the other condition that we can detect, the so-called rare autosomal trisomy and the structural anomalies, we see that the positive predictive value is very low, and that these rats are mainly due to a confined placental mosaicism. Women will be told that they have a problem, but the problem is not confirmed. And a very important point is that 35% of all the invasive procedures were done because of these additional findings. So we lose a little bit the meaning of the NIPT, which is to lower the number of invasive procedures. And we are artificially increasing it by adding these other conditions that we know very often, if they are there, they will lead to intrauterine deaths, so they will not be real problems. We see here that the majority of the rare autosomal trisomies were not confirmed in the fetus, blue, and only a few were confirmed, trisomy 9, and then trisomy 16, trisomy 15, just a minute minority. The most frequent one was trisomy 7, never found in the fetus. It was purely a confined placental mosaicism. And regarding the structural anomalies, the positive predictive value was 32%. You can see that also here in the majority of the cases, they were for false positive cases not found in the fetus. And then there are the so-called abnormal profiles indicative of cancer. And as you can see also here, only in 11 cases they were found, and in 4 cases there were myomas. You don't want to tell a woman that she has got a malignancy only because she has got a myoma. And in other cases, the anomalies were found, but there was a lot of uncertainty. I mean, the number of women who were really helped out of 80,000 was maybe 1 or 2, and not more than that. Last but not least, all the women with these positive results for additional findings experience a degree of stress, anxiety, and this was, in actual fact, a patient of mine. The woman was the wife of a journalist, and they described in this paper their roller coaster in counseling and diagnosis about this additional finding that in the end was not found in the fetus. So what this says, this heading, is that this deep test can produce weeks-long anxiety and stress in the parents. So I get to the conclusion of my talk, and this is that cell-free fetal DNA is a test with far better sensitivity and positive predictive value than the combined test, and it performs extremely well, especially for trisomy 21. However, women must be informed that other fetal anomalies are much more frequent in pregnancy. And the first trimester ultrasound investigation has to remain, and it's really essential to detect these other more prevalent conditions. At present, it may still be too early to adopt an IPT as a first-year test and abandon the combined test, unless, obviously, we have a lot of money to spend. And if structural anomalies are present, or the risk of the first semester screening is more than 1 in 100, consider offering a raised CGH, because also in that case we may have, due to the low PAPA, some rare genetic aberration. An IPT for microdeletion is still premature, as the test characteristics are not yet optimal, and more studies are recommended before broad implementation of a genome-wide approach is introduced. And I thank you very much for your attention. Shukriya.
Thank you, Professor Bilardo. Can you introduce for us Dr. Eric? Introduce Professor Eric.
Yes.
Next speaker, please.
The only problem is that I haven't got so I will do it. Well, it is my great pleasure to introduce the next speaker, a very good friend of myself and of ISUOG. Nikos Braknis is a professor in obstetrics and gynecology and fetal maternal medicine at the University of Athens Medical School, Areta Yeo. He also serves as chair of the Gynecology, Obstetrics and Perinatal Medicine unit at University Hospital in Athens, and as honorary consultant at St. George's University Hospital in London. And he has been very active within ESWOG, and I really hope that we will be able to do a lot of other works together. And Nikos, the floor is yours. I remove my computer.
Hello. It's my great honor to be back in Cairo and Egypt, place which is very dear to my heart. Thank you very much for the invitation. I'm Nick Vraknis, working in Athens and London. I've been involved with ISUOG, and I can see, and all of us, we are very happy from ISUOG to be present today in this very important international event. And I would like to congratulate Professor Mohammed Kamal and his team for organizing this really exemplary meeting. Fetal neuroanatomy is very important to our day-to-day practice. It is true that most babies that we scan are normal, but for the small number of cases that we'll find a central nervous system anatomy anomaly, then we have to know how to navigate. How to navigate in the fetal brain using also different planes from the standard planes. So how complex is our brain? The answer is that there are millions of neurons and synaptic connections, and brain abnormalities are associated with severe disability. When we say a baby is born preterm, that we listened earlier, our mind really goes to the cerebral palsy and all issues related with brain. How far this baby brain develops later in life? Well, the brain develops until we reach the age of 25. So you understand how important are events during the pregnancy and how important are for the parents to make this diagnosis. 2D views are very, very useful. Our day-to-day practice, 3D views are useful provided that you have the patient and you get the right volume of information in order to work. Because if the quality of the volume is not adequate, then obviously you will not be able to showcase what you are looking for. The 3 views, transverse or axial, coronal and sagittal, very important, even if we are not used to use transvaginal approach in fetal brain anomalies. If we do our standard second trimester scanning, and there are some issues there, if the baby is cephalic, then using our high frequency probe is really the best option to clarify what we see. And of course, skilled maneuvering is required. But what it is, skilled maneuvering? Skilled maneuvering comes with practice. You cannot you cannot become an expert in parasagittal safe use when you don't practice it in your daytime, when you have some time, a gap in between your scanning, then you can do the parasagittal on a normal baby and get used to that, or do a vaginal scanning on a normal brain, and then you will step by step start navigating. Because if you don't sail with normal cases, it's very difficult when you get the fetal brain anomaly to decide and go for it before obviously ask for an expert opinion, as should be done as a routine if we are in question what we are seeing today. So brain has similar echogenicity between different regions, and the MRI is valuable for the second half of pregnancy. And we should keep in mind that structural aberrations are detected at a lower percentage in comparison with other systems, where the detection is higher. So the question is, we see a structure, but we keep in mind that we cannot see their function. That's why when the fetal medicine specialist or the fetal neurosonologist or the pediatrician or other people that are called in the room to counsel the patient, usually our consultation is that there is a percentage of this and there is a percentage for that, but because the brain is what we see is the anatomy and not the function, we are cautious. We are cautious with our counseling. So there are easy cases, as you can see, and challenging cases, like the ventriculomegaly, the corpus callosum, agenesis, and dysplasias, mild forms of Dandy-Walker. And there are different types of abnormalities. Organs, parts of the brain not constructed, or dysplasias, organs, parts of the brain start developing, but for a reason this stop leading to dysplasias. We have only one mid-sagittal plane in our day-to-day practice, and that is on the first trimester scan, because the second trimester brain scan is all about transventricular planes, is about axial planes and not mid-sagittal planes. So these are basics. Provided that you do these planes on both trimesters, according to ISUOG, and you have normal findings, you can proceed to the next organ that the baby, depending on the position and the maternal habitus, you can go. We start by looking and commenting on the fetal brain in different trimesters. This is the transventricular section. The cranial shape is oval. The proper ossification, you can see here on the dotted arrow on the top that there is a suture between the bones on the very top first picture. The fox is in the middle, and there are some prominent hyperechoic chorioid plexuses. This is the butterfly sign. And if they are asymmetric, there are no worries at all. Obviously, you've got the right plane. But again, if they are asymmetric, these will be assessed later and there is no reason to upset the patient. So you see the butterfly sign. My question is, can I have a pointer or a mouse here so I can use the index of the computer? Thanks. So on the very low, I'm trying to get my pointer, but it is... but I have a small difficulty. On the very low of the picture here, on this point, here and here, you can see this dark area. This dark area, as you can see, the chorioids are filling on the first trimester scan the cranium. So this area is the fetal cortex. This area there is where all the fetal cortex will develop with the next months. So this is how we come and understand why events in the very first trimester of pregnancy, fetal cortex is this black line just below the butterfly sign, in between the butterfly sign and the bone of the skull. So it's very, very important to understand what we see. Moves slowly, that's my... Okay, So now, mid-sagittal section on the first trimester, we can see the nasal bone, maxilla, and mandible, and there are three hypoechoic bands separated by two echogenic lines. Here are the three lines. So the fourth ventricle is in between my dot, and is the one that we use to assess if there are any spina bifida or other issues. Below that is the cisterna magna here, just above the bone. This is bone, the whitish area. And here is the fourth vessel. So intracranial translucency, we keep in mind that it is the fourth vessel. And here is the brain stem. Right. The first trimester pathology that we can see is holoprosencephaly, and then we see an encephalocele, pictures 2 and 3, and then spina bifida below on picture 4, and then a crania, and finally an encephaly with presence of hydramnios. Second trimester, we move to second trimester. These are the standard sections, as shown also in ISUOG, and you can see what different pathologies we can exclude here. On plane 4, which is the transventricular, is an encephaly, encephalocele, a lobar holoprosencephaly, and ventriculomegaly. And plane 6, posterior fossa cysts, megacisterna magna, cystic hygroma, and scalp edema. We move to this transventricular axial section. You can see the medial wall on the posterior horn. On the lateral ventricle, the lateral wall of the posterior horn, you can see the chorioid plexus, the cavum septum pellucidum, the interhemispheric fissure, and the lateral fissure. Now here is an unusually clear picture because the near hemisphere, the top hemisphere, is usually masked by reverberation echoes. So if you are new to scanning and you know, you have experience and you cannot see the top part of your brain, no worries at all. This is a normal effect. Perhaps moving around the head from other views, you can overpass this difficulty if the baby is not moving, but it's normal. Reverberation is normal, and we usually see the lower half of the brain. The transventricular axial section, we can see the cranial shape, deficits, echogenicity, and distorting abnormalities. Now, the cavum septum pellucidum is another part of the human brain that it is visible between 18 and 37 weeks. Obviously, in a limited number of cases, it is visible after 37 weeks, but sometimes people come and ask that they cannot see the cavum septum pellucidum at 39 or 41 weeks. This is normal. If the cavum septum pellucidum is not there, then we have to look for the corpus callosum agenesis or other issues like holoprosencephaly or endocephalus. The posterior horn of lateral ventricle, the normal rule is that it should not exceed the 10 millimeter. Now, on these lateral ventricles, we see different pathologies. On the first one, we see ventriculomegaly, the teardrop ventricles in agenesis of corpus callosum, and the chorioid plexus cysts. The transthalamic axial section, we move now. This is used to measure the fetal biometry, BPD, OFD, and the normal index of BPD divided by OFD should be 0.7 to 0.87. Otherwise, we should evaluate the head for brachycephaly and dolichocephaly. Holoprosencephaly. It's very important that the brain develops, as explained earlier, not only the cortex, but also other parts, and the ventral intaction is important. If there is a failure of division, a failure of cleavage, as you can see here, and a failure of rotation, then the holoprosencephaly, as shown on the second picture, the top one is normal. The holoprosencephaly develops with the destructive results on the baby's brain. And you can see the different parts of holoprosencephaly on the bottom of the picture. Other issues with corpus callosum is the septo-optic dysplasia. We can see on the colored picture on the top the pathways of neurons on the brain. These are on the these are neurons on the cavum septum pellucidum on the that pass below the cavum septum pellucidum. If these neurons are affected, septo-optic dysplasia may arise, on the septo-optic dysplasia, like most cases where there is an agenesis of corpus callosum, we will not be able to see the cavum septum pellucidum. However, you keep in mind, you may not see the cavum septum pellucidum, but the corpus callosum is there. However, if the corpus callosum is not there, you cannot see the cavum septum pellucidum. These are basic principles of neurosonography when you get to this point. Here we have agenesis of the corpus callosum. This is evaluated after 20 weeks. There may be complete or partial agenesis with a similar prognosis. So here we have a complete agenesis of the corpus callosum. I think I will come a bit closer. So we have a complete agenesis. You see there a very thick on the bottom down, a very thick dysplastic corpus callosum. So the corpus callosum looks fine, but we should look for any sulcation on the corpus callosum, a very hyperechoic corpus callosum as usual, a very thick one, and we don't check only for the thin corpus callosum. We also check for the thick corpus callosum because this means dysplastic neural tissue. And we have to take it in mind when we proceed to consultation. And there are charts, so a hypoplastic corpus callosum can be measured. You can see on that picture in the middle on your right-hand side the thick corpus callosum and the pericallosal artery, how nicely delineates the presence of corpus callosum, but we see here part of the artery is missing. We'll see that also later. The transcerebral axial section, we'll see the cerebellum, the hemisphere, and vermis, and it is, as you'll see later, very important to study the vermis. Is vermis made up from two different parts? We should be able to see these parts because this means normal development of the vermis. If one part is not there or both parts are symmetric, because not both parts have the same length, then something is running with the vermis. So we don't look only for Daddy Walker say syndromes, but we also assess the vermis properly, that both parts of the vermis are there. We'll see later. And the cisterna magna should be there, and the normal range is 2 to 10 millimeter based on ISUOG guidelines, and the nuchal fold should not exceed 6 millimeters. The cisterna magna, we see here cases of isolated increased cisterna magna. The prognosis is good on this occasion. We see cases of decreased cisterna magna with the banana-shaped cerebellum, the banana sign, known to all of us. And we move to other issues like cranial shape and deficits. We see our known lemon sign and spina bifida on the top picture. Lemon sign denotes spina bifida. Lemon sign is the shape of the skull. And we see there encephalocele that may be able to diagnose already from the first trimester. But apart from deficits, as we see here, and cranial shape issues, there are also normal cranium, but there are echogenicity or other distorting anomalies issues. So on the top picture, you see osteogenesis imperfecta. In the middle, on the lower pictures, you can see the porencephaly, the large anechoic cyst, and from a brain MRI, you can see schizencephaly, how these whitish areas distort. There is an abnormal construction of the brain. We move to the second part of this presentation, which is other planes. The planes that, as I said earlier, we should try and practice in our day-to-day practice when we have some free time. So, any abnormal finding in the three axial sections is an indication for a detailed fetal neurosonogram, including coronal and sagittal sections. Now, there are 4 different coronal planes and 2 different sagittal planes that we can do. The sagittal is the mid-sagittal and the parasagittal. So the vertex approach through the anterior fontanelle yields the best coronal and sagittal images. We are scanning. We cannot see anything on that brain, and we have moved already to coronal planes. What we do next? Next, when we have this head and we have the plane and we cannot see, we cannot get our views, is slightly to move 1 millimeter and another millimeter and another millimeter. And suddenly, this view will come up. Why? Because our picture now comes from a suture. If you hit the bone, your picture is not clear. So when you go for these parasagittal, say the sagittal planes or the coronal planes, and you cannot get it, don't get disappointed. Just move a few millimeters there to meet a suture, and then this picture will come clear to you. And with other adjustments, you will be able to have the result that you require. And again, 3D volume, if you don't get your 3D volume from the appropriate suture, maybe the quality of the volume is not as you expect later when you try to get these things. So we start with the coronal sections. Here is a coronal section. You can see the intrahemispheric fissure in the middle is uninterrupted, as this section is anterior to the cavum septum pellucidum. The intrahemispheric fissure in the axial or transverse sections is interrupted by the cavum septum pellucidum. But now we are on coronal sections, and we are very front on the fetal head. You can see here the thick line that we are moving. You will use these lines to orientate yourself in which section we are. And this is how the intrahemispheric feature is fissure is present throughout. Symmetric anterior horns, we see the small arrows there, and on the bottom where we see the letter O are the orbits, and on the top is the bone, the orbital roof. So this is our first plane, the coronal transfrontal section. The next plane, you see the arrow navigating on the draft above the scan picture, is the anterior horns. You see the arrows showing the anterior horns, and the star showing the cavum septum pellucidum. So the cystic space immediately to the corpus callosum, which means the corpus callosum cannot manage to move this dot. So the corpus callosum is just above this star and the hypoechoic area. The corpus callosum is sitting there. We can check the corpus callosum on a transverse view for the corpus callosum. And the caudate nucleus, both caudates nucleus are there represented by letter C. So that's why we call this transcaudate section, to make a distinguish from the transthalamic section, which comes next and that we are about to see now. So this is the transthalamic section, which is next section as we move to the fetal head. So this is interrupted again by the body of the corpus callosum. We see the dotted arrow on the body of the corpus callosum, and the CSP just below that. And above that is the intrahemispheric fissure. Interior horns of the lateral ventrix, and the thalami represented by the letter T. So this is our transthalamic section, and we move to our final section, which is the transcerebellar section, but this time is coronal. It's our own all-eyes view, which again we have the uninterrupted interhemispheric fissure, the posterior horns of the lateral ventricles shown by the arrows, and then the calcarine sulcus. The calcarine sulcus is a fissure in the middle of the brain inside. I'm sorry, this video is not working. Is at this point of the brain. There it looks it works. Okay, so the calcarine suture is this red line next to my dot. You will see now. The calcarine suture is there, here. And this is the most, is where I show it with my long arrow. And this is how, together with the cerebellar hemisphere, the picture of the brain gets this all-eyes view, and you can see also the MRI there. So it's the calcarine fissure that makes the nose of the owl and helps to that. So this is a video. Let's see if we are lucky, that shows all the coronal views. I guess the videos they play, but it may take a bit longer to start. I will not spend your time. Okay, and we move to the mid-sagittal sections and the parasagittal sections, but not to see the fetal profile, but as a means to see the corpus callosum and the vermis. So we should see the entire corpus callosum and the length of the corpus callosum. As a hypoechoic band, we see the corpus callosum there on the arrow. After 20 weeks, the splenium of the corpus callosum is fully developed and extends posteriorly. You see here where the star is that the CSP is a bit larger and longer than expected. And this is because it is cavum verga, means that the cavum septum pellucidum is a bit longer than usual, and this is called in anatomy cavum vergam, or if it is even longer, is cavum veli interpositi. You can meet sometimes larger size cavum septi pellucidi if it is an isolated finding, and of course this needs full fetal neurosonography, but if it is an isolated finding, the prognosis is good. And we move now to the vermis. On the bottom picture is with the letter V. The vermis is seen posteriorly and should really look like a hyperechoic kidney. The vermis also is represented with the letter B on the top picture. And in front of vermis is the brain stem, and above that is the thalami, and above that is the star with the cavum septum pellucidum, and above that is the corpus callosum. So the vermis, let's try to focus on the vermis. The vermis on the mid-sagittal section is seen having an indentation on the dorsal contour, dividing the vermis into an upper third and a lower two-third. If, say, the upper is two-third, this denotes an abnormal vermis. Should be smaller and larger when you check it with your eyes. And obviously for this, for cavum septum pellucidum, for corpus callosum, there are measurements and charts. The vermian length and anteroposterior dimension are the parameters used to confirm normality of size using normograms. So it's very, very important to make sure that we have the right shape vermis. And again, on the mid-sagittal section, I would like to focus to the vein of Gallen is the single arrow in this picture. The vein of Gallen is the single arrow, and the double arrow is the straight sinus. Both are normal, however, later, and we should always check the corpus callosum with the Doppler because and the pericallosal artery because there may be other anatomy that may miss if we do not switch on our Doppler power button or color Doppler. We move to parasagittal sections, see the baby's head. We don't move our probe, we just tilt and tilt, provided that we have the sagittal, mid-sagittal section. Then we have moved to the parasagittal sections, and we can see the ventricular margins and the cortical surface. Why we need the parasagittal section? Because it's the only section that we see all the ventricle on each side. The full size of the ventricle is the only section that visualizes the ventricle. So the ventricular margins, you can see here, the front and the bottom, the posterior part. Here is the posterior part of the lateral ventricles. So we need also we check the cerebral parenchyma and the cortical surface, and these are best seen in the parasagittal sessions. Video here. Okay, so the body of the lateral ventricle, the cavum septum pellucidum as we scan, the choroid plexus, and again on a mid-sagittal view we moved now, we see the corpus callosum very nicely demonstrated in the cavum septum pellucidum. The pericallosal artery, very nicely demonstrated. On the very back, the vein of Gallen now. Great. And we move to the third and shorter part of this presentation and final part, which is on the fetal neurosono anatomy, which is sulcation and gyration. The fetal brain surface is very smooth before 16 weeks, and before 12 weeks, as we discussed earlier, it's very difficult to see the details on the brain, even if we do transvaginal scanning. From 16 to 20 weeks, the gyration and the surface of the brain becomes more extended, so they appear. The ultrasound sections in which a sulcus is seen depends on the orientation of the sulcus and on the cerebral surface, so we do the combination of 4 movements that we do when we scan abdominally. These sections are perpendicular to the anatomical plane. MRI is informative. I will focus to the parieto-occipital sulcus, which is the most common that we use to date the pregnancy, in case that we have other issues, or in case that there was a fetal infection going on and we would like to know how the brain develops. Of course, we can use other different sulcuses as well. So this is the evolution of parieto-occipital sulcus in the axial transventricular section. You see the weeks, and it is very smooth at 18-21 weeks. At 27 weeks, here it is very smooth at 24 weeks. It's like a V shape. Very shallow indentation here at 21 weeks, does not exist at 18 to 20 weeks earlier. So it's a V, but then you see that it deepens, it becomes very narrow, and then it becomes a line at 30 weeks. So this is the T shape. The part of the T is here on the top, and the sulcus is here. So as the pregnancy progresses, this sulcus narrows and gets deeper. So this shows us a good brain development for the gestational age studied. And again here I have various axial sections starting on the top from 20 weeks, 23 weeks, 26 weeks. These are the 3 lines, and you can see the dots that is not almost there. Then from 23 weeks on the bottom, we move to 26 and 30 weeks finally, where you can see this narrow area there, which means that this is excellent development. Vein of Gallen. Just a very short story to tell you about the vein of Gallen. When I was scanning in my early years with my consultant, we thought it was a brain cyst. Why? In the first scanning? Because we didn't put on the color Doppler. So each time that you see a cyst on the brain, you have definitely to switch on the color Doppler button. So, prognosis. This presentation is not about prognosis, it is about sonoanatomy. However, we can very briefly visit the prognosis of anencephaly, schizencephaly, and porencephaly. They have bad prognosis together with encephalocele and holoprosencephaly only in severe types. Ventriculomegaly can have good prognosis. the prognosis will be definitely guarded until a few months, and to be specific, for subtle changes in behavior until the 5th or further year of age. By the pediatricians will be this prognosis. Corpus callosum agenesis in most cases has good prognosis. The agenesis, so you can imagine that dysplastic corpus callosus have even better prognosis, but we should be guarded when we give our prognosis because we don't know if that is the 30% or the 70%. We don't have clear-cut criteria. Daddy Walker depends on the severity. The prognosis, megasterna magna isolated, a good prognosis. Spina bifida, chorioid plexus cyst isolated, good prognosis and disappears later. Vein of Gallen, there is a risk of hydrop, and this is how it is, bad prognosis. 2 ISO guidelines, if you got any time to spend within the next few days to go through the detailed sonographic examination of the fetal central nervous system. This is what this presentation was. Major abnormalities can be seen since the first trimester. At the second trimester, we use the standard views, and then we proceed to detailed fetal neurosonogram. MRI after 26-28 weeks, ideally 32 weeks, should be used to study these cases. ISO guidelines, very important to define our practice of screening and targeted neurosonography. So the most important task when we scan is based on our 3 planes and 2 planes respectively on the first trimester to reassure the woman based also on our total full views of the baby that this is a normal pregnancy, and subsequently we expect in most cases a normally developing brain. ISOG has like 15,000 members and expands in 140 countries. However, this meeting organized by the Egyptian Fetal Medicine Foundation is most important, not for Africa, but for other continents like Asia and Europe and beyond. It is really, I'm very impressed by the bulk of the meeting, and again, I will finish my talk as I started earlier. You are very dear to my heart. Thank you.
Thank you, Professor Nikos. We don't have much time for discussion. Already Dr. Badreddin have left. So we'll allow for 1 question to Professor Katia and 1 question for Professor Nikos. Any questions, any comments, please? This is 1 of 2. I'm not sure they have 1, so you can take my, it's behind.
Thank you very much. I'm Mohammed Sanosi from Sudan. I enjoyed the 3 presentations. Thank you for presenters. My question to Prof. Katia. I would like if
closer to the mic, please.
Okay. I would like to know the impact of the non-invasive prenatal testing on termination of pregnancy regarding incompatible with life, because we are clinicians, we are very much in need of an early test, an accurate test that can tell us the condition is incompatible with life. So we can counsel the parents better for termination. Thank you very much.
Sorry, can you repeat the question exactly? Because
what I'm saying.
Yes.
What?
Of the Okay. Well, I don't think that there are data yet, but I think that it all begins with a good counseling. If you tell the couple, this test can tell you very early that there is a problem, then I suppose that if the couple decides to undergo this test, is because they also consider termination. And I am aware of the fact that in certain countries, it's very important to have an early diagnosis in order to access termination. So I think that for these countries, definitely the non-invasive test has got a major advantage. But you should also make the couple aware that if the test is normal, not all the conditions that we can screen for are automatically excluded. But in that respect, I think that for this country, this test is very important indeed. I hope I have answered your question.
Now, any question for the third presentation of Professor Nicholas? For the neurosonography.
Maybe I will ask a question to Nikos. So do you think that we should all become experts in neurosonography? How do you see the organization of the scanning for these important conditions?
Thank you very much for your question, Professor Bilardo. You mean ISUOG or us or as individuals?
As individuals. I mean,
as
all the people
yes.
here in the room.
Thank you.
Should they all be capable of doing such an advanced neurosonography, or there are other ways around?
Yeah. Well, as each sonographer, each obstetrician, each fetal medicine person develops and progresses in scanning. Initially, yes, I recognize that the first years should be a struggle to address more standard views and trying to become an expert on these views. But later, I would give an advice not to stay there, try to use alternate views on the fetal brain, alternate views on the fetal heart. Try to educate yourselves. I do that continuously in my career. I use the very informative videos from ISUOG platform. You can become members because there are many live scans there in the presentations. And the next time that you have time and you go back to your practice, try to do that. Also, maybe the younger are acquainted using their mobiles. When they run into a difficulty, you can go either to ISUOG, which is a visual encyclopedia, or other encyclopedias that are available from Fetal Medicine Foundation or USA encyclopedias. And then you can check and go back and try and get the views. It is very important, all of us, to become the more expert that we can, because yes, we'll address, if there is any question in our mind, we'll send this patient, we'll refer the patient for another opinion, for another scan, even if we cannot define what this anomaly is. But if we are certain and we use the standard views, there is no reason why we should refer this patient. So, competent scanning of your views and you move to your next organ. But try to improve using the sagittal and coronal views concerning the fetal brain. All of us should do.
Yes, I think this is right, but it's always important to work in a kind of a network, because there will be people who will be very good in doing the screening, And then once you find an anomaly, I think it's very good to refer to a center for the global assessment, for the invasive procedure, which is important that is done in only few centers, and then for the management of the case. Because I think that it's very, very difficult to become an expert in neurosonography, even if you have a lot of teaching possibilities. As you know, there are only a few people in the world who are really excellent in this, and we should be aware of that.
Indeed, the case should be cancelled, as said in my presentation, not only by one people, but by more people, and obviously the expert, and also other specialties may come into this consultation depending on the finding, like baby doctors, geneticists, and other, depending on the finding. Thank you.
Now we came to the end of this session. Thank you for the presenter and thank you for attendance. And let's move to the opening ceremony. Thank you.
Assalamu alaikum wa rahmatullah. Good afternoon, all. On behalf of the Egyptian Fetal Medicine Foundation and the International Society of Ultrasound and Obstetric and Gynecology Symposium Local Organizing Committee, I feel extremely privileged and honored to be given this opportunity to welcome you all. I'd like to thank all the delegates for their commitment, whom without their participation, the event wouldn't be that great. We are so grateful to all guest speakers as well as whom shared us with their oral communications as well as the poster presentations. My sincere regards to all the sponsors for their support. And now it's my real honor to introduce Professor Katia Bilardo, the past president of the International Society of Obstetrics and Gynecology, to give us the welcome speech of ISUOG. Please, Professor Katia.
Thank you very much.
Thank you.
Just a second, we seem to have some technical problems. It doesn't really react. Well, while we are waiting, I will start telling you something about ISUOG. ISUOG was founded almost 32 years ago by Professor Campbell, who had been a pupil of Professor Ian Donald, the person who really applied the principle of ultrasound, which had been used in navigation to detect objects in the sea, to obstetrics. And the mission of ISUOG, 32 years later, is that every woman should get an expert ultrasound in pregnancy, and therefore our task is to give to every practitioner in the world education from the very basic level to the very expert one, so that by improving diagnosis in obstetrics and gynecology, eventually the outcome of women and their fetuses in the world will improve. So in the 32 years that the society is there, it has grown tremendously. We have over 15,000 members from all over the world, and we are especially hoping to improve our presence in continents like Latin America and Africa and the South Pacific area. Your country is an exception because you all speak English, and this is really good for us. So this is the vision mission. These are the number of members that, as you can see, have really grown steadily throughout the years. And we also offer a free program for trainees. All the trainees in OBGYN can get a 2 years membership for free, and they can renew then at a very, very discounted price. What we are now trying to focus in ISUOG is this concept that the membership should cost according to where you live, according to the level of your career, and if you are very young and you are a student, a trainee, or a sonographer, and you live in Africa, you should pay less, a minimum. Whereas if you live in the United States or in a very rich country and you are already practicing for 20 years, you may also pay more. We offer a lot of products, and these products are from the basic training, which is meant to teach people who don't know how to scan, how they should properly learn scanning, to a lot of courses from the very basic to the advanced level. We have a journal, which is obviously a very, very important resource with a very high impact factor of 7.3, and that also offers, besides very good quality science videos, we have an app that you can consult on your mobile, introducing you to the high-level scientific content of the journal. And you can access all the articles back to 1991, because after the first year, all the articles are free. And obviously, if you are a member, you have access to all the articles from the moment they are published. Which are the key events and educational courses in 2022? First of all, our World Congress. After 2 years of having gone virtual, we go back to a hybrid Congress, which will be held in London. But if you cannot afford to travel to London, you can also follow it from your home in a hybrid way. And then we have some international symposia. Well, this was one of them, and the other one will be in South Pacific Asia in November 19 and 20. Plus, we offer you a number of advanced courses, 8 a year, on specific items ranging from the fetal brain, the fetal heart, the first trimester, and these courses are really excellent. We had one a week ago about the second trimester scanning, and it was really excellent. The basic training, as I told you, you can also organize yourself a basic training in your region with the Run ABT model, and you can put together students and use our lectures with our guidance to give this basic training course. And we are thinking of very soon to introduce a diploma, a certification program that will allow people who have successfully followed this program to get a certification of competence. We have, besides the practical courses, also this BT Flex, which is offered by ISUOG, and again with this concept that is for free for low-income countries. So last but not least, I all invite you to come to our next World Congress in September in London from 16 to 18. And please register before the 18th of July so that you will profit of the early bird registration fee. And if you're not able to come, please register and follow us online. We are very proud of you. We really value a lot your friendship and your commitment to ISUOG. A particular thank to Professor Mohammed Kamal for having initiated this partnership with ISUOG. And we really hope to see you again and again and again, and especially that you will be successful in increasing your scanning skills for the benefit of your patients. Thank you.
Thank you very much, Professor Belardo. I would like, on behalf of the delegates, to thank you very much to come to our event, and we hope to see you in the future more and more. Thank you very much. And now to the right person, Professor Mohammed Kamal. Professor Mohammed Kamal is the president of the Egyptian Fetal Medicine Foundation and the chair of the 16th ISUOG International Symposium. Please, Professor Mohammed, give us the presentation.
Assalamu alaikum wa rahmatullah. On behalf of Egyptian Fetal Medicine Foundation, it's my great pleasure and honor to welcome you all in our lovely and historical country, Egypt. Actually, I consider today and this event as an exceptional event in Egyptian Fetal Medicine Foundation story. To start normally in 2015 as a national NGO, and within few years, exactly 4 years, we become able to host the international event like ISUOG International Symposium. It is an exceptional day in the Egyptian Fetal Medicine Foundation journey. I will show some of our activities and collaboration for 2 years. These some photos that represent our activities in different areas in Egypt and outside Egypt, like in Sudan and Libya. And we was very honored to welcome a lot of stakeholders and key speakers all over the world, like Philip Gianti, Baladini, John Hayat, and the last one in 2019 before the COVID, Josh Koppel, Alfred Abu Hamid, Fred Ushkov, George Kunduz. With Boris and Nikos. Before talking about our journey in organizing the ISUOG International Symposium, I have to mourn and console my dearest friend. To be honest, he's our dearest friend from Sudan, Dr. Hassan Hembat. Dr. Hassan was supposed to be with us now. He already registered in the conference, booked his flight tickets, but unfortunately, he passed away 10 days ago. May God have mercy on him. Honestly, the best one who can talk about Dr. Hassan is my colleague, Professor Ashmik.
Thank you very much, Professor Kamal. I want to thank Professor Kamal for the kind invitation for us to accommodate us and to host us in this important meeting. And the second thing is to congratulate him for accommodation and hosting the important meeting of ISOG. And thanks to Professor Bilardo also for being here to arrange this important meeting. And maybe this is the first meeting in Africa. And the next time we need the ASOC to invade South Africa to Sudan and other countries. The third part is Dr. Hassan Himmat. Hassan Himmat is one of the most actually open-hearted, wine-hearted, friendly to everyone. He was responsible on arranging the Yandonda school training in Sudan, and actually we lost him suddenly, as Professor Kamal mentioned 10 days ago. And the most painful part is the sudden death of Dr. Hassan while he is doing his work and offering his clinical practice and skill to his patients. He suddenly dropped in the clinic. Dr. Hassan was very friendly to everyone in Sudan. He was an open book, and he was offering his clinical skills and practice in Sudan for registrars, young specialists, and students as well. And the most important part that he's actually after a loss, this is a nature, after the death and loss, after disease may be, it can be accepted or partly actually painful, but it is severely painful if we lose one of our colleagues suddenly while he's offering his work and his skills to his patients and students. And actually, we should actually pray for him, and we should always remember him in our meetings, scientific meetings, and so on. And we hope that we meet every now and then for these associations in our actual beloved countries in Egypt and Sudan. Egypt actually is the second home of us, and Sudan is the second, maybe first home for you as Egyptians in Sudan. Thank you very much.
Now, the last point that I wanted to talk is our journey in organizing the ISUOG International Symposium. Unfortunately, this event subjected to a lot of international challenges, starting from COVID-19, Omicron, and recently Russia-Ukraine war that causes a major international and national inflations. But we were lucky to have someone in our life to support us, starting from ISUOG stakeholders, including the past president, Dr. Katia, and the present president, Tom Bourne. Passing through the ISUOG team and the Egyptian Fetal Medicine Foundation team, ending with our partners, the sponsors companies. شكرا لحضراتكم. شكرا.
Thank you, Professor Muhammad. We really thank you all, and we are so grateful for anyone who used to share us and is sharing us now in our success. So thank you. And now to the award part of the opening ceremony. We used to award some of our honorable guest speakers, and today we are going to award some of our honorable guest speakers. I will start with a great personnel who was born in Italy and have had the specialization of OBGYN at the University of Turin. She trained as a fellow in prenatal diagnosis at the fetal medicine unit at King's College Hospital, London, where she worked under supervision of Professor Stuart Campbell and Professor Kypros Nicolaides. Since 1989, she lives in Netherlands, where she has worked as a consultant and head of the prenatal diagnosis department at the Academic Medical Center, Amsterdam. In 2011, she has been appointed professor in fetal medicine. In Netherlands, she has been the president of Dutch Working Party of Ultrasound and OBGYN and is currently a member of the Committee of Prenatal Screening of the National Health Council. She has been appointed as the director of the Prenatal Screening Association Northeast Netherlands. Let us welcome Professor Katia Belardo. Thank you so much, Professor Katia. Another great personnel who was born in 1952 and had a mid-UE in OBGYN University of Khartoum, 1987, and the Fellowship of Sudan Medical Specialization Board, 1997, and the Professorship, the National Ribat University at 2000, Fellowship of Sudan Medical Specialization Board, 2008, and the Fellowship of the Royal College of Obstetrics and Gynecology at the United Kingdom, 2009, the Fellowship of the International Academy of Prenatal Medicine at Croatia, 2009, the Diploma in Policy Science and Law, National Ribat University, the ex-president of the Sudanese Medical Union, 2015, and the ex-president of the National Ribat University, 2008 till 2020, and the vice president of the National Ribat University, Khartoum, and was the director of the Police Medical Service Administration in Sudan and the director of the Police Central Hospital, Khartoum. Let us welcome Professor Abdul Latif Ashmig. Thank you, Professor. And now, the father of many generations in Egypt and MENA region, the professor of the professors. He was born 1944, professor of obstetrics and gynecology, the Faculty of Medicine at Shams University since 1987. The ex-director of the OBGYN Hospital at Shams University, and ex-director of the Gynecology Unit, the Egyptian Fellowship of Obstetrics and Gynecology Board Examiner, the Egyptian Medical Emergency Society Examiner, member of many societies. One of them, the Egyptian Obstetric Gynecology Society, the Egyptian Fertility and Sterility Society, the Middle East Fertility and Sterility Society, the American Society of Reproductive Medicine, the American Ultrasound Society, the Pan-Arab Updating Medical Knowledge Society, the Arab Society of Obstetrics and Gynecology and Infertility and Women Health, European Society of Gynecology, International Society of Endoscopy, and many others. Let us welcome Professor Sobhi Abulloz. And now, our guest speaker was born 1958 and was graduated from the Faculty of Medicine, University of Jazeera, 1985. Awarded the degree of MGO, 1992. Has many remarkable abilities regarding the teaching, mentoring, supervision, students assessment, curriculum development and evaluation. Founded and implemented the first master PhD degree postgraduate course in medical education 2008 in the University of Jazeera. Obstetrician and gynecologist Wad Midani Teaching Hospital for OBGYN since October 1992. Consultant of Gyne-Oncology and member of the Gyne-Oncology Clinic at the National Center at the National Cancer Institute, University of Jazeera. Professor of OBGYN and Medical Education at Faculty of Medicine, University of Jazeera, and the chairman of the Bashir Hamad Research Chair for Medical Education and Social Accountability, University of Jazeera. Let us welcome Professor Muhammad Al-Sinosi. And now let us welcome Professor Ashmeeg. He will give us a talk on behalf of the Sudanese delegates who is usually supporting us in our events and conferences we are holding. Please, Professor Abdul Latif.
Thank you very much. I already delivered some of my talks previously, but I want to just to repeat and to thank actually Professor Kamal and Ahmed Khatib for the kind invitation and to congratulate them also for the success of this important meeting. Always we are enjoying to come to Cairo, to our second home. Actually, on behalf of the Sudanese delegates in this conference, which they constitute maybe around 50% of the delegates, and always they do that. And actually, we want to thank Eva Farm and the head of the Sudan part, Dr. Maaz, and his colleagues, actually, for always supporting our team and arranging these important scientific and social meetings. Actually, on behalf of the Sudanese delegates, we repeat our thanks always for Dr. Maaz and his actually successful team who are arranging everything, bits and parts of of making these meetings very successful. And we hope that we meet every now and then. And actually, it was maybe the COVID era prevented us maybe for 2 years, but we wanted to be repeated every now and then on our loved Egypt and the colleagues, Professor Muhammad Kamal and his colleagues, and the Society of the Egyptian Foundation. And actually, we invite ISUOG also to invade Africa and to arrange a successful one as this one. And we repeat our thanks for Muhammad Kamal and his colleagues and teams for inviting us for this important meeting. And just a small award on behalf of Sudanese delegates, we want to give you this small award, and we ask you to accept it.
Thank you, Professor Abdulatif. Thank you so much. And now, just hold on for just a few minutes. It's time to have the opening ceremony lecture in which you will live the evolution of modern science in only just 30 minutes. Will be presented to us by Dr. Magdi Sheikh, who is one of the pioneers in reproductive medicine and many international publications. He is now appointed at the head of the ART unit, Sulaiman Faqih Hospital, Jeddah. It's titled, "The Sky is Your Limit, the 20th Century Defends Itself."
Respectable audience, distinguished guests, the time has come for us to face and charge a past century of pain, inaccuracy, and unfairness. We would like to hear what the 20th century has to say. Did you or did you not create 2 world wars and waste millions of lives? Did you or did you not discriminate against races and abuse children? Mr. Century, did you or did you not suffer ignorance and poverty? Did you or did you not manage the sick wrongly? Did you or did you not transfuse patients with incompatible blood? Did you or did you not fail to recognize and treat infections? Syphilis, typhoid, smallpox, cholera, tuberculosis, anthrax, and polio are only just examples. Ladies and gentlemen, on your behalf, I hereby charge the 20th century with ignorance, inadequacy, incompetence, unfairness.
Sitting at the far end of the park, watching the kids play. The very same spot, the very same clouds and skies, the same northern breeze, the same hour of the day. If they just look at him or give him ear, very little time is left to set the records clear. A small cold hand touching the old man's shoulder interrupted his dream. The old man seized the opportunity and started to say,
my diary is full with so many memories. I wish you recognize my deeds and hope you excuse my weakness. It might be my destiny, or perhaps my fate, to live and remain. Never was my wish to denote all the folks. They are all gone now. But here I am to linger and pass the story to you. Very serious charges. Probably we're getting life sentence here. But we, with very little in hand, paved the road for you. And we, with much less fortune, made this possible for you. Life was not in any way similar to what you're about to innate. Our life was different. Our facilities were nothing compared to what you have. Our ambulances, hospitals, instruments were all very primitive. However, we didn't lack enthusiasm, perseverance, nor honesty. We did our best to help the sick and needy. What was more concerning than the facilities was the ancient concepts that we had to live with. Concepts that not only affected our medical care, but also restricted our attempts for improvement and creation. You can only imagine that you have no communication. If you have a sick patient, you had to travel to the medicals. And if you happen to be living in a remote area, you probably have to use a horse or a donkey or a cart. You might spend a day or two on the way to reach the hospital. And above all, we didn't have electricity. You know, my son, it's quite difficult to examine a patient under the oil lamp light. But that's what we had. Our homes, streets, were all dark. And we had difficulty in treating our patients. But we did our best. We also had to create and make our own instruments out of nothing. And some of the instruments and equipments were kept secret in families. So there was kind of privatization. Perhaps they didn't want it to fall in the wrong hands, or some kind of selfishness. As you see, instruments and equipments run in the families. But again, there was some light. Thomas Edison, a great scientist, after 200 trials, eventually managed to invent the electric lamp. And this brought a lot of hope to everybody. It was a tremendous achievement that opened the door for us. Thomas, as a child, was just below average child. You know, my son, that Thomas was sent back from school with a letter to his mother saying that he is incapable of education. And he asked his mother, what was this letter from the teacher about? She said, no, the teacher said that you are so intelligent to stay at school. So he was totally educated by his mother at home, and he was totally self-educated afterwards. Thomas patented more than 1,000 devices, and he laid the foundation for the General Electric company that you all know now. When he was asked about his genius, he said, well, genius is only 1% an inspiration and 99% perspiration. Infections and infectious disease. Yes, we had infections all over the place. We had so many diseases. But our elite thought that diseases arise from inside. We had to battle with the concept of endogenous evolution of sickness. In other words, that sickness arises from inside the body. And you cannot argue with them because you will be risking yourself, probably risking your life. We didn't know about germs. We didn't have microscopes. In fact, the first microscope was introduced by Luynog. This is a Dutch draper. He works with clothes. Lenses were known from the time of Galileo, but there was no microscopes. So Leo invented a simple microscope of one lens and light source to enable himself to look at threads. And incidentally, Leo saw creatures moving in the water under his microscope. Well, he called them small animals or animalcules. He is not a biologist, but he wrote several articles to the Biology Society. and reported this incident. After that, he got interested and he added another 500 improvements on his microscope, and that's equipment to the type of equipment we used. But the real development in infections and infectious disease and our knowledge about that was made by Pasteur, Louis Pasteur. Louis Pasteur was an opponent of the spontaneous evolution theory. Louis had 5 kids. 3 of them died at early childhood by typhoid. He was a professor of chemistry in Paris, but his work in biology and microbiology was tremendous, probably more than chemistry. And perhaps because of the death of his children, he was inclined to work in microbiology. He was opposed strongly when he introduced the germ theory. Pasteur told us that infections arise from outside, and there is organisms that are responsible for infection. So, you know, my son, before that time, we didn't know that bacteria or germs exist and cause infection. It is us that we introduced the germ theory. Louis was assisted a lot by Robert Koch, a German guy who was also working in the field of microbiology. And both of them struggled very hard to lay the foundation of the modern microbiology that we have now. They collected a bunch of very elegant and interested scientists around them in Paris and in Berlin. And between the two of them, there has been lots of discoveries and inventions. In meetings, they virtually skinned each other to the bones. But on the personal level, they admired each other and loved each other and cooperated. Well, Louis Pasteur was the one who introduced pasteurization, the one who recognized that microorganisms cause fermentation. And at that time, he saved the milk and wine industry in France. He advised surgeons, obstetricians, to boil their instruments, to sterilize them. And he was faced with fierce resistance. He also learned that by culturing organisms, the virulence of the organism might change. And this laid the foundation for the production of vaccines. He performed the first randomized controlled study on animals with anthrax vaccine. And he invented the anthrax vaccine and rabies vaccine. He didn't get a Nobel Prize because Louis died 5 years before the century. But he is very much a man of the 20th century. He had a stroke and left side hemiplegia and died while working. His last words were, "I have to work, I have to work. I think I have done my best." He was buried at the Notre Dame Cathedral, and eventually his remnants were transferred to Pasteur Institute, which was inaugurated in 1888. And now you have at least 3 other Pasteur Institutes all over the world. Pasteur always said, chance favors only the prepared mind. The other great guy was Robert Koch, the German. Robert actually discovered the anthrax vaccine for which Louis Pasteur developed, the anthrax organism for which Louis Pasteur developed the vaccine. His great discovery of the Mycobacterium tuberculosis changed history. You know, my son, at our times, every single family in Europe had a mortality with tuberculosis, up to the extent that people thought that tuberculosis was a hereditary disease. Robert traveled to Alexandria in Egypt, Calcutta in India, to look for the organism causing the cholera. And he laid down the Koch postulate, which is used for in diagnosis of infectious disorders up till now, which means you have to have an organism and disease that's caused by the organism. So he linked the relationship between the disease and the organism. He got his Nobel Prize 1905, and he deserved that. And Robert Koch Institute was inaugurated in 1900. His students and workers discovered the diphtheria organism, pneumonia, cerebrospinal meningitis, typhoid, leprosy, plague, tetanus, and syphilis. So we worked very hard at that time. Paul Rowe was the second man in Pasteur Institute. Paul was able to isolate toxins for tetanus and diphtheria, and therefore they developed the anti-tetanic serum and anti-diphtheria serum, which was a great revolution in the management of infectious disorders. Rowe had the first Nobel Prize in Physiology or Medicine, 1901. Elie Mechnikov was another man of the Pasteur group. He was a Russian zoologist, traveled from Russia, Italy, and settled in France with Pasteur. And he was the one that described phagocytosis. You know, we didn't know that white cells kill bacteria and do phagocytosis. In fact, the predecessor thought that white cells spread infection. The TB vaccine was a great revolution. Albert Calmet, a man of Pasteur group also, discovered the TB vaccine. But to be fair, the TB vaccine work was a joint work by many people. Fire described how we prepared bile-containing media, and this bile-containing media could attenuate organisms. Later was discovered, and Koch discovered the TB bacillus, and the joint work on the bovine tuberculosis between Camille Guérin and Albert Calmet resulted in the production of the first TB vaccine, which was used at the Charité Hospital of France successfully. And when the vaccine was used in Germany at Lübeck, 72 children got TB after vaccination, and the vaccine was halted until a new version was produced in 1932. Emil von Behring, a man of Robert Koch, produced diphtheria vaccine in 1913. Before that, many children died with diphtheria. So we did our homework, and we tried our best to get out of these problems. Also on the therapeutic side, we worked on medications. Ehrlich, a German scientist, discovered treatment for syphilis, and on the way, there were other medications. You know, when Röntgen discovered that passing an electric current through a vacuum glass produces a strong electromagnetic current, and this electromagnetic current can pass through flesh and not bones, we came to know the X-ray. And actually tried that on the hand of his wife for the first time. And he discovered that he can see the bones and the wedding ring of his wife. From that time, X-ray had been involved strongly in the Balkan War 2 years later to diagnose the site of bullets inside the body of soldiers. By the frequent use of X-ray, we started to realize that X-ray also destroy tissues. And this made this great physician, George Peirce, to think of using X-ray as a therapeutic treatment for warts, skin cancer, breast cancer. And this was the introduction of radiotherapy treatment. And George Peirce, both of his parents died with tuberculosis, you know. Blood. We didn't know that people had different blood groups. All the informations we had from the predecessors were bizarre. We learned that blood was used orally by some, and we know that Richard Lower performed an experiment transfusing blood from dog to dog and eventually using dog blood to humans. And also, Jane Baptiste used lamb blood to humans successfully. We don't know what successfully means. Until a surgeon called James Blunden in London transfused human blood from a man to his wife who was dying with postpartum hemorrhage. And luckily she survived. So he was happy with the result. He used that on 10 other patients, only 2 of them survived. The other ones developed strange things like passing dark urine, getting jaundiced, severe pain, and collapsing to death. Our folks across the Atlantic were not any wiser. They thought of using milk transfusions. They tried cows, goats, and human milks. Saline infusion was only introduced when cholera epidemics happened to replace salt and water. But anyway, we saw light at the end of the road. Karl Landsteiner, a big name to remember, an Austrian physician who was the first to describe the blood groups. We didn't know before that people had different blood groups. Landsteiner described 3 different blood groups. 2 years later, a couple of his students described the 4th blood group. And the first successful transfusion was carried out at Mount Sinai, New York in 1907. His discovery was ignored for 30 years, but he got a Nobel Prize for that, 1930. Also, a guy called Janjeski, physician from Czech, discovered the blood groups, but that was 7 years after Landsteiner. It took us several years to find a solution for clotted blood. We could not store blood. It gets clotted. Eventually, in 1914, we discovered that by adding sodium citrate, we can use the blood for a longer duration. And in 1940, RH group was described by Alex Werner. So all this was not known before. Now we started to investigate other problems. Sickle cell anemia was described by Herrick, and plasma transfusion was used by Edis, and the ball started rolling. Corneal transplant was carried out by Zirm, Austrian ophthalmologist, successfully for the first time. Also, on the other sciences were developing massively, dramatically because of enthusiastic people we had. One of them was Marie. Marie was a Polish scientist, physicist, who traveled to France and got married to Pierre Curie. Both of them worked very hard. They spent so much money from their pocket and time to discover radioactivity. And they got a Nobel Prize for this. Unfortunately, Pierre died in a car accident a few years later, and Marie had to continue her work until she discovered radium, which you use in different aspects of life. And Marie got another Nobel Prize, and she went to teach at Sorbonne. She was the first woman to get 2 Nobel Prizes and to teach at the Sorbonne University. Another great man came from New Zealand to the UK, was Lord Ernest Rutherford, who went inside the nucleus and discovered alpha and beta rays, identified neutrons and protons, and performed controlled nuclear split and got Nobel Prize 1908. Rutherfordium is element number 104 in the periodic table, was named after him. He died in London and was buried at Westminster, LA, next to Isaac Newton, and he got a Nobel Prize for this. We can't, of course, ignore the work of Albert Einstein.
What distinguishes the language of science from language as we ordinarily understand the world? How is it that scientific language is international?
Yes. He
What
said,
science strives for is an outpost of
he was also a musician.
if language is to lead us all to understand. There must be rules concerning the relation between the science on the one hand, and on the other hand, there must be a stable correspondence between science and the impression.
A great man. Millikan described the electrons. They were not known before that. 1912. Also, surgeons were doing a good job. We had Alexis Carrel, who was a French, moved to the United States. He was a good vascular surgeon. He developed techniques in vascular surgery that were not known before and used antiseptic chlorine-based solution for wound treatment and invented the perfusion pump. He got a Nobel Prize for this. You said that we discriminated against races. In fact, we worked very hard to abolish this bad thing. And this Slavery Act in England was issued in 1907, but we worked very hard to implement it in the 20th century. And the 13th Amendment of the US Constitution, 1865, also abolished slavery. So did all the other European countries. Unfortunately, our work was interrupted by war. The Great War. Well, we ended up with 8 million dead and 29 casualties, 29 million casualties. But again, war is a humiliation for human race, an abuse of science. After that, we recovered very quickly. And Jan McLean, a second-year student, and William Hall and Luther Holt, 1916, extracted heparin for the first time. And that was made commercially available 20 years later, 1936. What could you have done without heparin? You know, we didn't have facilities. We had to improve communications. We had to improve all other facilities. We cannot go on without them because we didn't have a regular radio broadcast until 1920. And the first telephone conversation between London and New York was only 1926. Before this time, there was no communication. We extracted insulin from animals, dogs in Canada. Banting went to MacLeod, Professor MacLeod, and asked him to provide him with laboratory facilities. He closed his private clinic and stopped working and devoted himself to extract insulin. MacLeod provided him with a student called Best. They extracted insulin from dog pancreas, and James Collip helped them in purification. Eventually, they tried to extract 1922 on a dying child with diabetes who survived. So 1922 marked the introduction of insulin in the management of diabetes. We didn't know sex hormones until 1929. I received a phone call from my friend Adolf Bittman. He told me he discovered a hormone that he thinks is responsible for making women look the way they do. And from that time on, other sex hormones started to be on the agenda. Fleming was a big story. Alexander was a bacteriologist working in London. And Alexander was a rather untidy person. He left his laboratory with some dishes with bacteria and traveled for a holiday. When he came back, bacteria flourished in the dishes except a couple of dishes where a mold had grown. So he said one sometimes finds out what one is not looking for. This describes his personality. He's a very good observer. So Alexander thought probably the growth of the mold killed the bacteria, and he described the mold juice, which turned up to be the penicillin later on. It took us more than 10 years to produce it commercially, but the first patient who received the penicillin was Ann Miller in the USA, a patient with septicemia following puerperal sepsis who was dying, and there was very little amount of penicillin available. Her doctor asked for a spoonful of penicillin, which was provided, and the patient was cured. From that time on, all companies rushed to produce penicillin. But Gerard Dumac described sulfa and used it for treatment of patients earlier than penicillin. Although sulfa was described after the discovery of penicillin, but it was used and implemented before the penicillin. We tried to abolish children employment, and the act to abolish children employment was issued in the UK, and by the year 1933, there should be no employment of children. So again, we're faced with another great war, abuse of science. destruction, hunger. Atomic bomb was used. Cities were demolished. Science was totally abused. And the toll was very heavy. It was millions of people killed and injured. But again, we recovered. Chances come to the clever minds. In Donald, a great Scottish man in Glasgow, he pulled out the secret of the ultrasound from the industrial and military sources and created his own first ultrasound machine, which is now currently used by all of you. In Donald, 1948, told us about the ultrasound. Ian was a great man. He fathered 4 daughters. He was a cardiac man, cardiac patient. He had 4 cardiac surgeries. But his sick heart was in the right place. He was all-rounder, painter, sailor, mechanic, electrician. And he diagnosed his own hematoma in the chest with his own ultrasound. He wrote a nice book that everybody learned from, opposed Abortion Act, and became commander of British Empire. He died at the age of 77. But he laid the foundation for the ultrasound technology that you know and you use now. Another great man is Roddick in London. Roddick was a good obstetrician. He worked in diagnosis of genetic and chromosomal anomalies in uterus. He mastered the fetoscopy technique, and he had 700 publications. But again, the largest fetal assessment unit was established by Stuart Campbell in London, King's College. And Stuart was interested in fetal biometry and fetal well-being. He had many students from all over the world coming to learn ultrasound at King's College in London. One of his co-workers is this great man, Kypros Nikolatis, a Greek who moved to the UK and became a British citizen. He was considered the miracle doctor of the National Health Service. He performed many intrauterine procedures for different sorts of things. Kypros was a nice man. He supervised 700 research PhD or master degrees and produced 1,500 publications. He worked very hard and struggled very hard with his work and struggled very hard against his leukemia. TV, fax, and television were all introduced by us. In 1933, cortisone was isolated from animals and used successfully to treat different types of disease, including rheumatoid arthritis. Poliomyelitis also got attention. We produced the vaccine for poliomyelitis, the Salk vaccine, injectable form, and the Sabin oral vaccine. And Sabin was a very kind man. He refused to patent his vaccine discovery and allowed it to be manufactured by everybody. We also produced contraceptive pills for you. I don't know what you have done without it. We performed the first kidney transplantation. Joseph Mary did that on identical twins, and he got a Nobel Prize for this. Several kidney transplants were performed after that. Some of them had difficulties with the rejection. So the science of immune suppression was introduced by Jane Hamburger. This great genius man is a big story. He's a fearless surgeon. He introduced liver transplant. And listen to this. We also introduced heart transplant.
On the 3rd of December 1967, surgeon Christian Barnard performed the world's first human-to-human heart transplant. Barnard was head of the Department of Experimental Surgery at the Groote Hospital in Cape Town when he performed the pioneering surgery. Having previously performed successful kidney transplants, his team identified 53-year-old grocer Louis Washkansky as a suitable recipient of a donor heart. Washkansky had developed chronic heart disease but had previously been an active sportsman and was said to have displayed a tenacious determination to hold on to his life. On Saturday, the 2nd of December, 25-year-old Denise Darval and her mother were struck by a drunk driver while crossing the road. Although her mother died at the scene, Denise was transferred to Groote Hospital when she was diagnosed as brain dead. While a respirator maintained the beat of her heart, doctors approached her father, who agreed
Another Egyptian British surgeon performed the first heart and lung transplantation in the UK. He's here celebrating the 19th birthday of his heart transplant patient. The 90th birthday. We developed the science of genetics. We looked at the DNA. Double helix models were described by Watson, Crick, and Wilkins, and Franklin, who died before they get the Nobel Prize. And this laid the foundation for the genetic science. NASA was introduced to explore the universe, and we landed on the moon. Again, IVF. Robert Edward and Patrick Steptoe performed the first successful IVF. But again, Walter Hipp was the first one to perform embryo transfer in history 100 years earlier. He transferred rabbit embryos from one rabbit to another, and it took us 100 years to establish the IVF that we are doing now. Robert Edward got the Nobel Prize, and Patrick Steptoe also got the blue plaque. And Louise Brown was born. And she became a mother. Another great guy, Egyptian-American Ahmed Zuwail, described his camera that used the nanotechnology, and we have been able to look at reactions that we were not able to see before. He earned the Nobel Prize also in chemistry. So you see, my son, in our century we had 130 Nobel Prize winners in chemistry, 154 Nobel Prize winners in physics, 165 Nobel Prize winners in physiology and medicine. We couldn't have done any more. You have to go and look in the history and see the history makers. You see, we worked very hard to extract knowledge and information from different civilizations, Egyptians, Greeks, Romans, everybody, Persians, to provide all these informations from all over the world to you, and provide you with this beautiful world to live in. So you see, in defense, we regret that we had all these charges. We confirm we were not ignorant, brutal, or lazy. We worked hard. We put up with many mistrusts, ontological and physical hardships. We lost our money and lives on occasion. We fought on all fronts to bring you knowledge and wisdom that you now possess in a language that you can understand. So, my son, now it's all up to you, my son. Sail with force and wisdom, fly with courtesy and care, judge with fairness and humanity. May your mind remain unhindered to search, think, and achieve, for only the sky is your limit.
Thank you so much. We have the end of the opening ceremony, and we will have a break for around 30 minutes and then go back to the lecture rooms. Enjoy.
لا إيه لا إيه لا تست لا
بسم الله الرحمن الرحيم. الزملاء الأعزاء، اسمحوا لنا نبتدي second plenary session. ومعلش احنا we are a little bit late. احنا معانا two lecture في ال second plenary session. هنبتدي أول session، هنبتدي أول presentation. التوبيك preeclampsia biomarkers by Dr. Blenda Shili from Tunisia. Welcome, Dr.
شكرا. هو في شوية بحط. هذاك ما يمشيش عليه، ما يمشي. لا لا c'est bon. Ok. It's okay. لا it's okay. تناقض هذا فما ليزر هو اللي في الوسط. très bien.
May I introduce Professor? She is a Professor of Gynae and Gynecology, Obs and Gynecology and Fetal Medicine, Tunis University, heads the Department of Midwifery Center and Chief of Research Laboratory. Yes, please.
شكرا. Can I begin? شكرا. بسم الله الرحمن الرحيم. اولا حبيت نشكر دكتور محمد كمال على الاستضافه. انا سعيده جدا بوجودي في مصر اليوم، البلد الشقيق، مع ثله من الاطباء التوانسه. It's the first time، اول مره نجيو من تونس لمصر باش نشاركوا في المؤتمر هذايا، وان شاء الله ما تكونش اخر مره. و I will begin in English the presentation. So they asked me to talk about preeclampsia biomarkers because I will show you that we began in Tunis working on that since a few years now. And before talking about that, I will show you these slides to make you remember that maternal mortality is not equal in all the parts of the world. As you see here, the problems are more important in low-income countries, of course, in Africa and sub-Saharan Africa. Just to let you know that more than 99% of these deaths occur in low-income countries, in developing countries. Here, just to show you that in Tunisia, many efforts have been made on health, and we could decrease the maternal mortality rate. For now, we have about between 40 and 50 per 100,000 deliveries. But it's not the same thing in the other countries, and I focus on Africa because, as you know, the problems are there. The key facts are that more than 800 women die every day from preventable causes, and the most of them die in developing countries. Maternal mortality is higher in women in rural areas and among poorer communities. What about hypertensive disorders and in pregnancy? They affect up to 10% of pregnant women. With their complications, they contribute to maternal and perinatal morbidity and mortality worldwide. They are responsible for more than 67,000 maternal deaths per year and more than 500,000 perinatal deaths per year. So it's a really big health problem worldwide and particularly in Africa. As you see here, the most important causes of maternal deaths are bleeding, severe bleeding, and pre-existing medical conditions, and then you have pregnancy complications of high blood pressure, so preeclampsia. It's important to differentiate between early onset preeclampsia, that is preeclampsia occurring prior to 34 weeks, and responsible for preterm induced labor. Generally, as we saw this morning, it has many complications, and it's an important health problem. Then you will have mid-onset between 34 and 37 weeks, and the late onset after 77 weeks. So the most important type is the early onset preeclampsia, which is associated to really many problems for mothers and babies. Another thing I wanted to focus on is that there are long-term risks for mothers, even if they don't die. They have risks of chronic hypertension, of diabetes, of cardiovascular disease, cerebrovascular disease, and kidney disease, and impaired memory after delivering. For those infants also, there might be neurodevelopmental impairment, insulin resistance, diabetes, coronary heart disease, and hypertension. So as you see, preeclampsia doesn't stop when it occurs. Even for those mothers and those babies, there are long-term risks. So the problem is preeclampsia predictable? Not really, because if you rely only on the history, the maternal history, you will only detect maximum 50% of patients. You will have 50% who will be primipara with their first pregnancy. And once diagnosed, the evolution is unpredictable. You don't know if it will be severe preeclampsia, mild, if the patient will be able to go on until term. So what about the underlying origin of placental dysfunction in preeclampsia? I will try to explain to you the current understanding based on biomarkers. Let's begin with the classical, what you know generally about preeclampsia. So everyone knows that between 8 and 16 weeks, there is an abnormal uterine vascular remodeling resulting in hypoperfusion and then resulting in villous trophoblastic dysfunction with endothelial disease and maternal complications, fetal complications, and placental complications. So that's the classical schedule that you know all. This is the new thing. So many researchers and authors worked on this topic, and they studied particularly angiogenic factors. You all have to know that we have pro-angiogenic factors and anti-angiogenic factors, and normally in a normal pregnancy we should have a balance between those factors. So PLGF is the placental growth factor, and SFLT1 is an anti-angiogenic factor. In normal pregnancy, we won't have complications. In abnormal pregnancies with preeclampsia, there is an angiogenic imbalance with SFLT1 more important than PLGF. So the ratio of SFLT1 on PLGF will be more important. Let's see this in details. Here you see the maternal endothelium and angiogenic balance. So in the endothelium, you should have SFLT1 and PLGF in equal amounts. And here you have the normal pregnancy. In preeclampsia, the bioavailability of free pro-angiogenic factors, PLGF, is markedly decreased because it's captured and inhibited by SFLT1. And then SFLT1 will cause peripheral vasoconstriction, as you see here. So here is a normal blood vessel, and here vasoconstricted blood vessel. and then it will rise maternal blood pressure, and you will see all the complications. So in the first trimester, you have to know that PLGF, the placental growth factor, is detectable from 10 weeks of pregnancy, and this is an important thing to know. You will see why. And its amount will evolve differently between a normal pregnancy with no preeclampsia, so this is from the first trimester to the third trimester, and the more you will have severe preeclampsia, the less you will have amounts of PLGF. Here the traduction, we traduce the other slides in which we saw the classical physiopathology of preeclampsia. So in the first trimester, PLGF is the biomarker, the most important marker, in which there will be impaired presentation and problems of vasculogenesis. Sorry. Then, in the second trimester, the problem will be the ratio, because then we will be able to detect the FLT1 and PLGF, and this will be responsible for all the complications we saw for the fetus, the mom, and the placenta. So it's different. The biomarkers you can detect at the first trimester are different from those of the second trimester, and the aim is also different. And if you want to give us something maybe easier to understand, it's if, as you have a volcano, which doesn't work in the first trimester, you don't see anything, but there are problems of imbalance of biomarkers. Your diagnosis until now is made from 20 weeks, and there you will have new onset hypertension with proteinuria in the second half of pregnancy. And if you have complications, you will have sometimes warning signs and really complications with maybe fetal death or maternal or fetal death. So the interesting thing is, in the first trimester, you will have a window of opportunity to predict and prevent preeclampsia thanks to the detection of PLGF. There is a possibility, before everything exists, to screen patients at high risk of developing preeclampsia and to give them treatment to prevent preeclampsia. So now preeclampsia can be preventable. In the second or the third trimester, once you already have the signs, you cannot prevent, of course, but this ratio will help you to do diagnosis and to know the prognosis of your pregnancy. So let's see the usefulness of biomarkers in the second and the third trimester. The clinical implementation of angiogenic markers in the second half of pregnancy will help first to predict and diagnose preeclampsia, second to manage and to give a prognosis of preeclampsia. And here I put this slide to show you how this works. So just to know, it's a simple blood sampling. You give it to the lab and you will have a result as you will have. So if it's beyond 33, you can rule out the diagnosis. It means, for example, you have a patient at 29 weeks who comes to see you and you take the blood pressure. It's about 140 and 90. You don't know if you have to ask her to go to the hospital, to keep her, to let her go home. You can propose this blood test, and if you have a result under 33, you can be sure that within the 4 weeks, within the month, any problem will happen. And this means the rule out. So it's clear for early onset preeclampsia and late onset preeclampsia. If you have a result more than 85, it depends. So if you are in early onset preeclampsia before 34 weeks or after, it depends. The cutoff is different. But I won't insist on this. You will see why, because in our results, things are different. This is a strong publication of Mr. Verloren. You see, these are recent publications in which it was the prognosis study which concluded that the ratio under 38 or lower can be used to predict the short-term absence of preeclampsia in women in whom the syndrome is suspected clinically. This is a very important publication. And then Mr. Verloren published now in February 2022 in the American Journal of Obstetrics. Please see here, you see that there is a balance, and even if you have a primary risk or pre-existing conditions, the most important thing to assess actual risk is the ratio for pregnancy outcome. So if you are under 38, it's green, it's okay, nothing will happen. More the ratio will arise, more you will have complications. But let's not take the cutoff of 85 for now. You will see why. So if you are under 34 weeks, the split 1 PLGF ratio is useful for also the differential diagnosis in case of chronic hypertension. I don't know if in your countries, but in Tunisia, some patients don't have prenatal care like they should, and they come and they are at 30 weeks, and you take the blood pressure, and maybe you find 15 under 100, and you don't know, she doesn't have edema, she doesn't have a problem in the blood test, and you have to keep her. Now, with this ratio, if you have a ratio under 85, it can help you to know that it's chronic hypertension and not a new onset preeclampsia, because you don't have any idea of what happened before. Many other studies studied the IUGR, the vascular IUGR, and for now there is insufficient data to establish a specific cutoffs, but you have to know that in vascular IUGR also ratio is involved, and it can help you. Sometimes you know also that you can have some patients who come with IUGR and there is no blood hypertension, but if you do your ratio and if it's disturbed, it can help you to know that it's vascular, and maybe then you will have the onset of the clinical hypertension. So, to summarize, for a ratio under 38, the interpretation is rule out for 1 week with negative value of 99%, very high value. For 4 weeks, 95%. And this is important in our areas. I will talk about Tunisia, but I'm sure it's the same thing for you. When you have patients coming from rural areas, they don't have enough doctors in their areas, it's really helping to know if you can tell her to go home and to be safe. Then for the other intermediate risk, you see that ratio can go very, very high, more than 655. Here, for example, only 30% of patients will remain pregnant within 48 hours. So the more it's high, the more you know that you will have maternal or fetal complications. Many publications have been done. Many researchers are studying this item and this topic. Just to tell you that really the conclusion of all the doctors who are working on that is the split 1 on PLGF ratio is effective in predicting preeclampsia and its adverse outcomes. And it helps in health economics, of course, because if you don't hospitalize all the patients, they come with a problem of hypertension, thanks to this ratio, you will save money. But where is the problem? The problem for now is we know when and how to be able to roll out, but we don't know the cutoff, the real cutoff, which will determine maternal and fetal adverse outcome. The first publications have been made in Germany. So that I showed you in the New England, it was in Germany. And when we saw that, we said, okay, if we will take in account 85 as a cutoff, we will see if it's adaptable to Tunisian women. Just to show you that many studies showed that the ratio, the cutoff, actually is not possible to do because it depends on the countries. You see here more than 800, for example. Here 100, 400, 700. Here 293. So this is a problem for now. And now I come to Tunisia, my country, to tell you if you don't know it. It's located in North Africa. Our official language is Arabic, but we also speak English, French, and some other languages. We are about 11 million, so if you take all Tunisia, it will be the same as Cairo, maybe. So it's a little country. Scholarity is given to 99% of people, and 65% of our population lives in urban and peri-urban areas. Here is our university, and here is my hospital. I work in a public hospital, one of the referral third-level hospitals in Tunis, with neonatal care units. So we began with 3 studies. The latest one is ongoing. Just to show you the reality, the everyday reality, it's crowded. We don't have place for each baby in our neonatal care unit. Sometimes we have to put 2 or 3 in the same place because we don't have enough money and enough things to do that. And here to show you that how did I discover the history of biomarkers. In 2015, I have been invited to the PNS forum, and as you see here, when it's colored, it means that there is at least one representative of the country. So I was the only African representative in this PNS forum among 33 countries. And then we began to work on biomarkers. I published this original article in 2016, in which we had already different results compared to the publication of Verloren, because we had amounts of ratio more than 1,000 in our population without very big complications. So we said there is something wrong, or maybe there are genetic things different, or maybe the settings are different, and we cannot use things coming from Europe or from, not to say rich countries, but high-income countries that have everything at their disposition. They can have neonatal care units, their hospitals are in better conditions, and we decided to continue doing this report study included in my search laboratory with the Ministry of Health and other ministries. So we decided it was just an observational study. It means that all patients coming with high blood pressure at our hospital, we managed them like usual, but we took blood pressure and keep it, not to be disturbed with the results. And we managed normally, and then when she delivered, we took the results to see if the value of ratio would have been changed, or if it's exact to take in account the 85. And we began in April 2017 until now. We included 581 patients with preeclampsia, and now we are finishing the control group with 60 patients. The aim of the study was to find the cutoff. If the ratio, there is a cutoff, a threshold, correlated with maternal and fetal morbidity. So just to confirm you, be careful. About 50% of patients coming with severe preeclampsia were premipara. So you cannot rely on the medical history alone. To give you quickly our results in this setting, normal setting, we had about 26% of maternal complication rate. The average length of maternal hospitalization was 5 days plus or minus 5 days. The fetal complication rate was of 46%. This is true life. Fetal death rate, 6%. And average length of new hospitalization, 16 days. The cost of 1 day of hospitalization in Tunis, in my hospital, is about $500 1 day. So it's really very costly, a big health problem. Then, once patients were delivered and we compared what happened, our complications, I cannot give you more information, and we should publish how to implement this ratio. I'm sorry we didn't have enough time, but I have many clinical, real clinic cases. But if you want, we can discuss after. So it's an objective, independent of women, of human, because it's just a blood test. A dynamic tool, it's very important. It's a dynamic tool. You can find today 200, tomorrow 300, then 300. It's not the same thing if today you have 200 and the day after you have 800. For the second and third trimester. It does not replace other techniques, of course, because I know what you are thinking about. You would say, I'm sorry, when I have a patient with high blood pressure, I want to maybe take time to do the blood pressure. You have to take in account all things, but in sometimes when you won't have all the classical signs, when you won't have edema, when you are not sure, when you don't know if you have to keep her, it will really be helpful to have this exam. It's helpful for early onset preeclampsia to avoid induced preterm delivery. It's very much cost-effective. And when you should do expected management in this patient. For sometimes you have infertile patients who are 40 years and you would like to keep the baby if possible, not taking also complications. So it can really help. It's a strong predictive and diagnostic value for preeclampsia-related disorders. For the rule-out, of course, more than the other, for now. Its implementation in clinical management saves costs, and decisions regarding delivery must take in account other established techniques and the clinical context. So, before finishing, we'll see, I'm sorry, I hope we still have some minutes. The key question, isn't it better to identify women at risk in the first trimester, since PLGF exists and we could screen at the first trimester? This is the logical way to think. What should be the appropriate screening approach to identify women at risk? So you have to know that since about 10 years, all this is recent. So about 10 years, many researchers worldwide, studied many things, and you will see here important data such as the ASPRE trial with the Fetal Medicine Foundation. You'll see why. And until now, the FIGO included this screening. It's in its recommendations. First trimester combined preeclampsia risk assessment. You see, unfortunately, that in all Africa we are not considered still. This was published before we began in Tunisia. I don't know, in Egypt, I don't think you began. But in many, many countries in the world, this screening began. These are slides from the Fetal Medicine Foundation. So it's called the EFMF triple test. We'll see in details. It's the best predictive performance by combination of maternal factors with middle arterial pressure, uterine PI, and serum PLGF. So we won't rely only on the blood test, on PLGF, but we will take in account the medical history and some other tools. Be careful to the quality assessment. The middle artery pressure should be taken in a special way. The Doppler, you have to know how to measure the pulsatility index, uterine pulsatility index, and also the use of the cryptor, of the machine which evaluates the PLGF, also must be done carefully. This is an important slide to show you. So here you have the method of screening. If you rely only on maternal risk factors, this is the detection rate. You won't detect more than 45% of people who are at risk to develop again a problem of preeclampsia. If you take in account the maternal risk factors plus, and then you will choose, you will see that if you take in account the maternal risk factors plus middle arterial pressure, mean arterial pressure, uterine pulsatility index, the PAP-A, and PLGF, you will have a detection rate about 75% of your patients in the first trimester. So this changes everything. So how to implement this first trimester prediction? Here, the latest publication of the FIGO about preeclampsia screening, and I put here the most important things to know. All pregnant women should be screened for preterm preeclampsia by the first trimester combined test. Risk calculator is available at FMF site. FIGO encourages all countries to adopt this strategy. Best combined test is maternal risk factors, MEAP, PLGF, and uterine PI. Women identified at high risk should receive aspirin between 11 to 14 weeks at a dose of about 115 milligrams to be taken every night until 36 weeks. This is what it's made for. And low dose aspirin shouldn't be prescribed to all pregnant women. Just to remember you that if you give aspirin after 16 weeks, it doesn't work, so please don't do that. You should give aspirin before 15 weeks. If you have a patient after 15 weeks, you cannot eat, I don't know the name in English, but it doesn't work. So the first trimester screening issue is to do prevention possible and more accurate. The ASPRATE trial, you can see it, read it, 2017, a very huge study in which Professor Nicolaides showed that when you detect, you screen patients at high risk of preeclampsia, and you give aspirin with the dose and before 15 weeks, you will be able to prevent more than 80% of early onset preeclampsia. Remember, we are at the first trimester of screening. And if you give it until 62% before 37 weeks. The admission to neonatal unit cares also is decreased of 68%. So, and a cost per screen about, you see the difference, huh? This to show that they're really saving money. So, prevention of preeclampsia by aspirin more than 100 milligrams at onset before 16 weeks. The reduction in preeclampsia before 32 weeks up to 90%. In preeclampsia before 34 weeks up to 80%. Before 37 weeks up to 65%. Reduction in abruption, 30%. Reduction of admission in neonatal unit care, up to 65%. So in our settings, in low-income countries, I'm convinced that it's very important to know, and you will save not even economics and money, but you will save lives, mother lives and baby lives. How did we do in our hospital in Tunis? It was a huge work for me, but I'm really happy to have been able to do that. We could implement this screening via my research lab. So just to give you an idea of the cost in Tunis, I'm talking. Patients now come, maximum they pay between $3 and $10, but it's with the research lab, with the help of the research lab. We included 1,024 patients. Until now, only 453 delivered. The detection rate of early preeclampsia was about 4.4%. For all those patients, we proposed taking aspirin between 100 and 160%, because in Tunisia we have these two dosage. Before 14 weeks. After 14 weeks, we don't give, of course. And since I don't have time, I just put the most important data compared to what I showed you for the first group who came with preeclampsia. You see that in this group, maternal complication rate decreased, and we had just mild complications, just new onset of HELP syndrome, for example, some proteinuria, some edema, 13%. We, alhamdulillah, had no maternal mortality, no intensive care unit stay. Only 2% of our neonates were admitted in our unit care units. Fetal complication rate, if you remember, we were about 40%. Now we have 10%, with 3.3 small for gestational age, 1.2 neonatal death after birth. So you see clearly the difference, and once we will finish this study, we'll be able to give you official results with statistics. So take-home messages. What's the added value of first trimester screening? Today, it allows, and in our study, it showed that it allows early detection of high-risk pregnancies, very early detection of preeclampsia onset, because once you know that this patient is at high risk, even if you give her aspirin, you will follow her and you will do a triage. It won't go very fast, very far, and you will survey her until delivery more accurately. We are doing better prenatal care, of course, and it allows survey triage, maternal and neonatal mortality and morbidity reduction, and this is real in real life in a poor, low-income country. So that's why I'm sharing this experience with you. I think every one of us as obstetricians, when you know this, you cannot tomorrow say, I don't know, and I won't give this proposal to my patients. I think this is the last slide. So if we look to prenatal care strategies, generally in all congresses, we talk about screening for trisomy 21, which now it should be done in the first trimester or in second trimester. We talked about NIPT this morning. At the end, maybe it will result in pregnancy termination. But in this case, our issue is really different. Here you have the possibility to propose first trimester screening and to manage this and to save lives. And you all know the importance of saving lives, even in our religion, more than the fact that we are doctors, and this is a mission for us. And even if the patient comes after, and you are able to do second and third trimester ratio to avoid maternal and fetal complication. So I have to tell you that it was a huge study. These were huge studies. We made many efforts. I want to thank every person who helped me in Tunisia and Tunis. Here we have about, we are 13 Tunisian doctors here with my young students. I'm proud of them. It's not obvious to do all this, but I'm very happy to be able to share it with you. Voila. And this is the baby. Thank you. Voilà.
Thank you very much.
Sorry for the time.
So it's okay. Thank you very much for Professor Delinda. I know it is very hot topic, but we will postpone discussion after the next presentation, please, just to save time. And the next speaker. The next speaker is Professor Mustafa Fouad, Ain Shams University professor, and he is one of the very pioneer and eminent, and he's ascending in the sky like the rocket. Dr. Mustafa Fouad will present for us update in fetal growth restriction management. Please, Dr. Mustafa.
Good afternoon, my dear colleagues and professors. At first, I'm very happy to be with you in such an honorable meeting. And I'm going to discuss a very debatable issue in the practice of fetal medicine, which is intrauterine growth restriction. What's the trouble with IGR? What's the trouble of being born small? Being born small is a real threat because our observations have proved that being a small fetus means that you are at risk for intrauterine fetal death, and you are at risk for perinatal brain injury, and you are at risk for intrapartum fetal distress. When all of us, the experts in fetal medicine and general obstetricians, when you are doing your scan and you find that the baby is lagging behind, the first thing that is going to slap your mind is this baby in IGR? Is this baby going to die or not? This is the first question we all ask. Moreover, we discovered that impaired fetal growth is going to cause impaired fetal programming and is going to cause later complications in adulthood. And so, prenatal identification of small for gestational age babies is very important to prevent stillbirth and to prevent adverse fetal outcomes. From our basic studies, basic education, IGR, we say that symmetrical IGR, asymmetrical IGR is placental insufficiency, symmetrical IGR is congenital anomalies, and go. But does it really work when you manage your patients? Unfortunately, no. Most small for gestational age babies, they pass unnoticed until we are suddenly fronted with stillbirth. And there is a lot of publications identifying that the most common cause of unexplained stillbirth is improper detection of a small for gestational age fetus. Also, we have to confess that the true identification or true specification of true fetal growth restriction and small for gestational age is not as easy as we expect. Not all small for gestational age fetuses are just constitutional. And also we have a lot of variability while managing fetal growth restriction. Every center is going to manage fetal growth restriction according to his own guidelines. So the first step when we find a small for gestational age or a small fetus is to differentiate, is it a true fetal growth restriction or a constitutional small for gestational age? In general, we know that true fetal growth restrictions is associated with Doppler signs suggesting hemodynamic redistribution as a reflection for fetal hypoxia. But the term small for gestational age, we usually use it to just specify a subgroup of small fetuses that do not have hypoxia and hemodynamic changes. And for many years, we depended on umbilical artery Doppler for identification of those fetuses. For almost 20 years, the whole practice depended only on umbilical artery Doppler. However, we discovered lately that depending on umbilical artery Doppler is not totally efficient, because our observations has led that umbilical artery abnormalities are just a reflection for severe placental disease, and umbilical artery abnormalities fails to pick up mild placental disease, which actually constitutes a good sum of early onset fetal growth restriction and almost all cases of late onset fetal growth restriction. So umbilical artery Doppler can't be used alone for identifying true fetal growth restriction. Through the last 2 decades, evidence has demonstrated that small for gestational age fetus defined solely by only umbilical artery pulsatility index abnormalities have poor perinatal outcomes than normally grown fetuses. Thus, umbilical artery Doppler cannot be used to differentiate. So how we are going to differentiate? We have to extend the definition of true fetal growth restriction. It's not a single parameter to define fetal growth restriction. And we have 4 other parameters that we can depend for actually defining true fetal growth restriction. The first is cerebroplacental ratio, which is calculated by dividing the middle cerebral artery pulsatility index over the umbilical artery Doppler pulsatility index. This ratio is more sensitive than using umbilical artery alone or the middle cerebral artery alone. The second one is using uterine artery pulsatility index. And we found that a lot of patients with small for gestational age having normal umbilical artery Doppler, they do have abnormal uterine artery Doppler, which represents an early manifestation of placental insufficiency. The third one is having very small estimated fetal weight. We define fetal growth restriction for a long time by the fetus below the 10th percentile. Expected fetal weight is less than the 10th percentile. But especially, adverse outcomes are seen with estimated fetal weight less than the third percentile. Thus, the definition of fetal growth restriction should be extended, not depending only on abnormalities of umbilical artery Doppler, but we should extend and use all the other 3 parameters. What happened when we used these parameters? Did it affect our practice? These figures were published in Fetal Diagnosis and Therapy Years 2014. Just look at gestational age 40 weeks. When we depended only on the umbilical artery Doppler, no fetus was diagnosed to have an IGR. But when we extended the definition of fetal growth restriction using either one of the 3 other parameters, almost about 80% of the fetuses were discovered to have an IGR. This is how we do have some cases of stillbirth that we say that they are unexplained. Actually, they are not unexplained. They are just complications of early placental dysfunction. So literature began to divide IGR to two phenotypes: early onset IGR and late onset IGR. Fetal growth restriction is definitely caused by placental insufficiency. But when did this placental insufficiency begin is the issue. Is it started early or started late? Differentiating between both types is very important for both research purpose and for clinical purpose. What about early onset intrauterine growth restriction? It represents 20 to 30% of cases of IGR, while late case onset of intrauterine growth restriction represents 70 to 80% of IGR. And this is the main issue. In our routine practice, diagnosing early IGR is not a great deal. Everyone is not going to mistake an early onset IGR. But almost all of us are going to miss one day a late onset IGR. And this is the most common cause of unexplained stillbirths. What's the challenge in early cases of onset IGR? The real challenge in the management. When you have an IGR case that's 26, 28, or 30 weeks, the real issue, what I'm going to do, when I'm going to deliver, how I'm going to follow it up. But in late cases of IGR, the main issue is how to diagnose. Are you going to miss or are you going to diagnose? The etiology of early onset IGR is mainly severe placental insufficiency. For late onset IGR, it's mild placental insufficiency. It's a mismatch between the growing fetal demands and the placental capabilities of supplying this demand. Another important thing is fetal tolerance. Preterm fetuses, they are capable of tolerating high rates of hypoxia because of the accelerated maturation of the suprarenal gland. While large or mature fetus has a low tolerability to hypoxia. And so cases of intrauterine fetal death are much more common with late onset IGR than early onset IGR. Fetal adaptation. In cases of early onset of IGR, because the case is severe, there is high incidence of prolonged hypoxia and prolonged acidosis, we are going to have systemic cardiovascular adaptation. But in late cases of IGR, is not going to reach the stage of systemic cardiovascular adaptation, just the central cardiovascular adaptation. The prognosis for early onset IGR, we have high rates of mortality and morbidity. Although for late onset IGR, if we compared it with early onset, it's of less mortality, less morbidity, but the important issue, it is the most common cause of stillbirth. And it's a very common cause for long-term complications later on. What's the gestational age for demarcation between early and late? We have a lot of gestational age, a lot of literature. Some say, some trying to define it at 37 weeks as the time of delivery. Some say it's 28 weeks. But the EFMF-ISUOG recommendations and the authors of the publications, they recommended the use of 32 weeks at the onset of diagnosis to be the demarcation between early and late onset IGR. For hypertensive disorders of pregnancy, it's common with early onset of IGR, but it's not common with late onset IGR, mainly because it's some sort of placental trophoblastic tissue invasion disorder. So at first, it's going to cause placental insufficiency, and then the systemic disease that is going to cause hypertension or preeclampsia during pregnancy. How are we going to diagnose early onset IGR? For diagnosis, we are going to diagnose early onset by abdominal circumference or expected fetal weight less than the 3rd percentile, or when we have an umbilical artery Doppler with an absent end diastolic flow. Any one of these two things is going to diagnose early onset IGR. Or we have an abdominal circumference or estimated fetal weight less than the 10th percentile, which is the original or the old definition, combined with uterine artery pulsatility index more than the 95th percentile and or umbilical artery pulsatility index more than 95th percentile. This is the criteria for diagnosis of early onset IGR. For late onset IGR, and actually this is my main concern because in our practice, we faced many cases of sudden unexplained intrauterine fetal death at term. And we don't know why. We didn't know why. We didn't have an explanation. I believe this is the explanation. All those cases, or most of them, were just the late cases of IGR, and we didn't diagnose them. How are we going to diagnose these cases? When abdominal circumference or expected fetal weight is less than the 3rd percentile, or at least 2 out of the following 3 criteria: the abdominal circumference, expected fetal weight at the 10th percentile, or the rate of growth of the abdominal circumference or the expected fetal weight is retarded, or when the CPR, the cerebroplacental ratio, is less than the 5th percentile, or uterine artery pulsatility index is less than the 95th percentile. After diagnosis, how are we going to manage? In order to design a proper plan for management, we have to understand what's the hemodynamic changes that occurs in these fetuses, because they are different. In cases of early fetal growth restriction, we have 4 stages. The first stage is placental impedance of blood flow, and is going to be manifested clinically by just impaired uterine artery pulsatility index, and later impaired cerebroplacental ratio. And after this, after the start of placental insufficiency, they are going to be fetal adaptation. This fetal adaptation is going to be manifested at first by central adaptation. That's going to be manifested by umbilical artery Doppler pulsatility index and middle cerebral artery pulsatility index. And then the umbilical artery is going to be severely impaired, and we are going to have an absent end-diastolic blood flow. With the absence of end-diastolic blood flow, we have entered the severe stages of intrauterine growth restriction. And we are going to have the peripheral systemic vascular compensation with advanced hypoxia and the occurrence of acidosis, which is going to be manifested clinically by umbilical artery reversal blood flow, aortic isthmus impedance more than 95th percentile, and abnormal ductus venosus just increased pulsatility index above 95th percentile. At terminal cases with serious injury, serious brain insult, the baby is impending to die, we have reversal ductus venosus blood flow, or when short-term variability detected by the computerized CTG is less than 3, or the biophysical profile calculated to be less than 4, or the conventional CTG shows unprovoked prolonged decelerations. This means that the baby is about to die and almost he has brain injury. This is the case with late onset IGR, but what is the with early onset IGR? But what is the case with late IGR? In late IGR, we have only 3 stages. A placental disease with reduced placental reserve. It's going to manifest by uterine artery pulsatility index more than the 95th percentile, or impaired cerebroplacental ratio. And then compensation is going to be central compensation, going to be manifested by middle cerebral artery pulsatility index and aortic isthmus pulsatility index impairment. Then we are going to proceed to the stage of acidosis, hypoxia, injury, and death. And this is not going to manifest except by aortic. There's no ductus venosus changes here. Just aortic isthmus impedance impairment and CTG decelerations. So we have four stages in cases of early onset of IGR and 3 stages in case of late onset IGR. What are the tools for diagnosis and management? We have an umbilical artery Doppler. What's the role of umbilical artery Doppler? Umbilical artery Doppler do have a diagnostic and a prognostic role. Umbilical artery Doppler has a great clinical value for identification of fetal growth restriction, alone or in combination with impaired CPR. And it was proved that using umbilical artery Doppler in follow-up of cases of IGR has led to 29% reduction in perinatal deaths. In extreme cases with absent or reversed end diastolic flow, it occurs 1 week before acute deterioration and fetal death, and it almost occurs in 50% of cases of fetuses with acidosis. After 30 weeks, the risk of stillbirth of a fetus with reversed end diastolic blood flow overcomes or overweighs the risks of prematurity. So it is justified to deliver fetuses with reversed end diastolic blood flow after 30 weeks. This is the value of umbilical artery Doppler. What's the role of middle cerebral artery Doppler? Middle cerebral artery Doppler, as we know, it reflects brain vasodilatation. It's a late manifestation occurring in early fetal growth restriction. And we improve its performance when we add it to the umbilical artery in the CPR ratio. Middle cerebral artery is of a great importance for identification and prediction of outcome in cases of late fetal growth restriction, especially in cases of late fetal growth restriction with normal umbilical artery Doppler. What about the cerebroplacental ratio? Its role is mainly diagnostic. The CPR remarkably improved the sensitivity of both the umbilical artery and middle cerebral artery in defining resistance to blood flow. In late, small for gestation age fetus, abnormal CPR is present before delivery in 20 to 25% of the cases and is associated with high risk of adverse outcome. So it has a role, a diagnostic role in late fetal growth restriction. What about ductus venosus? The ductus venosus Doppler is the strongest single Doppler for diagnosing impending intrauterine fetal death in cases of early onset IGR, not late IGR. Absent or reversed A wave is associated with high perinatal mortality, from 40 to 100% in early onset IGR. A ductus venosus pulsatility index above the 95th percentile is associated with high risk, but still less than reversal of blood flow. Abnormal ductus venosus is the event that precedes abnormal CTG and loss of the short-term variability. And in about 98%, it occurs 2 days before abnormal biophysical profile. And so ductus venosus is very important in timing, in planning the timing of delivery in severe cases of early onset IGR. And what about aortic ethmus Doppler? Aortic ethmus Doppler is associated with increased fetal mortality and increased fetal neurological disabilities, especially in early cases of IGR. Reversed aortic ethmus Doppler is a sign of advanced deterioration, and it's the next step after abnormal medial artery Doppler and abnormal middle cerebral artery Doppler in early cases of fetal growth restriction. The abnormal aortic ethmus Doppler can be found in a very small proportion of late onset fetal growth restriction, and so we don't depend on it, neither in diagnosis nor in treatment of late fetal growth restriction. What about fetal heart analysis? With the conventional CTG, and actually this is the main trouble in our country, in Egypt. In our country, we are a low resource country, and we depend only on conventional CTG. And unfortunately, abnormal CTG, conventional CTG, is a very late sign. When you have a fetus with an IGR and you have prolonged decelerations or lost beat-to-beat variability in the conventional CTG, this means that almost this baby about 4 to 60% has 4 to 60% chance of neurological disabilities. But if we have a computerized CTG which can accurately detect the short-term variability, we can use it instead of ductus venosus Doppler in determining acute fetal distress. What about the biophysical profile, which is calculated by the assessment of fetal tone, respiratory and body movements, amniotic fluid index, and the conventional CTG? Actually, a recent meta-analysis has proved that it has no benefit in management of high-risk cases. But in countries like our country, still we can depend on it because we don't have a computerized CTG, and we not in all our hospitals there is the expertise of doing a ductus venosus Doppler. For amniotic fluid index in longitudinal studies, early onset IGR fetuses have shown that amniotic fluid index progressively decrease, and it occurs 1 week before the acute deterioration in 20 to 30% of cases. But we have limited evidence for just taking a decision of delivery depending only on the amniotic fluid index. After defining our tools, how we are going to integrate these tools and our information in a management plan. The authors of this publication have suggested this staged management approach. They classified fetal growth restriction into 4 stages. First, second, third, and fourth. What's about the first? The first is a small fetus with mild placental insufficiency, diagnosed by expected fetal weight less than the 3rd percentile, CPR less than the 5th percentile, umbilical artery pulsatility index more than the 95th percentile, middle cerebral artery pulsatility index less than the 5th percentile, uterine artery pulsatility index more than the 95th percentile. How we are going to manage those fetuses? You are going to monitor weekly. And when we are going to deliver? You are going to deliver when they reach maturity at 37 weeks. And we can use labor induction under continuous electronic fetal monitor. And this has led to the lots of publications now that in many centers, they used to induce labor at 39 weeks. They don't want to wait for 40 weeks because of the increased complications with expected management at 40 weeks. Why did they change their mind? They changed their minds because a lot of cases have this late onset IGR. And it's now recommended that when you diagnose this late onset IGR, it's better to deliver at 37 weeks. Stage 2, when we have severe placental insufficiency, diagnosed by umbilical artery absent end diastolic flow, or ductus venosus pulsatility index more than the 95th percentile. We are going to follow these fetuses bi-weekly. We are going to deliver by 34 weeks and definitely by cesarean section. Stage 3 is a fetus with low suspicious to be acidotic. We are going to suspect this acidosis by a reversed end diastolic blood flow in the umbilical artery and ductus venosus pulsatility index more than the 95th percentile. We are going to keep an eye on this baby every day, at most every 2 days. And we are going to deliver by 30 weeks by cesarean section. In cases with high suspicion of fetal acidosis, which is going to be diagnosed by ductus venosus reversal with a computerized CTG showing very low short-term variability less than 3, or with the conventional CTG, we have unprovoked, spontaneous, prolonged decelerations. We are going to follow up this fetus every 12 hours, and we are going to deliver this baby by 26 weeks by cesarean section. This is a flow chart suggested by the author for this stage management of IGR. This stage management, just follow up and delivery. But are there any interventions that we can do? We are going to talk about corticosteroid prophylaxis to enhance lung maturity. All available guidelines on early fetal growth restriction, they recommend corticosteroid prophylaxis if delivery is expected to be before 34 weeks, except for the Royal College. They extend the duration for prophylaxis. We can extend it up to 35 weeks, 35 weeks plus 6 days. But we have to stress that in fetuses with absent or reversed umbilical artery blood flow, we have to do enhanced daily surveillance during steroid administration. What about magnesium sulfate? We have a good evidence in the literature that magnesium sulfate do have effect in protection of neurological deficits. But the question is when to start. Actually, we don't have a formal guideline when to start magnesium sulfate prophylaxis. We have a lot of literature talking about 32 weeks, some others less than 30 weeks, some other less than 29 weeks, and I guess it's going to be per protocol, per your protocol, per your hospital protocol. An important issue is how to manage late small for gestational age, even with a normal umbilical artery Doppler. Because as I just said, some cases with late small for gestational age and normal umbilical artery Doppler are actually suffering from an early placental disease. And they are at risk of late neurodevelopmental effects and stillbirth. Some small for gestational age fetuses may suffer of stunted growth that's not adequately identified by the current biophysical profile tools. So it is reasonable to consider delivery after 38 weeks of gestation and don't exceed 39 weeks to reduce the risk of severe fetal growth restriction or stillbirth. In cases of small for gestational age diagnosed late, fortnightly assessment of fetal growth and weekly assessment of umbilical artery pulsatility index, middle cerebral artery pulsatility index, and cerebroplacental ratio is recommended. And when you deliver those babies, they are high-risk babies. They should be under continuous electronic fetal monitoring during labor. It's a very debatable issue, and we have a lot of unanswered questions. What do we need in the future? In the future, we need preclinical detection of such group of small for gestational age babies suffering from placental insufficiency but do have normal Doppler indices. The second thing we need is an actual intervention for improving the blood supply for those babies. And we have a lot of ongoing trials on such interventions. One of them is the Strider trial, which is studying the efficacy of sildenafil. We have about 6 to 7 trials studying the effect of statins on delaying IGR, such as pravastatin or simvastatin. We have the Everest group who are studying in utero gene therapy using vascular endothelial growth factor in cases of IGR. And we need homogeneous application of Doppler indices. Actually, we don't have cutoff values for the Doppler indices to diagnose, and we don't have actual reference ranges for proper monitoring and time delivery for fetal growth restricted fetuses after 32 weeks. And still, we are just talking about what's known as late onset IGR, but we don't have clear guidelines for managing those fetuses. And the question is whether earlier delivery of fetuses with late fetal growth restriction can improve the outcome, or it may impair the outcome by inducing late prematurity. This question needs to be answered by more randomized controlled trials. And thank you.
Thank you very much for Dr. Mustafa for his very nice, tough, hot topics. And now we are open discussion for 15 minutes for Dr. Delinda. Can you speak, please? Yes, first question. Yes, please. Can you give him a mic, please?
Thank you very much for giving me the opportunity. الشكر موصول لأخواننا المصريين محمد عبد الرحيم من السودان. in the very definite, confirmed value of the test of the ratio, and in the absence of the test in my country. Is it valuable to give empirical aspirin without having this test? We cannot say no more, we don't know the test. We know the test, but we don't have it. This is number one. Number two, the dose of aspirin in your study is 150. According to our previous knowledge, according to the CLASP study of aspirin, it is between 60 and 80 milligrams. And we know that a non-steroidal anti-inflammatory drugs, whatever it is, they can cause kidney spasm and oligohydramnios. Are you sure that doubling the dose has no influence on that? Thank you very much.
Thank you. I begin with the second question. What I showed you are not my recommendations. These are the recommendations of the FIGO, the International Federation of Gynecology and Obstetrics. And there is these results result from the ASPRE trial, which studied the dose and the efficacy of the dose on hundreds of thousands of patients. So this is an international recommendation, the dose. They studied at least it should be 75 at least, at maximum 150, 160 maximum. But the recommendations for now, it's 100 or 150, depending on what you have in your country. And in the evening, it shows better results. For the first question, I'm not sure I have understood everything. So you asked about the ratio. If you don't have the ratio, that was the question?
No, if he doesn't have the opportunity to just to ask for the test because it's very expensive, should we give aspirin as a routine? His question.
We go back to the recommendations of the FIGO. It's not recommended to give systematically aspirin for everyone. So the ratio, you will need it once things are here, once you are in front of a preeclampsia. But aspirin would prevent at first trimester. It's completely different. So if you don't have anything else to do, I cannot advise you to give aspirin, sure, because now today you have publications, and I don't know if in your countries, but now people, even in Tunisia, begin to ask for legal, I don't know the name in English, but medical legal problems, and you can have problems then. If you give aspirin to someone and she will have complications and she doesn't need aspirin, you will be responsible.
Okay.
The price, just the price, but we will discuss after. For the price is after?
After, yes, please.
Okay.
Can I have a comment on this question? They mentioned in order to give an aspirin, or in order to have the test, we have a risk group patient. If I think, in my opinion, if we don't have the facility to have this test, like nowadays, we have many risk factors. History of previous preeclampsia, or history of an elder primary gravida, or very young primary gravida, one in the family with history of preeclampsia. This can justify to give the aspirin, but as you said, in the proper timing, before 15 weeks, till we have the facility to ask for the test to be available for everybody.
Exactly. And if you go on the website on the FMF, Fetal Medicine Foundation, you will find everything. It's free. And you will see the medical history, the questions you have to ask for. But this will detect about 50%.
Oh, thank you very much. Yes, please.
60 to 80, and your findings. There is tremendous improve in the outcome if you give your dose. Is it due to the dose, that because you increase the dose, or is it because, I don't know? You did not understand my question?
You are talking about the study of screening, first trimester screening? Our study in the first trimester screening?
The clasp study says that aspirin does not prevent preeclampsia. Aspirin may reduce the severity of the preeclampsia.
Yes.
Aspirin may not prevent, either may reduce the severity or reduce the onset of preeclampsia. This is what
it reduces also preeclampsia.
Like in your study, it gives very fantastic result. Is it due to the increase in the dose, or is it in a new opinion about aspirin usage?
I don't find that in our study things are very different. That's what I said. Now we are not able to give statistical analysis because the amount of patients who delivered is still low. But for now, what the value, what we learned more is that when you do this screening and you saw your patients, you see your patients in the first trimester, you do better management and better healthcare. I think that's the most important thing. So maybe we will detect earlier, we will see complications before they are more important, you see? That's what I said.
Excuse me, can I have a comment? Sorry. I think our aim as a gynecologist and obstetrician, it's now we cannot prevent preeclampsia, but at least we are seeking how to prevent the complication, how to be early diagnosis, how to interfere early, how to save mother, how to save baby. If we achieve this, we can implement using aspirin and also the recommendation to give second level management Clexane, or sorry, low dose, low molecular weight heparin. We are aiming in the present time just to decrease the complication, early diagnosis, late development of preeclampsia in order to reach the maturity of the baby. So we are saving mother and baby with the new drugs. We are in the same way by thinking. Next question, please. Okay, thank you very much for Dr. Delinda and Dr. Mustafa. Thank you very much for you. Thank you very much. Thank you very much. We are now moved to the third plenary session. Thank you very much.
مساء الخير. باسم فتحي برودكت مانجر نرهادو انترناشونال. طبعا ثانكس دكتور محمد كمال ان هو give us the chance ان احنا introduce the most two innovative technologies in the Egyptian market. اول حاجه التكنولوجي المالتي امينو اسيد كليشن تكنولوجي، ودي اللي بتتميز بيها شركه نرهادو الحقيقه. التكنولوجي الثانيه هي the most recent technology في الايجيبشن pharmaceutical market، هي تكنولوجي الاو دي اف او الاورال ديسبيرسبل فيلم تكنولوجي. لو بدانا باول تكنولوجي هي المالتي امينو اسيد كليشن تكنولوجي. why introducing multi amino acid chelated minerals? The journey of traditional salt like ferrous sulfate or calcium carbonate, this journey الحقيقه هنلاقي ان في منها اكتر من مشكله، زي مرحله الكوست، مرحله الويست، مرحله الكومبلين. يعني مثلا لما الافيلابل كالسيوم سبلمنت او الفيرس سبلمنت اللي موجوده، هنلاقي مثلا حاجه زي الفيرس سلفيت، وانس ان هو بدا يدخل الاستومك هنلاقي ان الاتش سي اللي بيبدا يعمل له ايونايزيشن، يفصل الكاتاين عن الاناين، الاف اي بوزيتيف تشارج في الحاله دي بيبدا يتفاعل منه 80% مع حاجات انتي نيوتريشنال فاكتورز، زي مثلا هنلاقي التنيتس this make complex with iron or calcium or other divalent metals. Again مثلا الاوكزاليتس in tomatoes and chocolate برضه بتعمل كومبلكس مثلا مع الايرون والكالسيوم بشكل كبير جدا. 80% من الكميه دي بيحصل لها اكسكريشن، وبالتالي دي مرحله الويست. المرحله الثالثه هي مرحله الكومبلين. ده كله لما البيشنت بتبدا تاخد فيرس سبلمنت او كالسيوم سبلمنت، وبالتالي النيوتريشن فاليو اللي بتعود على البيشنت بتكون قليله جدا، واخرها هي مرحله الكومبلين. الكومبلين دي اللي بتخلي البيشنت البريجننت وومن لما بتاخد ايرون سبلمنت 89% منهم نتيجه السايد افكت بيديسكونتينيو التريتمنت ده. علشان كده كان لازم نقدم تكنولوجي في الماركت المصري مختلفه عن السولز اللي موجوده، وهي المالتي امينو اسيد كليتد ايرون او كالسيوم. الفكره بمنتهى البساطه، الايرون از امبيدد ان 18 امينو اسيدز لايك كيج از يو لايك. بيبتايدز في الحاله دي هي بتتعرف ان هي بيبتايدز. البيبتايدز تقدر تعمل بايندنج بشكل كويس جدا، وبتزود السوليبيليتي بتاعه الايرون او الكالسيوم او اي داي فالنت ميتال هقدم في ال 18 امينو اسيدز دول. الميزه في كده ان وانس ان الايرون او الكالسيوم بقى امبيدد جوه 18 امينو اسيدز، ده بيخلي الابزوربشن بتاعه ثرو حاجه اسمها بيبتايد جيت. بيبتايد جيتس دي موجوده along ذا هول اوف انتستين، على طول الانتستين مش بس في اول جزء من الانتستين، وبالتالي ده بيساعد الابزوربشن بتاع البرودكتس اللي بتتقدم بشكل مالتي امينو اسيد سواء ايرون او كالسيوم، بتوصل النسبه بتاعته ل 95%. البرودكت اللي احنا بنشرف ان احنا نقدمه النهارده بتكنولوجي الكليشن او المالتي امينو اسيد كليشن هو الفيروترون. الحقيقه الفيروترون بيقدم فورمولا مميزه جدا، ايرون زنك كوبر موليبدينم وفيتامين بي كومبلكس، الوحيد في الماركت اللي بيقدم المينرالز كلها بتكنولوجي المالتي امينو اسيد كليشن. الكالسيترون كمان هو الوحيد اللي بيقدم ككالسيوم سبلمنت از ا مالتي امينو اسيد كليتد كالسيوم، مش بيأثر على الاسيديتي بتاعت الاستومك ولا محتاج الاسيديتي بتاعت الاستومك، علشان طبعا زي ما حضراتكم عارفين معظم البرودكتس اللي بتتقدم ككالسيوم سبلمنت عباره عن كالسيوم كربونات. كالسيوم كربونات مينلي هو اول لما طلع كان انتاسيد وبالتالي بيأثر على الاسيديتي بتاعت الاستومك. كالسيتون لا، مينلي كالسيوم سبلمنت هو الوحيد اللي تكنولوجي المالتي امينو اسيد كليشن. كالسيتون كالسيوم مغنيسيوم برضه عشان المصل كرامب، بوتاسيوم فوسفورس زنك منجنيز بورون سيليكون كوبر وفيتامين اي ازا بيتا كاروتين وفيتامين دي وفيتامين سي. ذا موست ريسنت تكنولوجي كمان بنقدمها مش بس المالتي امينو اسيد كليشن، هي تكنولوجي الاو دي اف، ودي ذا موست ريسنت تكنولوجي في الايجيبشن ماركت. او دي اف اختصار اورال ديسبيرسبل فيلم. التكنولوجي دي از يو سي كده ان هي فلات اند سين فيلم، ده according to WHO. once contact للسلايفا بيبدا يحصل لها rapid dissolution والابزوربشن بتاعها بيكون من خلال البقه الميوكوزا. دي بتكون ميزه كويسه جدا once ان انا محتاج حاجه ليها rapid onset of action. يعني لو جينا نبص على الاو دي اف تكنولوجي وورلد وايد هنلاقيها تقريبا في كل العالم. الحقيقه شرف لينا يعني ان احنا في مصر من خلال شركه نرهادو ان احنا نبقى اكسكلوزيف في المينا ريجن كلها وافريكا، ان احنا نقدم التكنولوجي الاو دي اف او الاورال ديسبيرسبل فيلم دي. ايه الميزه بتاعه التكنولوجي؟ هي يعتبر شورت كات ديليفري سيستم، لان انا باختصار انا عايز اوصل لحاجه ليها رابيد اونس اوف اكشن بدون ما اعدي على الجي اي تي والديجريديشن اللي بيحصل فيها من خلال البقه الميوكوزا. حضراتكم عارفين طبعا ان المنطقه سب لينجوال بتكون هايلي فاسكولارايزد، البرميبيليتي بتاعتها عاليه جدا، وبالتالي وانس ان انا بستخدم الاو دي اف ده بيكون ليها immediate اكشن طبعا بايو افيلابيلتي، والاكشن هيبقى افضل بكتير جدا واسرع. زي ما قلت لحضراتكم ببعد تماما بقى بالتكنولوجي عن الجي اي تي والديجريديشن اللي بيحصل فيها. وانس ان انا محتاج حاجه ليها رابيد اونس اوف اكشن، اعتقد اصعب حالات حضراتكم بتقابلوها وهي حالات النوزيا اند فوميتنج اوف بريجنسي اللي بتمثل تقريبا 80% من البريجننت وومن. بنتكلم ان 80% منهم بيكونوا عندهم النوزيا اند فوميتنج تقريبا طول اليوم. لو بصينا على الجايد لاينز حاجه زي الرويال كولج 2016 قالت ان الفيرست جينيريشن انتي هيستامين هي الفيرست لاين انتي ايميتكس اللي بنكتبها، وهي اكتر حاجه سيف واكتر حاجه افكتيف وببدا بيها في الان في بي عموما. ان الفيرست جينيريشن انتي هيستامين هي اكتر حاجه سيف. كان في مشاكل من الفيرست جينيريشن انتي هيستامين، يعني مثلا البريجننت وومن عموما اللي عندها نوزيا فوميتنج بيبقى عندها دايما مشكله في السوالوينج، عندها كمان محتاجين حاجه ليها ليديد اونس اوف اكشن، كل اللي موجود محتاج 3 ساعات او 4 ساعات علشان يقدر يعمل كنترول للنوزيا والفوميتنج دي. كمان كلها ليها شورت ديوريشن اوف اكشن الحقيقه. علشان كده احنا حلينا المشكله، هنقدم الميكليزين هيدروكلورايد في ببرودكت اسمه ميكليزيجو كميكليزين هيدروكلورايد. هو الوحيد في الماركت اللي فيرست جينيريشن انتي هيستامين، يعني وزن الجايد لاينز هو فيرست لاين انتي ايميتك، بس بتكنولوجي الاو دي اف او افلام سريعه الذوبان دي. وانس ان هو كونتاكت للسلايفا بيبدا يحصل له رابيد ديسوليوشن ويحصل ابزوربشن من خلال البقه الميوكوزا، وبالتالي في خلال 10 minutes اكشولي هو يقدر يعمل كنترول للنوزيا اند فوميتنج دي. اعتقد مفيش برودكت تاني يقدر يعمل التكنولوجي، لان هو الميكليزيجو هو الوحيد اللي بتكنولوجي الاو دي اف، وبالتالي دي هتبقى very effective treatment. هو الوحيد اللي هيستامين اتش 1 انتاجونست، وبالتالي هو الوحيد اللي فيرست لاين بتكنولوجي الاو دي اف. ستاديز كتير طبعا اتعملت على الميكليزين عموما والميكليزيجو، يعني بدات حتى من الستينات زي ما حضراتكم شايفين كده. يمكن اخرها واكبر عدد فيها كانت سويدش ستادي involving more than 18,000 women treated with ميكليزين during the first trimester. الحقيقه الدراسه دي ما لقيتش اي اسوسيشن بين اي malformation حصل من استخدام الميكليزيجو. تكست بوك زي drugs during pregnancy and lactation 2015 اتكلم ان هو ميكليزين is indicated للنوزيا and vomiting of pregnancy. كمان ميكليزين سيف وليس سيديتنج حتى مقارنه بباقي الكونستيتوينتس بتاعت الفيرست جينيريشن انتي هيستامين، فبالتالي البريجننت وومن لما بتستخدم الميكليزيجو هتقدر تمارس الديلي اكتيفيتيز بتاعتها بشكل افضل من الاوائل من الفيرست جينيريشن انتي هيستامين اللي كان فيها سومنولنس وسيديتنج بشكل قوي جدا. كمان ميزه ان هو بيقعد اب تو 24 ساعه او الديوريشن اوف اكشن بتاعه، وبالتالي دي هتبقى ميزه ان انا ممكن في حالات المايلد او مودريت اكتفي بوان فيلم بس من الميكليزيجو. اخيرا الميكليزيجو طبعا كده ليه الترا رابيد اونس اوف اكشن كنترولينج النوزيا اند فوميتنج، نو نيد فور ووتر، ودي نقطه مهمه جدا لان حالات كتير حضراتكم تاكدوا لي برضو ان وانس البريجننت وومن اللي عندها نوزيا وفوميتنج لما بتاخد نفسها الووتر في حد ذاتها ممكن تكون نوزييتنج ليها. هو لسه ديتنج فورمولا الحقيقه الميكليزيجو. كمان ايزي ادمنستريشن والديوريشن اوف اكشن بتاعه اب تو 24 ساعه. ثانكس لحضراتكم جدا. لو في اي كويشن على الميكليزيجو او التكنولوجي الكليشن تحت امركم. شكرا لحضراتكم.
شكرا لحضرتك وشكرا لشركه نرهاد وانها قدمت لنا هذا البريفنج.
شرف لينا ودايما من نجاح لنجاح.
لو ما حدش عنده اي اسئله نرهاد ممكن نبتدي السيشن الثالثه.
شكرا.
يسعدني ويشرفني I'm deeply honored to introduce Professor Dr. Subhi Abullouz, Professor of Obstetrics and Gynecology at Ain Shams University, the professor. And he's my own professor. And this is somebody I don't have to introduce because everybody knows him, not only through conferences and lectures, but through Facebook, Instagram, and everything. And the talent of Professor Subhi Abullouz an extremely difficult to achieve and a role model for everybody in Ain Shams University. And today he's going to give us a speech about emergency hypertension. Please, Dr. Sahri. Thank you.
Good evening for everybody. I would like to thank all the organizers for this very nice, successful meeting. My topic today is about severe hypertension, malignant hypertension, alarming hypertension, hypertension crisis, emergency, urgency, fulminating hypertension. All these terms about the risk on the mother and the fetus and on the community. We know why we are interested in this topic, because it is one of the serious causes of morbidity and mortality. We know that morbidity and mortality have many underlying causes, one of which is the severe hypertension. Either you see toxemia, ABH glucosis, hypertensive disorders, all these things, that is a serious disease. Can be diagnosed early, can be prevented or minimized on its risk factors later on. Emergency, that the hypertension is high, 180 systolic, 120 diastolic, or both. It affects every organ, especially the vital organs in the body. Blood pressure 180 over 110, progressive, target organ damage. So, in order to understand the risk, it leads to progressive, target organ damage. What are these things? It is emergency, yes. Needs therapy, ICU, yes. Severe hypertension is not managed at home, to start with. It is a hospital management. شوية عربي على شوية إنجليزي كده. من first pioneers who founded the toxemia unit and the hypertension management unit, Prof. Dr. Maher Mahran, and the team working with him. The term was EPH, so edema proteinuria hypertension. Then Prof. Dr. Sammour have been coined the term hypertensive disorders with pregnancy. The first episode in hypertension is called urgency. The treatment can be oral. Frequent episodes and controlled hypertension, this means that the patient is at risk. Hypertensive emergency affect the brain, encephalopathy. If the blood pressure is high, the blood vessels will not withstand this high blood pressure, especially the microvessels. It is a generalized disease affecting all the microvessels, arterioles, venules, and capillaries. It affects the heart and the kidney and the aorta, and it can be one of the serious causes of morbidity and mortality. So when we say urgency, that is it's hypertension, but death is not an imminent factor. Emergency, it affects the organs that may lead to morbidity and mortality risk. Normal blood pressure is 120 over 80. This is the dream of all the clinicians, that to make the blood pressure within normal, within control. When it rises, in past they told us if the systolic rise 30 and the diastolic 15, starting this is hypertension with pregnancy or preeclampsia. Until we reach 180 over 120, this is hypertensive crisis, emergency, fulminating, go to immediately to the hospital. Some women may have refractory hypertension. refractory hypertension that does not respond to the traditional antihypertensive medications. There is something wrong. There is something behind this disease. We should find whether it is genetic or not. Women may present when they have this hypertension by brain changes, eye changes, and kidney changes and heart changes. All these things can threaten the life of the patient. When we say hypertension, we say systolic hypertension, diastolic hypertension, systolic and diastolic hypertension. But there is a mean arterial blood pressure, mean hypertension, mean arterial blood pressure, hypertension. Usually this term is missed or underestimated. It is a simple equation. When there is a range for that, a normal one is below 90, elevated from 90 to 92, and then the stage 1, 92 to 96, and the stage 2 is above 96. So we want to be, it is below 90. This may be more accurate than the traditional measuring of the blood pressure. When the patient go to the doctor to measure her blood pressure, there is always a phobia. She is apprehended. Either from the doctor, white coat apprehension or phobia or stress, they called it white coat hypertension. Doctors taking the blood pressure of her smiling patient تختلف القصة. Smiling patient, smiling doctor, smiling nurse, all these can sedate the patient, and you should measure the blood pressure again. How to put the cuff, how to measure. There is special requirements for that. Not everyone can measure the blood pressure. This is the best machine in the operating rooms, the monitor. It can give you more accurate measuring of the blood pressure. Not that, systolic, diastolic, and also can give us the oxygen and the respiratory rate. When we measure the blood pressure, the patient should be sedated or calm, not talking with the mobile, and we measure the blood pressure. And there is noise. Why we are interested in this topic? Because it leads to vital organ destruction or dysfunction. The vital 5 organs, that is, they can't survive by any one of them. Preeclampsia, eclampsia review, that is what we are going to know. The pathophysiology of preeclampsia and eclampsia is poorly understood. We don't know the proper pathology, but it is mainly related to uterine, placental, decidual, spiral vessels. There is something wrong in this area, because when the patient is delivered and the placenta is delivered, usually everything may be much better. This pathology leads to decrease in uteroplacental blood flow during late pregnancy. Maybe background genetic chromosomal factor, immunological factor, placenta ischemia, and infarction, environmental factor. The secret is in the blood vessels. Where is the decidua? Where is the spiral vessels? There is narrowing of the vessels, and the process go stepwise, rising gradually until there is a risk. Before 20 weeks, it is chronic hypertension. After 20 weeks, it is either gestational hypertension or preeclampsia or eclampsia or superimposed preeclampsia. When we say that it is pathology, there is dysfunction of all the functioning organs in the body, whether kidney, heart, chest, liver, even placental pathology also. And don't forget the postpartum preeclampsia and eclampsia. Postpartum. When preeclampsia is severe, hypertension and proteinuria. Severe preeclampsia means the blood pressure systolic diastolic is high, and the eclampsia there is convergence on top. Usually the patients suffer from headache, blurring of vision, upper abdominal pain where there is an insult to the liver. Imminent eclampsia, impending eclampsia, that is severe, persistent occipital frontal headache, visual disturbances with blurring of vision. When a patient says to you, I have severe headache and my vision is not well, and sometimes I don't so well, there is pupillary edema. There is something wrong in the eye. When you measure the blood pressure, it is high, systolic and diastolic. When you take the urine sample by dipstick, you will find proteinuria 1, 2, 3, 4, 5 pluses, up to 5 grams, and the reflexes are jerky and the urine output is below. The warning signs of impending eclampsia, that is statistically severe persistent headache in 83%, reflexia, hyperreflexia 80%, proteinuria 80%, edema 60%, clonus 46%, visual 45%, epigastric pain 20%, and the normal blood pressure. Some women have preeclampsia and their blood pressure is normal. How this occurs, this is something serious. The impending signs of eclampsia, the warning signs: systolic blood pressure is high, 160 millimeter mercury and more, on 2 occasions 6 hours apart. Proteinuria 5 gram for 24 hours or more than 3 pluses. Urine is below average and sometimes cerebral and pulmonary edema. Preeclampsia is a cardiorenal syndrome, that affects both the heart and the kidney. And this cardiorenal syndrome needs to be under stress by the clinicians to know that is the proper diagnosis and management later on. The new onset of cerebral or visual disturbances is an alarm. The blood count, the platelet count below 100,000 is important sign, and some respiratory disturbances are an important sign. Atypical preeclampsia, as defined by Sibai and his colleagues, have 4 clinical groups: non-protonic gestational hypertension, plus the presence of severe hypertension, or symptoms, laboratory signs of suggestive microangiopathy and hemolysis, or normotensive gestational proteinuria with the presence of symptoms of laboratory signs. There is debate between both these conditions. Then HELP syndrome later on. The warning signs of postpartum preeclampsia. When we deliver the patient, we are happy because we save the mother and the fetus. After 24 hours or 1 week or 2 weeks, 3 weeks, we find that the patient came to us again with severe hypertension. This is called postpartum preeclampsia, postpartum eclampsia, postpartum hypertension. This is a missed part, 6 weeks, especially after delivery. So I would like you to be always aware about this serious condition. That is, if you treat a patient with hypertension with pregnancy or preeclampsia or eclampsia, don't stop the medication until they are sure 6 weeks past that she is completely free. And at any time she had symptoms, she came to the hospital and asked medical help immediately. Warning signs, and the telephone is running and calling for help, immediately came to the hospital. It is more serious than before. Hypertension, when it rises, makes stroke, cerebral encephalopathy. It is an emergency situation. This emergency situation would will affect our brain and may lead to semi-conscious, coma, deep coma, cerebral hemorrhage, maybe mortality. It is an emergency. Call for a neurosurgeon. If the woman has hypertension and headache and severe headache and taking her hand on her head like this, and you measure the blood pressure is high, don't hesitate, don't wait too much. Ask for a neurosurgeon with you. Don't put fundus examination. Just measure the blood pressure. Urgent CT scan of the brain. Within half an hour, 45 minutes, he will diagnose cerebral hemorrhage, encephalopathy. He is going to do what we call emergency craniotomy. He is going to evacuate the blood clot inside the brain, and he is going to be in your patient in a good situation. So acute severe hypertension is an emergency situation that needs your intervention immediately. Otherwise, you may lose your vision. Some women may have visual disturbance. Even she may lost her vision. Or she may pass to eclampsia. Usually we say that mild preeclampsia can be moderate, severe, bending, fulminating, eclamptic fits. Or eclampsia de nouveau from the start. Eclampsia is a serious disease. Eclampsia is a serious disease. It may lead to death immediately, or some complications, broken arms, broken teeth, or cut her tongue, or secretions. And these fits usually, when we see it, very serious. The situation in the management of these patients is an emergency. Cerebral hemorrhage with encephalopathy, pulmonary edema, liver failure, heart failure, renal failure. All these can be prevented by detection and the treatment of preeclampsia very early. The treatment is an emergency aid measures. We could put the endotracheal tube, the airway, the suction, and all these things, and the bed with support, fall complications. Don't leave your patient and go to any restroom. There is someone or two, nurse and the doctor behind your patient. Don't make the patient lonely with her family. Close observation, a nursing in obstetric ICU, and good nursing care. Never leave the patient unattended. Never leave the patient unattended, because life is going to finish if you leave your patient in few seconds. And you should monitor the vital signs, pulse, blood pressure, temperature, respiratory rate, and fluid balance by the urine output. Whether severe preeclampsia or impending eclampsia or fulminating eclampsia or impending eclampsia, all these things should be hospital management. The MAC sulfate, a very useful, helpful weapon. It will minimize or abolish the effects of the sizers. And you should know how to give the dose and to monitor the dose and the reflexes and urine output and the toxicity level. Sometimes we may give some medicine, anticonvulsive like diazepam, but the most important item is the anti-hypertensive medication. It is usually given IV, intravenous, bolus, on monitor in the ICU. Don't give it in the bed or in the home or on it should be in the ICU unit, not in the ward. Say sometimes your patient phoned you and her family phoned you that your patient had hypertension. We measured it in the pharmacy. الصيدلي قاس لها الضغط، الضغط كان عالي شويه، كان 160 170 107. These patients should be admitted to the hospital. No beds? Find another bed. Find another space. Mandatory. Strongly recommended that severe preeclampsia, especially the diastolic if it's high, should be admitted to the hospital. Now we have two problems about the gestational proteinuria and edema. Is it significant? Yes, it is significant. When you have heavy proteinuria, something wrong in the glomeruli. There's something wrong in the kidney or the liver or both. So we should monitor these patients by urine analysis. The glomeruli, we find the term of glomerular endotheliosis. Here is the leakage of the protein in the urine. If the woman urinate and see the bubbles or the foam, this is a clinical observation, but the urine should be analyzed by the dipstick. This is accurate. Will give you the level, and you give you the measure and the significance. Pitting edema. Pitting edema may be in the hand, in the face, in the lower limbs, in the vulva, and everything in the body, soft tissue. ICU, best place to manage eclampsia and preeclampsia. No management at home. Now, our last thing is the treatment is symptomatic. The only cure is to deliver the patient, the fetus, and the placenta. Both should be out. If you still have hypertension, postpartum, preeclampsia or eclampsia, and it is more serious. The season of eating salty fish and excessive salt and those things, alarm by rising the blood pressure may be one of the serious causes. We should stop this habit to minimize the risk. The antihypertensive medicine or medications كلها either vasodilators or sympathetic inhibitors or diuretics or renin-angiotensin blockers. Renin-angiotensin blockers is not advisable and not recommended and should not be given. The vasodilators, yes, we can give it. Sympathetic inhibitors, yes. Diuretics on debate in only very rare situations. Acute medical therapy. All clinicians and obstetricians should know these medicines. Hydralazine in the past, apretuline. Nowadays, we are lucky, labetalol or labibres, nifedipine, sodium nitroprusside in the ICU, and the other medications available. So we have vasodilators and adrenergic inhibitors. The drug labetalol or labibres, if the woman is pregnant, is the best first choice to treat these patients, especially high blood pressure, all through pregnancy and after that for long duration. WHO says that the first line treatment is hydralazine, labetalol, nifedipine. We may alternate or combine medicines with each other. The alpha-methyl dopa, اللي هو الالدوميت, صديق, 56 years more, still working, still good, still available. But if we have a newer medicine, much safer and more effective, welcomed. It can be combined or alternative instead of labetalol. The angiotensin converting enzymes are not recommended. Take labetalol even if you feel well. That she took the treatment, her blood pressure is controlled. She says to you, I am now okay, I measured my blood pressure okay, I will stop the medicine. No! الدواء اللي يشتغل ويجيب نتيجة ده صديق. Continue by it for the end of delivery. ما فيش حاجة اسمها stop. Don't stop taking labetalol suddenly. If you want to stop it, ask your doctor, managing doctor. I am not satisfied by this medicine. I will not stop. He gradual stop it. Or no. How much I will take? The usual tablets, 100 milli, split dose, one morning and evening, up to 2.400 milligram per day. Titrating the dose every 2 to 3 days, building up the dose until you reach the maximum effective medicine. Or you may combine with this labetalol other medicine to help your patient. It can be taken at any time by food. Swallow and don't chew it. Don't chew it. Maybe as any medicine, allergic reaction, which is very rare, anaphylaxis. The only contraindication is bradycardia. Bradycardia, sinus bradycardia. The drug may be secreted in a minimum dose in the milk. She can suckle her baby, no risk from breastfeeding. Is it safe to take it for a long time? Yes. In fact, it works best when you take it for a long time. What will happen if I stop taking it? It's not good. It's not good. This drug acts on the heart and the blood vessels. Friend, صديق يشتغل على القلب ولو قاعد يقول ده المطلوب. لابيتولول فارماكولوجي بتاعه الفا ادرينرجيك and beta blocker receptor blockers. Alpha 1 and beta blocker. Recommended dose 100 milligram twice daily, building the dose up to 2.4 milligram per day. Now, if I am in emergency, I can't take the oral. I would like to intravenous, especially on the IC unit. In the IC unit, not in the bed or in the ward, can be given labetalol intravenous slowly, bolus dose or infusion, and monitor and by your colleague in anesthesia. It is given in any patient with severe hypertension, fulminating hypertension, rising hypertension, threatening the life of the patient. It should be titrated. احنا كنا قبل اللابيتولول ده بندي ترانديت نيتريك اوكسايد كل ده في اوضه الرعايه. How you give it? Labetalol should be diluted only in compatible fluids like dextrose 5% or potassium chloride, sodium chloride. It can be given with these fluids. The second medicine is nitroglyceride. The only drawback of this medicine is reflex high tachycardia, reflex tachycardia. It is a very good medicine. If it is available, also it is good. Reflex tachycardia. Now, before conclusion, hypertension during pregnancy, drugs that may be used, mild to moderate, methyl dopa, labetalol, أكتر من كده methyl dopa, labetalol, and nitric oxide, and lamivudine. Some women may suffer from cardiac problems, even cardiac arrest. We should train the doctors and the nurses to do resuscitation. I would like to thank DBK company. She alert and fighted to manage hypertension by introducing this life-saving weapon, IV and oral lamivudine. I would like to thank you for your
Thank you, Professor Sobha Balouz, for this very alerting lecture. And next speaker will be Professor Baha Sibai through satellites from the United States. He will be talking about severe hypertension during pregnancy. And I don't know if we are ready for, are we connected? هي المفروض لو المحاضرة متسجلة لو هو مش لسه مش available. Professor Sibai, I think everybody knows the name. I know him in person. I worked with him for 2 years in Memphis, Tennessee, like 30 years ago. He is my mentor slash friend slash brother, and he's a very nice person. And usually the Americans have a word, hypertension with pregnancy before Sibai and after Sibai. It's like before Christ and after Christ. And he was for like 20 years the head of the International Society for the Study of Hypertension in Pregnancy. I think he will be with us maybe after the lecture to discuss what is he is presenting in the his lecture, and he will be able to answer any question about that.
احب اضيف معلومه كده. دكتور سباعي من الليدرز اللي مصنفين عالميا في علاج تشخيص وعلاج الهايبرتنشن وذ بريجنسي، وهو عمل شغل جامد جدا في ريسيرش وببليكيشنز، والحقيقه هو له دور كبير قوي، وانا في منتهى السعاده لما عرفت ان هو هيبقى معانا في هذا المؤتمر، وهو متحدث جيد، وبالذات مرض البري اكلامسيا سبيشالي سيفير هايبرتنشن، لان threatening the life of the woman او الموربيديتي والمورتاليتي بتاعته عاليه. الحقيقه بنشكره وبنتمنى ان احنا نستمتع بمحاضرته.
معاك تقدر تبتدي.
discuss differential diagnosis and management of eclampsia. This might discuss management of Count syndrome and its complications, and the diagnosis and management of pulmonary edema, all of which are conditions that are life-threatening to the mother as well as to the fetus. How to define severe hypertension? When does it happen? The definition is if the systolic blood pressure is more or greater than 160, or the diastolic blood pressure more or equal to 110 millimeter of mercury, that is persistent for at least 15 minutes. Severe hypertension can occur antepartum, intrapartum, or immediately in the postpartum period, up to about 4 weeks to 6 weeks. The etiology could be severe gestational hypertension, severe preeclampsia, or exacerbation of chronic hypertension. Severe gestational hypertension is defined as systolic blood pressure of at least 160 millimeter, or diastolic blood pressure of at least 110 millimeter of mercury, and 2 occasions at least 4 hours apart. Or if you have one elevation of severe blood pressure 15 to 30 minutes apart, and you give IV medication, this will satisfy the diagnosis, and there is no need to wait the 4-hour period. In such cases, there must be absent symptoms, and the blood test should show a normal platelet count, liver enzymes, and serum creatinine. Preeclampsia is defined as any gestational hypertension and the presence of severe gestational hypertension or new onset persistent cerebral symptoms start with labetalol, at time zero we give 20 milligram. We check the blood pressure again at 10 minutes. If it's still in the severe range, then we give 40 milligram. 10 minutes later, if it's still severe, we give 80 milligram. If at 30 minutes the blood pressure is still severe, then you can give diclofenac, check the blood pressure. And if still uncertainty about whether magnesium is beneficial to sparkling, and there is no evidence-based data to recommend repeat use after the initial manifestation. The main reason we give magnesium is to prevent convulsions. So what are the steps in managing an eclectic seizure? The first step is to prevent hypoxia. This can be done by supporting maternal respiratory cardiovascular functions, prevent maternal injury and aspiration. Most of the complications from eclampsia happen because the mother might fall off the bed or she might have aspiration. So it's extremely important to pay attention to this. Do not try to arrest the first seizure. This is a common mistake for physicians. They tend to overreact when they say seizure because it's frightening. We only give magnesium sulfate
الكهرباء فصلت في ثواني كده هترجع.
Listen one. Also, I met with the fire for 8 times. This responding please if a woman has 8 times of food, or if she has chronic hypertension, or if she has renal disease, if she is morbidly obese, or if she has diabetes. At the present time, there is no biomarker that's very superior with the clinical risk factor. So in the United States, we do not recommend use anywhere around the predicted vaccine. And for prevention, we give low-dose aspirin at 81 milligrams up to 25 weeks. Because of the benefit of aspirin on perinatal mortality and preterm birth, we currently give low-dose aspirin every pregnant. Thank you very much for your attention.
We have like 10 minutes for questions. Can we have Baha on? المفروض ان Baha. Okay, 1 minute. Okay, any questions for the? هيقدر يشوفنا هنا ولا كلام بس؟ هيقدر يشوفنا. اوكي. Morning, Baha. I was just talking about you. Been ages since I saw you. Now, you delivered your lecture, and I think there is some questions for you. And I hope you and your family are in good health. And I'll talk to you later. Anyway, okay. Any questions for Dr. Sibai? Yeah, you can use the mic and stay in front of the camera here.
Thank you for our professors, Dr. Ustaz Dr. Subh Abullouz Dr. Baha Sibai. Very thanks for these very good lectures and very good new trends and knowledge about hypertension and preeclampsia. Dr. Alaa Hilmi Omar, consultant of obstetrics and gynecology, MD Al-Azhar University, colleague of Auvergne. My question, the Pritchard protocol in treatment of preeclampsia is to give 4 grams loading dose intravenous and 5 grams intramuscular in right and 5 grams in left gluteal region and continue every 1 hour for by 1 gram and not to be more 24 grams in 24 hours. In your protocol, our professor, Dr. Baha, you say that the loading dose is 6 grams. And then every 1 hour, we can give 2 grams in 24 hours. What is the maximum dose to be used and to be in safe side with our patient? Because we cannot do the tests every dose of every 2 doses. And thank you.
We don't hear you.
IV plus 10 grams IM, which is really start with 14 grams as loaded.
الصوت
6 every shower for 4 hours, and you repeat the 4 grams, you're going to exceed the 24 grams. Optimal dose, as long as the patient has. Because what happened with magnesium pharmacophyte, it really depends on 2 factors: volume of distribution and excretion by the kidney. So really to satisfy the volume distribution, we give the 6 grams of loading dose. And this will be moving from the intravascular space to the extravascular space. So, as well as, in order to maintain the serum level at an appropriate value, then we give the
الصوت وحش يا
Sorry,
دكتور.
sorry,
وإحنا
Baha,
ما
Baha, to
جمعناش
interrupt you.
الكلام بتاع الدكتور
We have
بهاء.
just a minute. The internet connection is not that good, so the voice is not reaching in a good manner. Although the picture is good, and yes, now we can hear you.
connected. How about now?
Yeah, okay. We're hearing you.
All right.
Okay.
So read it.
The last part of it.
Yeah, to repeat is that there is no maximum dose. You need to 4 hours. As long as please you're having 1 milliliter of urine over, and you have reflection, there is no need to worry because all of this is showing you the maintenance dose is treated in the pit. We only worry about maintenance dose if you have abnormal renal function. So in essence, you can get the first 4 hours, 14 grams of magnesium sulfate to anyone, and then you don't have to worry about toxicity because this is the dose that's given. And it's 4 grams IV and 10 grams IM the first 4 hours. My protocol says you have 6 grams and 2 grams an hour. We said we'll make it 14 grams. So the answer to your question, the only worry about is if you have an abnormal renal function. This is why it's important to monitor the patient when you are using magnesium.
Baha, let me repeat that because it was not, because I worked in this with Baha. Yes, we have a lot of trouble changing people from the intramuscular route to the intravenous route. Intramuscular route takes time to act. It's not intravenous. It's very painful to the patient. And if you can check the magnesium level in blood every 1 hour, so you can increase the dose. There is no limit. Okay, your limit is the magnesium.
No limit for the dose of magnesium.
No, there is no limit. The limit is
during the 24 hours. يعني أنا أدي 2 grams every 1 hour for 24 hours.
2 grams
or more.
2 grams every hour intravenous, slowly. I mean, it's a drip.
What's meant by slowly?
I mean, the 2 grams in 100 milliliter, you can give the 100 milliliter in 1 hour. And after this hour, you test for the magnesium level in blood. If it's in the therapeutic level, it's okay. If it's in the toxic level, you can decrease the dose. If it's lower, you can increase. But usually they give a maximum of 2 grams per hour. Actually, they tried 3 and 4. I remember this.
What is the time which I can manage for the side effects? يعني امتى انا اعمل تيست على التوكسيسيتي؟
always
كل ساعة اعملها؟
لا، لما انت كل ساعة بتعمل مغنيسيوم سلفيت، مغنيسيوم level in blood every hour.
Let me explain. You don't need serum magnesium level. You need to have follow-up of the reflection. We never monitor patients in Bulgaria. We only use it if a patient has severe abnormal. If a patient has severe abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnormal, we use it. If a patient has moderate abnor
Okay.
As long as the patient is excreting 100 cc of urine in 4 hours, you don't have to worry because it means.
Okay.
This is why monitoring the urine output and the reflexes are the things that are very important.
Okay, so monitoring by reflexes is quite good, and it can be repeated. And magnesium sulfate, if you do it by an hour in good, you can check it again after 4 hours. But you should monitor by reflexes. This is what you want to say?
Yes.
Okay, good. Another question, please.
Thanks, Professor Sibai. We are proud for you. And we're hoping to see you here in Egypt, inshallah, in the near future. Your lecture is well designed, but to be applied, it is with very bad prognosis, especially for the patient. What is your opinion?
What do you mean with bad prognosis? I don't understand the question.
The maternal prognosis in such cases all the time is very bad.
Well, you know, it depends on your management
and the condition.
So it's going to be good if the patient comes early in the process with a proper management. Survival and eclampsia now in the United States is really more than 99%. So it's very, very unusual. I think most patients who have bad outcome are those who have eclampsia outside the hospital, and it takes time to bring them to the hospital to save. The same thing will happen.
The old saying during the basic teaching that preeclampsia is not a preventable disease, but eclamptic fit must be a preventable.
Correct.
Right.
Preeclampsia is going to be tested from the beginning. I really think what prenatal, if you look what happened all over the world, before we had antihypertensive medication, before we have eclampsia, just because of prenatal care. If patients come regularly to prenatal care, you are going to make timely diagnosis of the disease, timely delivery, and this will prevent the complications. Magnesium sulfate and antihypertensive medications will take care of the other 10%.
Okay. Any other questions? Okay, Baha. Have a very nice morning. We had the pleasure to have you.
Thank you very much.
You're welcome, dear. Okay. Bye. Inshallah. Bye-bye. Now is a fourth plenary session. Chairmen and speakers, please be ready. Okay.
Good evening, my dear colleagues and professor. Now we came to the last session. I would congratulate Dr. Muhammad Kamal for the success of this conference and to introduce this talk by Dr. Katia Bilardo. Cleft lip and palate.
Yes, thank you very much for your introduction, and thank you to all of you who are still here. We are running a little bit late, so let's start with my lecture that will deal with this subject of a diagnosis of facial clefts with 2D and 3D. Well, the face is very important. We know that when a woman gets a scan, she wants to see the face of the baby, and as we all know, the face is also the mirror of the soul. Usually in at the 20-week scan, we get the fetal profile, and we can appreciate whether it is normal or not. And in case of a cleft lip and palate, we will see that there is an alteration of the profile, and we will discuss this also later. Usually what we see is that where there should be the upper lip, there will be a deformation. Either the nose is distorted, or there will be, in case of a double cleft, a deformation of this area due to the protrusion of the so-called premaxilla, which is typical of a double cleft. What we see classically during the 20-week scan is we get the view of the normal lips. We switch from the profile view, we turn our probe, and with the tangent line, we get these very beautiful pictures with the nostrils and the upper and the lower lip and the chin. In case of a facial cleft, this image will be changed, and we will see that there is an interruption of the lips. That could be a unilateral interruption, a thin one of a very large one, with also distortion of the nose. And if the clip is bilateral, as in this case, we will see that there is a double interruption of the lip, and sometimes we can see also very clearly the interruption of the alveolar ridge, and we see that this portion of the upper lip is disconnected from the rest of the lips, and is usually sticking out and protruding, and that's the so-called premaxillary protrusion. A little bit of embryology. We all start as two separate parts that meet on the midline. And the same also applies to the development of the face, of the nose, and of the lips. And if this meeting in the midline of the processes that will give origin to the nose and the lips doesn't occur properly, we will have a facial clefting. Just a few notions. We can visualize a cleft of the lip and of the palate already in the first trimester from 12 weeks onwards, although usually the diagnosis occurs at 20 weeks because more women are having a 20-week scan rather than a first trimester scan, let's say a detailed first trimester scan. The diagnostic ability is especially good for a bilateral cleft and in case of associated anomalies, and if we know specifically that the woman is at increased risk because in the family there are more cases of clefting. The diagnosis of isolated palatum cleft is sporadic unless this is accompanied by micrognathia, as for instance in the Pierre-Robin syndrome, and therefore it's more challenging. I will also give you some new hints that may make you aware of the fact that we may be dealing with a case of cleft palate. Schisis is the most common congenital anomaly, being present in about 1 in 600 births, with the prevalence of male fetuses with a ratio of 1 to 2. There is also a clear relationship with ethnicity. We know that is more common in North American Indians, and then in Asian. In European is about 1 in 700, and in the African population is the prevalence is lower. The clefts are a product of the combination of genetic factors with environmental factors, and we know that when genetic factors are prevailing, we will have some syndromal clefting. There are, for instance, some syndromes like the van der Waals or the 22q11 or Stickler-Appert and trisomies, where clefts are very, very common. And when the environmental factors are prevailing, we will have, therefore, some cases of clefting that are not present in a syndromal association, but are rather due to, for instance, fetal alcohol syndrome or embryopathies like, for instance, hydantoin embryopathy or rubella of other cases where external agents may have produced the damage. The clefting can be unilateral, as in this case, of unilateral very subtle or unilateral quite severe, extending to the nostril, or can be bilateral. And what I show you here are also some 3D pictures of the cases, and I also show you the baby after the repair. And as you can see, sometimes the repair can give excellent results, although more operations may be necessary. The most common types are listed here. We start with a unilateral cleft of only the palate, of only the lip, of extending from the lip to the alveolar ridge and to the palate, or we can have a bilateral, and it can be therefore a very complete cleft of the palate or a cleft of the alveolar ridge, bilateral, that can extend towards the palate. And in this case, we have a bilateral clefting of the lip, alveolar ridge, and the palate. In 50% of the cases, the defect will be unilateral, and it will comprise lip plus alveolar ridge plus palate. In 25% will be lip plus alveolar ridge, and in 25% of the cases, only the palate. Sorry, I think I was wrong. In 50% of the cases will be, yes, bilateral, and in 25% unilateral, and in 25% only the palate. In 20% of the cases, there will be also association with other abnormality, and isolated cleft palate is often part of a genetic syndrome. Therefore, we may find other anomalies and then look also at the palate because that may be involved. This is a paper that we published in 2016 about 330 cases of clefts, and the prevalence was 1.5 per thousand, so about 1 in 600, as I said. The ratio male-female was 1.6, and the correct diagnosis at 20 weeks was very much dependent on the type of cleft. If it was a cleft of the lips plus, so which means quite of a severe case, it was correct in 93% of the cases, and less correct if the cleft was involving also the maxilla and the palate. External defects were visualized rather good, but it was more difficult, challenging to say whether the alveolar ridge of the palate was also involved. We see that the vast majority of the unilateral clefts are isolated, and the vast majority of the median clefts are accompanied by additional anomalies, and we know that this is especially accompanied, I will also come back to it again, with trisomy 13. The karyotype was abnormal in 21% of the cases. The majority were trisomy 13, then followed by trisomy 18 in 23% of the cases, and other genetic anomalies in 30%, including various syndromes and also microdeletion syndromes. And we know that, for instance, 22q11 is often also accompanied by a cleft. Well, my question to you is this really a mild defect? Yes, fortunately in many cases, yes, but there are cases where the clefting can be very, very extensive, and this is a classification based on the criteria of Tessier, and there are also cases where the cleft is extending to the eyes or really very, very complex. Therefore, not always a facial cleft is a very mild defect. And now let's have a look at a lot of pictures. These are 3D pictures showing various types of clefts. This fetus doesn't want to be seen, and this is in actual fact very, very typical that when we are trying to get the fetus in 2D or 3D, they seem not to want to show the defect, or maybe they are just playing with the defect. What we can see here, especially in this axial view, is that sometimes you see, in case of a bilateral lip and alveolar ridge cleft extending to the hard palate, that what you see here, this hard white line, is in actual fact the nasal septum. It's a very typical view, and I will come back to it later again. This is a very young fetus, and also here you can see that the defect extends from the nose to the alveolar ridge. So here in the second trimester, we see again in an axial view this unilateral cleft lip, only of the lip and not extending to the alveolar ridge. Here we see that there is involvement also of the alveolar ridge, and this is a bilateral cleft with a double involvement of the alveolar ridge and extension towards the hard palate. Well, and these are again some 3D reconstructions, some rendering picture showing a very subtle cleft of the lip, and this one is a more severe one, and this is a bilateral one with a maxillary protrusion. And this again, the same. What you can see here, these are two cases of unilateral cleft, and you can see that here the nose is quite normal. You see that the nostrils are still quite normal, whereas in this case where the cleft is wider, there is a profound distortion of the nose that is deviated to one side. Median schisis is typical of trisomy 13, is a quite rare anomaly, less than 1% of all clefting cases, and it can be subtle, as in this case, or very large, as in this case, and in this case, and it's also associated commonly to other structural anomalies, like, for instance, hypotaylorism, microphthalmia. You can see sometimes also the presence of proboscis in the typical trisomy 13. It's a very severe anomaly. And now let's have a look at some first trimester pictures. I told you that you can see sometimes a cleft already in the first trimester. This was a fetus with an enlarged nuchal translucency, a microagnasia that you can see very clearly on the profile view, where you also measure the nuchal translucency. And by 3D, we could see that there was a double cleft of the alveolar ridge. We can see also in this 3D reconstruction of the face that there is clearly a defect. And here we can see again that nasal septum, and this fetus had also and abnormal ductus venosus flow. Another marker that in the first trimester can help us in saying whether the palate is intact or not is the so-called retronasal triangle that we can get in this kind of coronal view of the hard palate and of the frontal processes. There is this kind of triangle, and we can see that in these two fetuses the retronasal triangle was intact, whereas in this fetus, where we see clearly that there is in a profile view that there is a problem, that there is this protrusion of the premaxilla, if we look on this plane, we will see that there is an interruption of the hard palate, and this can be seen as an abnormal retronasal triangle. And here we see again that protrusion, and what we see here is another marker which has been described more recently by Rabbi Shawi, and is the so-called maxillary gap. We see that the maxilla is not continuous, but there is a gap here. We can see it very clearly, and this is due to the fact that the hard palate is not intact, that there is a gap. Another important notion is the association between an increased nuchal translucency in the first trimester and the likelihood of a cleft. In actual fact, the relative risk for any cleft in a fetus with an enlarged nuchal translucency is 19, and it's much higher when there are associated anomaly, 53, than when it's isolated, which is 8. And here I show you some cases, some video clips of first trimester cleft. In this case, we see that there is a very abnormal profile. There is this protrusion of the premaxilla, and this was a fetus with a bilateral cleft. This is another case with a 3D video clip, and we can see very clearly, and I show you also all the different manipulation that we do on the volume, that there is a problem with this fetus, which again shows the premaxillary protrusion in the profile view. You see that it's got a very strange nose, and we will now slowly also come to the palate, and we will see that the palate is indeed affected and is not intact. Well, this takes obviously a little bit of time to show you correctly, because these are video clips that have to be elaborated, and we now flip the face. This is the so-called flip face view, and if we adjust our area of interest, we will see on the hard palate, we will see very clearly that there is a gap, a lack of continuity in the hard palate. You will see that in a moment. You see that here there is indeed a gap in the hard palate. We are almost there. Well, unfortunately, to show you all the different steps of manipulation of a volume, it costs some time. Okay, let's move forward. And well, so I already have discussed with you this flipped face view, which means that you turn your volume in such a way that the region of interest is placed, that you're looking at the palate from the inside. But I want to tell you something. Although 3D obviously is a very good help, unless you have some fluid in the mouth and unless you have a very good 2D visualization of the palate, don't think that 3D can do magic tricks. In this case, what we see is again, it's a bilateral cleft, this nasal septum with the two alveolar ridges that are also interested by the defect. Well, the 3D technique makes use of the axial plane, and this is an old paper by now of Pilu and Segata, who for the first time described this technique, or of the coronal plane, where we will really move from front to back or from back to front, and therefore see which structures, and especially in this case, which bony structures are interested by the cleft. And now we have a new tool, which is called the OmniView. It's quite recent, whereby we can trace in our 3D volume some lines and specifically have a look at what happens in that plane. So here, for instance, we see again the nasal septum, and here we can see in this bilateral cleft lip that the alveolar ridge is indeed involved by the clefting. Regarding the visualization of the palate by 3D, this can be quite challenging, but by using well our 3D techniques, and if we have a good volume, we can indeed have a look and sometimes identify this defect of the hard palate. Regarding the soft palate is a different issue, but also for the soft palate, a new sign has been described, which can help us to say whether there is a cleft of the soft palate or not. And we look in particularly at the uvula, and this ultrasound sign that has been described is called the equal sign. And I don't know if you can see it, but when there is a cleft of the soft palate, what we will see is not this nice picture where we see that there is an equal sign of the which represent the uvula, the two echoes of the uvula. We can see it in the sagittal, in the axial, and in the frontal plane. So this is normal. And then later we will see when there is an abnormal. So in this case, we don't see this equal sign. We don't see it here. We don't see it here. Whereas we see it here. We see that here the equal sign is present. Again, in coronal view, we see here, this is the cranial and it is the caudal side, and here we see the equal sign, and here we see another important feature that we will see even moving during the scan, and these are the vocal cords, because the fetus moves the vocal cords spontaneously during the scan. Okay, let's have a look at the normal case. You can see here the equal sign there. Look very carefully. You can follow the hard palate, and at the end of it, these two lines, parallel lines, and they are those giving the equal sign. And these are other pictures of a cleft of the palate. Here we see that there is an interruption, again the maxillary gap. Here there is an interruption, and here there is an interruption in these sagittal views, in this kind of profile views. And this is a bilateral clefting, and here again we see that's the tongue, and here we see the nasal septum, and we see here in these axial views again these two interruption of the alveolar ridge. Let's have a look in a volume and intact palate. So here again we are manipulating our volume again, aligning the three planes, and when we get the exact mid-sagittal view by aligning all the three planes, we will use the technique of the reversed face. It's one of the two techniques. You have the flip phase and the reverse phase. What we do with the reversed phase, we are in actual fact moving, in this case, from front to back with our region of interest, with our view. Sorry, I told you from front to back, but in actual fact it's the other way around. It's from back to front. And we will see indeed the different planes that we are visualizing. In this case, this is the hard palette. You can see it here very, very clearly. And therefore, this will be very helpful in navigating through the hard palette to see whether the hard palette is intact or not. So here we have another video clip. No, sorry, so this is again the same one. I apologize. And this is the other technique, the so-called flipped face technique. And see what happens here. So what we do here, we turn our volume in such a way that we will place our region of interest in such a way that we will visualize the hard palette from the mouse towards the, let's say, the upper side of the, towards the brain. So, and in this case, we will also be able to see the hard palette. You can see here, this is the alveolar ridge with all the tooth buds, and this is the hard palette. And we can see it very clearly, and in this case, it's an intact palette. And this is another technique, and is the actual frontal view. And again, an intact palette, because obviously you have first to become very much acquainted with these techniques and with what is normal, to be able then to recognize very well what is abnormal. So in this case, we are moving our region of interest from to a frontal view, modifying and making it smaller. And here again, you can see this hard palette very nicely reconstructed and obviously normal. Okay, let's move forward. This takes a lot of time. So this is a case of cleft palette with the flipped face view. So again, here we are flipping our volume. You can see that we put it in such a way that the neck is up and the vertex is down. And we have obviously to align the three planes exactly. And then once the three planes are aligned, we put again our region of interest on the hard palette. We make the window smaller. We can also make it more curved. And here you see again the reconstruction of the palette, but what you see very clearly is that it is not intact, that there is a gap which is very clearly seen with this technique. And there it is. Okay, we move forward, and this is a cleft palette, this time with the, again with the flipped face. I think I'm back on the same. Whereas this is with the omni view, a cleft palette visualized with the omni view technique. We get the volume going, and so when we get the right view, we can use these lines, draw the lines, and then have the reconstruction of all the structures that are found in the lines. We magnify the picture, and now we use the line and the line will be drawn along the hard palate. And what you see here very, very clearly, in this case of bilateral clefts, is that there is a defect of the hard palate, very clearly seen. And if we move the line a little bit more up towards the nose, the nasal cavity, we see again that septum. You can see it very clearly here, the septum, with the two black spaces representing the two alveolar ridges defects. Okay, and now I'll show you some video clips demonstrating another way of establishing whether there is a defect of the cleft or of the palate in case of a bilateral cleft, and is by use of color Doppler. You can see here, this is first of all, why is not working? Well, probably is this one working. Well, I'm sorry, but I cannot get it started, because it was otherwise quite interesting to see how you can see that that there is some fluid which passes from the mouth cavity to the nose, so which indirectly means that there is an opening from the palate. I'm really sorry, but I don't know why. All these video clips you can find on the EFMF site. On the EFMF site there are chapters on anomalies under the product called VISUOG, which is the Visual Encyclopedia of Images, and there are chapters for the majority of anomalies. So I invite you to have a look at this VISUOG, and you will find all these video clips. So this is another video clip which illustrates the cleft of the soft palate. Let's hope that this one will work. Yes, this one does. So as you can see here, you see that the line of the hard palate stops at a certain point. You can see it very clearly here. I will operate it again. And sometimes you also see that the mouth, when the fetus moves the tongue, comes very high because obviously arrives to the nose, to the level of the nose. So again, in this case of a cleft of the soft palate, and here it works, fortunately, you see that there is a fluid which is passing from the mouth cavity to the nose cavity, very high. You see, and it goes up and down, so which means really that there is not an anatomic separation between mouth and nose. So these are tricks that can help you if your 3D technique is not so advanced yet. So, and I've come to the conclusion of my talk, and I want to give you some tips and tricks and advice for a correct diagnosis. First of all, you have to be patient. Sometimes you have really to wait for the fetus to move the hands away or to move the face in such a way that you will have a good view. Wait for the baby to open the mouth, because if it opens the mouth and you take a volume at that moment, you will have better results and the capability of better visualizing the hard palate. Look at the position and movement of the tongue. If you see that the tongue is very high and that it seems almost to touch the nose, that is a suggestion that there is a palatal cleft. And look always carefully for associated anomalies. And do not underestimate the impact of such a small anomaly for the parents. So the conclusion is that cleft of the face are common congenital defects. Genetic components, male predominance, and relatively high recurrence risk are facts that we have to take into account while doing a scan. The diagnosis is already possible from the late first trimester due to the presence of micrognathia or an abnormal profile, offer genetic investigation, therefore karyotyping is not sufficient, but also microarray, unless the condition is completely isolated and familiar. If there is a familiar recurrence and there are no other anomalies, then you know that probably is not a genetic case. The diagnosis can be done with 2D and facilitated by the use of 3D, especially with regards to the involvement of the palate and the alveolar ridge, and put parents in contact with specialized teams, because the parents sometimes need a lot of explanation and to know that a good correction is possible, and also with other families, because this could give a very important information and support, because it's always a very traumatic news when we tell a couple that they have a fetus with a cleft. And then prepare the woman to breastfeeding. There are, at least in my country, some specialized nurses that are going to visit the couple and instruct the mother as to how can she use the Haberman tool, which allows mother to breastfeed the fetus even in case of a bilateral cleft. And with this, I have finished my presentation. I thank you very much for your attention. I'm aware that it was long and that it's late, but I hope it was useful. Thank you very much.
Thank you, Professor Katia, for this demonstrator's lecture. Many thanks. We postpone any questions to be our late time for come to the second session. Thank you. Postpone the questions for the end of session.
So, which will be in how much time about?
We have 3 lectures. Okay, thank you.
Thank you very much.
You're welcome. Now I'll present my professors, Dr. Ala Abrashi, professors of obstetrics and gynecology, Cairo University, one of the pioneers in the fetal medicines, director of Anne Donald's Fellowship in Egypt. He will address fetal cranium and phase at 13 weeks.
Good afternoon. Thank you very much. I know that it's late. However, thank you for staying with us. Thanks for Kamal Aitman and Dr. Sharif and all the organizers for this very fruitful and scientific meeting. I know that you have enjoyed the Italian accent. By the way, Catalia is an Italian originally, not the Netherlands. That's why I was asking her, this is an Italian accent. But this is an Egyptian accent, so it's not a big deal. I am going to mainly concentrate on the, let me see, this is one. The 13-week scan, and I see the future and fetal anatomy at the 13-week scan, because we have, all what we have is still there, and we are searching for the new aspects of fetal anatomy, especially in the era of the NIPT. We are not only concerned now with chromosomal, however, we are concerned mainly with fetal anatomy rather in the 13 weeks. So every now and then we are confronted with new things that are very important and landmarks that lead us in the fetal anatomy at 13 weeks. And this is, I think it is very achievable now concerning many aspects, like the fetal heart, all 70% of the fetal anatomy, and we are going to speak about the fetal cranium. Before we speak about the fetal cranium, the target of our lecture is to demonstrate the development of the fetal face and cranium, trying to illustrate the progress in the ultrasound concerning the cranium and face, starting from early pregnancy until 13 weeks, and pointing out the potential benefits gained from early checklist for fetal anatomy. You all know that the brain is developing in a dynamic way. It's not the organ that it starts to develop at maximum by 15 weeks. Everything is settled, like the fetal heart, for example. No, the brain is very dynamic. We have mainly vesicles surrounding cavities, and every now and then they are changing in size and changing in pattern. Everything is formed from the neural tube, and the anterior part will form the brain and the lower part will form the spinal cord. And you know that we have what we call the neurulation, which is the closure of the spinal of the neural tube, and usually it zips from the middle up and down. That's why we always have the encephalocele and the spina bifida or the meningeal at the lumbosacral, because usually it starts in the middle, zipping up and down. And this usually takes about, I think, 40 days post-conception. So it means that by the time of 8 or 9 weeks, the tube is closed. And this reminds you of using the folic acid as early as possible, if you are using it for minimizing or decreasing the incidence of open spina bifida. As I told you, the structure organization of the brain is mainly formed of vesicles surrounding ventricles, cavities. And it starts by 3 main primary brain vesicles, then it differentiates into 5 ones, and these are the ones that are going to be more and more going up with development. If we look at the transvaginal, very early pregnancy, starting from 7 to 8 weeks, you will find cavities, and these cavities embryologically is recognized as the telencephalon and diencephalon, and the rhombencephalon, which is the cavity of the 4th ventricle, which is supposed to be later, the smallest one, is the biggest one at the time of 6 or 7 weeks. And you can demonstrate them starting from 7 weeks in the cut section, and even this very nice illustration by having the 3D, you can cut through the cavities. You will have the very nice coronal view of the cavities, starting by the lateral ventricles, the aqueduct, and the 3rd ventricle, and communicating with the 4th ventricle. So you can visualize the development of these cavities in a way. And this is one of the videos that show you the fetal or the embryo at the time of 6 weeks, and you can see clearly that rhomboencephalic cavity is the biggest one by this time, and this is very important to be recognized. When we arrive at 9 weeks, these cavities become very clear. However, we do not have a cleavage yet. And by the time of reaching 10 weeks, we start to have the falx cleaving the cranium. And this is the very classical, but by this time we can now have a clear image of the cranium after being having the cleavage of the forebrain, and we having a very direct, straightforward falx. So this is the mid-sagittal view at the time of 11 weeks, and by time of 12 weeks, everything now could be related to a fetal anatomy checklist. So we have a ventricular system, which is obvious. We can have a comment on the cerebellum, and by the time of the vermis, which starts to form, we are now having also a very clear image of the cerebellum, as I'm going to show you in the slide. So what is the clinical application of this sonoembryology? It's by the 12 or 13 weeks we can appreciate an intact cranium, because it becomes intact by the time of 11 weeks. The ventricular system, we can appreciate the midline falx. We can see the choroid plexus. We can even measure the choroid plexus. We can understand in a multiplanar view, if you want 3D or even by 2D, you can demonstrate normal development, and this can help you in the potential role for early diagnosis of fetal abnormalities. We need to have views. As you know, ultrasound is views. So what we need at the view for the 13-week scan for the cranium is the mid-sagittal, and in the mid-sagittal it's the most important, while the axial view we have two different ones, thalamic and suprathalamic, as I'm going to show you, as well as the coronal. For the face we need the mid-sagittal and coronal or frontal face. So this is a very nice illustration of what we call the axial view or the transverse section, and this is the both the suprathalamic and the thalamic, demonstrating the choroid plexus on both sides, as well as the beginning or the visualization of the aqueduct of Sylvius, which is very clear at this time. So the first one to be mentioned, it was mentioned by Valdo. Valdo is a very nice scientist from Chile, and he said he was published in 2010 what we call the butterfly appearance. This is very nice. You can you can see it in the axial view. The choroid plexus are filling the ventricles. The midline is dividing the brain into two, and this is the first thing that you can exclude abnormal cleavage like the holoprosencephaly. So this is the first sign. It's called butterfly appearance. If you go for the mid-sagittal, every now and then we get some measurements and some cavities and spaces that are demonstrated very clearly here. All of them I'm going to send them in later on. Volpi have described a very nice review in 2021 in the ESOG, while demonstrating the capabilities of seeing normal and abnormal cranium, as I'm going to show you, by demonstrating this is the thalamus and the midbrain, pons, midbrain, and this is the fourth ventricle, this is sterno magna. So you can now appreciate the presence of cavities very clear. The story starts from 2010 and even less, when we described a very small cavity. It's called intracranial translucency, and it was Shawi and Kipros used this intracranial, the IT, in order to make it resembling the nuchal translucency. This is simply the fourth ventricle. And when you see the fourth ventricle, you are assuming that you don't have a descent of the brain and you don't have an abnormality in the posterior fossa, because simply when you have an open spina bifida, what happens is everything is thinking down because of the CSF is going down, so everything is decreasing down. So the fourth ventricle will be closed. So they have demonstrated saying, if you can visualize the IT, why this means that you can have a possibility of open spina bifida. And second thing was two dimensions which are very important. This is called brainstem and the brainstem occiput diameter. It includes area representing the brainstem, an area representing the fourth ventricle and sternomagna. And as you can see very clearly that the brainstem occiput diameter is almost doubled the brainstem. So what happens? Imagine that what happens in open spina bifida. We don't have sternomagna because it will be closed. We're not going to have the fourth ventricle, so all this area will be much compromised. And by this putting these ratios, they're starting to make some important remarks concerning this part. Even in the frontal, if you're rotating the probe very simply in this way, you are having the mid-sagittal, and then you rotate the probe to get the frontal view. If you get the frontal view, immediately you see double lines representing the brainstem and the cerebellum, as well as sternomagna posteriorly. So you can also see that. So what are the things that we can notice in this time of pregnancy concerning abnormal or even documenting normality? The anencephaly acrania, definitely. Holoprosencephaly, definitely. Encephalocele, definitely. Open spina bifida with a very high sensitivity. Dandy Walker still ongoing, and the ventriculomegaly also still ongoing. So all these parts could be part of your diagnosis in early pregnancy. Definitely all of you have seen states of anencephaly, and this is very easy immediately after 11 weeks because the cranium should be intact. So not finding an intact cranium or not having a possibility to measure the biparietal is considered anencephaly. Holoprosencephaly is very simple and very easy. If you are applying what I have said as the butterfly appearance, you're not going to see it. Instead, you are going to see a single ventricle and the brain, which is the forebrain, continuous with each other with a fused thalami. So I think it's not a big deal And it is shame now that you are not diagnosing holoprosencephaly, which is 99% trisomy 13, incompatible with life, and you are waiting to 20 weeks with a proboscis and median clefting. This is, of course, is nonsense. So you have to go on with this type of investigation or ultrasound. The Mickel-Gruber, you all know that we have a syndrome which is called Mickel-Gruber. It have three important signs like the polydactyly, encephalocele, and polycystic kidney, and this could be easy diagnosed. We have a very huge number of cases in spite of being a autosomal recessive, and we consider it to be rare. Now we are considered to be seen in many cases. This is polycystic, and this is the polydactyly, and this is the encephalocele. What else? As I told you, this is the sequence of open spina bifida in the normal. In the second trimester, we are depending on the cranial signs to diagnose open spina bifida. What are the cranial signs that you know? You will have the closed sternum-magna, and the cerebellum become curved and compressed, having the banana shape, and then we have the scalloping of the frontal bones to make what we call lemon shape. These are the cranial signs of open spina bifida. Can we see it at 13 weeks? It's very clear that we are going to depend on the presence of the fourth ventricle, presence of the sternum-magna, and presence of some of the diameters. A lot of publications starting from 2011, and they started retrospective. What they have, they got the cases of open spina bifida at 20 weeks, and they went back to see the stored volumes of these cases. What is the difference in this case in open spina bifida concerning the cranium? And what they have reached, in many cases, they have reached a very simple conclusion that you have to measure the brainstem occiput diameter, and all the cases which show open spina bifida was outside the range of the centile, more than 95th centile concerning the measurements. So this is a very valuable tool, definitely. Yes. And they have published this in 2011. And even Shawi have published something similar, and have said that 6 cases of them showed that the brainstem occiput diameter ratio is altered. Another signs, a very simple sign that was made by the French group. They measure the biparietal diameter, and they measure the transverse abdominal diameter. Always the biparietal is higher or bigger than the transverse abdominal. Just simple remark that if the biparietal diameter is smaller than the transverse abdominal, this may hint the presence of spina bifida. And this, of course, was proved in many, rather 1 or 3 publications. Others have documented the presence of the sternum-magna. Others have made a relation between the distance of the aqueduct of Sylvius here and the occiput, and the distance this have parameters or centiles, and if it is decreased, it means that everything is decreasing back to the near the occiput. This is a very excellent and smart study, actually. I like it very much, and I apply it now in our unit 2018, which is maxillo-occipital line. You imagine that we have the very nice mid-sagittal view, and we have the maxilla here. You draw a line taking the maxilla up to the occiput. You will find a flexure or a constriction between the thalamus and the midbrain. This constriction should be always above this line. In open spina bifida, as usual, everything is descending down, so this flexion is going to be lower. You see here, this is the normal, okay, and this is the abnormal. When you take the line, the constriction is below the line. Look at this trick, it is very nice. When I went back to the 6 cases diagnosed by brainstem and brainstem occiput, this was in 2011, and in 2018 this paper was published by the maxillo-occipital. I found out that all the cases which showed abnormal brainstem occiput are also showing abnormality in the maxillo-occipital line. All of them are the flexion is below this line. So this is states that this sign is very good. Now we come to the prospective study. Now we're starting to make prospective study. This was from Turkish, and they have to visualize the sternum-magna in 1,400 cases, and it was very nicely demonstrating that just visualization of the cisterna magna. Once to visualize cisterna magna, it means that you don't have an open spina bifida. And also you can compare it with the brainstem occiput diameter. There is something also called crash. It didn't have too much popular reputation, which is the crash sign. Everything concerned the posterior fossa will be retracted back. Also, there is something called non-visualization of the choroid plexus of the fourth ventricle. It means that it could be related to chromosomal or it could be related to abnormality in this fossa. So we come to the most important one, which is the 2000 and 2020. This is very important. The ratio of the choroid plexus to the cranium itself. If the choroid plexus is very small in relation to the hemisphere, it could be related to the abnormalities. Screening for spina bifida, this was published in 2021, and this was a prospective study by multi-center study, 4,000 cases, and the screening for open spina bifida proved to be very high sensitive, and it could be applied in the practical part. So these are clusters of what we call abnormalities that we can use. We are now in our center having the large study, which we always do as we did in the fetal heart at 13 weeks. We are approaching 3,500 cases to see what is the most appropriate of these signs, but we are applying the brainstem occiput as well as the maxillo-occipital mainly, while others are be considered. If I want to summarize this part, look at the cranium in the mid-sagittal. So you are always appreciating the presence of three spaces, 1, 2, 3. These are three hypoechoic areas, should be anticipated or seen in the mid-sagittal view. Once you have a change in these spaces, or one of them is absent, or there is distance, or the brainstem occiput ratio will be altered, then you are thinking of abnormality in the posterior fossa. Either it would be open spina bifida, or it would be on the other side as Dandy-Walker syndrome. So this just to remind you that you have to see three spaces in the area of the mid-sagittal at the part of the posterior fossa. And you can read this in the State of Art published by Volpi, as I showed you. If I speaking about the face, Katia have said many things about the face development and the face features, and you know by embryological we are reaching 12 or 13 weeks. By that time we can see a real face, and we can have some landmarks that through these landmarks we can anticipate chromosomal abnormalities and clifting of the palate as well as micrognathia. If you are thinking of how many cases are associated with micrognathia related to chromosomal abnormalities or aneuploidy, there is a large number. So I am not speaking about the accuracy of diagnosing cleft palate at the age of 13 weeks, but just segregating or diagnosing cases that have a possibility or a high possibility of chromosomal abnormalities, which could be related to the nuca translucency, ductus, and so on. So you will find a complex abnormality. So in this case, we have the checklist which you have published in 2010 concerning the 13-week scan. We can see the orbits, we can see the face, and the most important is the mid-sagittal view. And in the mid-sagittal view, we have very important landmarks. As you see, we can see the nasal bone, we can see the intactness of the maxilla and the mandible, and as well as, of course, the posterior fossa, which I have mentioned. So all of these parts considered to be essential to be seen by the time of 13 week as a part of the 13 week. What is the value of that? Of course, this is the demonstration of how can we see it, how can we see the orbit, and so on. In the previous lecture, and this is the clue for diagnosing everything in the first trimester. So we can have the nasal bone and the maxilla and the palate, and you can have a relation between the nasal bone and the maxilla as in such case. And we are going to speak about the retronasal triangle. A very simple line is drawn from the nasal bone, passing by the mandible, passing by the maxilla. This means that everything in position, there is no micrognathia and so. Some have spoken in the last lecture about what we call the retronasal triangle. This was advocated by Sepulveda. He said that if you are dealing with 2D, just 2D, taking the frontal view of the face as here, you will see the primary palate representing the both sides, and this means that we don't have clifting. So retronasal triangle now is very easy to get. The second thing is what we call mandibular gap. The mandibular gap is that the mandible, when you cut in the frontal view, you cut through the mandible. So always you will find a gap between the bone. And if the mandible is receded back and it's small, if you are speaking or you are seeing from the frontal, you are not cutting through the mandible. So you will see the mandible intact. So what I mean is that you have to see the gap. This is very simple way as you are in London, where you are riding the metro underground. You see in the microphone somebody says always, please mind the gap. Mind the gap means that when you are putting your leg inside the metro, there is a space between the platform and the train itself. So they always say in the microphone, please mind the gap. I mean, take care of this gap. So this made Sepulveda also published the paper, and he said that please mind the gap, which is the mandibular gap is very important. And you can very easily see it here. This is the retronasal triangle, and this is the mandibular gap. So you can get it by 2D very easy. It will take seconds. So mandibular gap, retronasal triangle, and adding to such another very important sign was provoked by Shawi. It was maxillary gap. The intactness of the maxilla. It's very simple. When you find the maxilla interrupted in a way, and this usually carries a possibility of aneuploidy, like Rubens, like Di Giorgi, or whatever, all this clifting will be demonstrated by non-sound, healthy, or long mandible. So this is the maxillary gap. And these are some of the cases which are abnormally showing the maxilla, and it's very easy. It's part of your routine examination at this area. A very nice publication was comparing the maxillary gap with the retronasal triangle, and found that the retronasal triangle is more sensitive than the maxillary gap, while both of them are important for the diagnosis of micrognathia. So you can state micrognathia, you can state the palatal defects, not for the palatal defect, but actually for the association with chromosomal, because these cases will show abnormality later on, which is much more grave than having a cleft palate. This is to demonstrate what's meant by the retronasal triangle, and this is what we call the mandibular gap. You can get it easy when you are doing the 3D. The frontal space also, as we get the prenasal space in the second trimester, we can get the frontal space, and we make a line drawn between the nasal bone, beginning of the maxilla and the mandible, and you see the distance between this line and the frontal bone is very small. While if you have a micrognathia, this distance will be much increased. So this also will help a lot in these cases. So as a conclusion, the sonoembryology paved the way for more understanding of the embryological stages of the fetal organs, including the CNS, the brain vesicles and ventricles. Embryological stages of development can be appreciated like mirror images. It helped a lot in better understanding and following up these important stages of evolution to the full-sized brain. Face examination is now considered to be part of the 13-week scan, as I told you, and this enabled us to see the normality of such part. And we are now able to highly suspect as well as to diagnose the presence of open spina bifida, high potential diagnosis, Dandy-Walker syndrome and abnormalities. It was beyond our scope of knowledge in the posterior fossa before, and we can now have many things related to the aneuploidy. And the future of ultrasound still have its fascinating aspect. It's showing more and more of the 13-week scan. So the 13-week scan is actually the treasure that we have, but nobody is digging in that. So believe me, you have to go with that. And I finally leave you with the best face in the whole world, which is Tutankhamun Amun. Of course, you all know that this young youth died 17 years old. What he did for history is nothing. He was not doing anything in the history of the pharaohs except that his tomb was discovered completely, and this dazzles and fascinated the whole world. Thank you very much.
Thank you, Professor Alaa Brashi, for this highly impressive and perfect illustration concerning the fetal anatomy. And now we go to Dr. Ali Youssef. Dr. Ali Youssef is a consultant in obstetrics and gynecology and prenatal medicine in Bologna University of Italy. He is a social media editor in the Journal of Ultrasound in Obstetrics and Gynecology and member of the advisory board in EFMF-ISUOG. Dr. Ali Youssef will present to us a mid-trimester anatomy scan, a quick guide.
Articles, and we are present on almost all social networks, so please of Bologna University Hospital in Italy. It's a pleasure and an honor to be part of this event, although remotely. I will be talking about the second trimester scan, a quick guide. Okay, so I hope that most of you know already the EFMF website. We have a lot of very useful materials, whether lectures and whether guidelines and articles, and we are present on almost all social networks, so please follow us and you will be updated on the newest events and publication and materials. In particular, I'm talking about the mid-trimester scan. Is we have many guidelines, among which the mid-trimester scan, and if you are interested for a more exhaustive assessment of the guideline, you can, they are all free access. You can go on the EFMF website, clinical resources, and then you choose EFMF guidelines, and you can find all the guidelines free access. The mid-trimester scan guidelines is, if you go down till the end, you will find them, and you can access the free access PDF by simply clicking on it. So I will, in my lecture, I will summarize the main indications and the main activities that we have to undergo during the mid-trimester scan. So definitely the first thing that we have to assess before beginning, we have to, I'm sure that all of you know the planes in which we can do the scanning, so the axial or transverse plane, the sagittal plane, and the coronal plane. Why do we say that? Actually, the basic anatomy scanning can almost all be done by simply moving on the axial planes. So it's in the head, the heart, the stomach, the bladder, the port of insertion, and the extremities by a few seconds movement of the probe. Okay? So most of the mid-joint scan can be done by taking several axial planes. And we start with the head. There are on the digital head, there are two images that we have to obtain on the axial plane, both of them. The first one, the upper one, is the transventricular plane. It's called the transventricular because it passes by the posterior horn of the lateral ventricles, and you can see both the anterior complex and we'll talk about this later, and the posterior horns of the lateral ventricle and the midline. The second plane is the transcerebellar plane, and it's a lower plane, more angulated, okay? And it passes by the anterior complex and the posterior fossa, constituted by the cerebellum and the cisterna. On the planes, both the transventricular and all the transcerebellar, but not the transcerebellar. We can measure the biparietal diameter and the head circumference. So these can be measured on the transventricular plane, like we see in this image, or in the transthalamic plane. So this is the first example of what can be abnormal in a transventricular plane. So we have to measure the posterior horn of the lateral ventricle at the level of the occipital surface, and the diameter should be less than 10 millimeters. If we have the diameter of the lateral ventricle equal or more than 10 millimeters, it's ventriculomegaly. So this on the right-hand side, we have a case of the ventriculomegaly. Of course, we will not go into the details of each abnormal image because of the time. What about the anterior complex? What can go wrong? Well, the anterior complex is formed about from the calyx previously, which is a rectangular, fluid-filled, aneuploidic structure, and it should separate the anterior horns of the lateral ventricle. That we see with the rightmost picture. And these are some of the abnormal images that can be associated with an abnormal structure of the anterior complex. So we can see the whole anterior part of the brain formed like a crescent with no differentiation between the two hemispheres, and we have a huge communication between the two hemispheres, and this is the case of severe holoprosenception. Whereas we can see a fusion between the anterior horns of the lateral ventricle, so there is no calypso that separates the anterior horns, and this is the case of absent septum pellucidum. Whereas we can see, like the last image on the right, we cannot identify the calypso pellucidum. We can see that the anterior horns are separated, so are far from each other, and we have the ventricle has a teardrop shape. This is the case of a complete agenesis of the corpus callosum. So these are examples of an abnormal anterior complex. What about the posterior fossa? The cisterna magna, which is the aneuploidic space behind the cerebellum, should be less than 10 millimeters. So if you have more than 10 millimeters, it's mega cisterna magna. Sometimes we can see a communication between the fourth ventricle skeleton, we have to measure the femur diaphyseal length, and not all skeletal displays can be suspected in the second trimester. Some of them have abnormal dimensions in the second trimester, and then there is a deviation in the third trimester, but there are, in many other cases, especially severe skeletal dysplasias, we can already find very small and sometimes malformed, curved, or fractured long bones in the second trimester. The club foot, so regarding the foot, leg, and the foot, we have a particular relationship between the leg and the foot, and the sole of the foot and the leg should not be seen in the same image, whereas in case of club foot, we see persistently the foot on the same plane of the leg. So we see the sole of the foot on the same plane of the leg. Having said that, whenever we do a mid-trimester scan, it has to be reported. If you have a ready report, you can fill it, and otherwise, the ISUOG guidelines have a report which you can print it and fill it for each patient by clicking each structure and filling the spaces, and every patient to which you do a scan in general, especially the trimester scan, should have a report of the examination. Okay. So to conclude, the mid-trimester scan can be an instrument to diagnose many malformations through the identification of variables or variant appearances. The accuracy of ultrasound in determining the diagnosis of congenital malformation in the second trimester is around 50%. Okay? So patients should know that, well, you are doing a standardized, recognized examination, but that examination cannot exclude all the malformations that can happen in pregnancy. And this is a screening test. So you have, in case of a suspected malformation, in case of a failed visualization of any structures, you have to refer to a secondary level with an expert evaluation and for diagnosis and forecasting. Thank you very much for your attention, and I will be happy to answer questions.
Any questions for Dr. Ali? Yes, Dr. Muhammad. What is the ideal time for anatomy scan?
This should be, in some countries, it is modified according to the local legislation. So, for example, in Italy, since termination of pregnancy cannot be done beyond 23 weeks, the maximum age of mid-trimester scan is 22 weeks. But from a technical point of view, from 18 to 24.
Any more questions? Thanks, Dr. Ali, for being with us.
Thank you so much. It has been an honor, and I hope next time, inshallah, that we'll be together.
Inshallah. Welcome.
Physically.
Thank you. Now for the last talk in this session by Dr. Jihad Shallawi, Associate Professor, Department of Obstetric and Gynecology, American University of Beirut. affiliated to Hospital Hicard in France, Paris, France. He will address us the first trimester screening in the era of NIPT. Ready? شباب. Okay.
skip part of the semester exam independently of the intention of doing AIT or not. Nevertheless, we can deny that sensitive introduction and IPT of cell-free DNA has brought a lot of advantages to high-risk pregnancies and low-risk pregnancies. For high-risk pregnancies, it was quickly adopted and it had an important decrease in the rate of CVS and the rate of amniocentesis, with an average decrease of 77% for CVS and 52% for amniocentesis. But the question is, if we rely on just this screening test, on an IPT or cell-free DNA screening, what do we miss? And in this article, we see that if we just rely on cell-free DNA results, we will miss 95% of fetal findings, which is very, very important, and this is really the topic of our talk today. So, in summary,
Okay. Thank you very much, Professor Gehad. We come to the end of this session. We have one question for Professor Gehad and then another question for Professor Katia. For Professor Gehad, do you have any question about the relation of first trimester and NIPT? Okay. Professor Gehad, can I ask you if after performing the NIPT during by the end of the first trimester, and we detect a sonographic marker, do we have to proceed further investigation concerning chromosomal abnormalities?
Thank you for the question, and thank you again for the invitation. I congratulate the warriors who are still watching, if there are many. It's been a long day, I think so. But for your question is very interesting, and here for NIPT, first of all, we don't do it if you have an ultrasound time, even if it's minor. So we don't do it as a second step. And another way, like you're asking, if we did the NIPT and we had an abnormality, it is recommended to go for the invasive diagnosis, because we know NIPT is not a diagnostic test. And in the second hand, it only answers the questions you have asked. And most of the time, we ask the sex, trisomy 21, 13, 18. We rarely go beyond that. So there are so many things that we can search for in the microarray or in the karyotype, classical karyotype.
Okay, thank you, Professor. We go to the first presentation by Professor Katia concerning cleft lip and palate. Do we have any question? Yes, Professor Abu Frika.
Thank you very much, Professor Bilardo, for your very outstanding presentation. I'd like to ask you two questions. The first one is how accurate the ultrasound concerning the diagnosis of cleft lip and cleft palate. This is the first question. The second question concerning some of the syndromes, like Sprinzen syndrome or Pierre-Robin syndrome, or complex or sequence. Is it possible that the time will come for prevention of deletion of these chromosomes for the syndrome to be happened? Thank you very much.
Thank you for your questions. So the first one, the accuracy. Well, I showed you the data from the paper that we published on 330 cases of clefts. And the ultrasound diagnosis was accurate in detecting the external defect in 93% of the cases, so a very good accuracy. Less accurate in detecting the involvement of the alveolar ridge and of the palate, and that was 65%. So overall, the accuracy is becoming very good, because by using the standard views that I discussed, and especially the tangent view of the lips taken from below, we can reach a very good accuracy. Obviously, Sometimes we cannot see the face because the fetus is lying in such a way that it makes it impossible. And then, as I told you, you have to be patient and sometimes to bring the patient back. And obviously, if there is an oligohydramnios, there are special circumstances where we may be unable to do a full, accurate examination due to these circumstances. Regarding your second questions, well, there is a very important role for sonography for these syndromes. Many of these syndromes are recurrent, are familial. So I had some cases, for instance, of Pierre-Robin and syndrome, and especially the other one, the Roberts syndrome, where you can already quite early reassure the parents or not. And then you can take them with you for the following, the follow-up of the pregnancy. Well, regarding the possibility of intervene and correct the genetical defect, this was not the topic of my presentation, and it's an open window. I mean, obviously genetics is doing big step forward, but I think that for monogenetic syndromes, this will be possible in the future. Probably not for syndromes that are due to a number of factors where the genetic and the environment together play a role. So there is hope for the future, and probably in the future we will be able to cure a lot. But I still think that you will still need ultrasound examination, because that will always remain very important. And as we heard from Jihad, increasingly earlier. Yes. I hope that I have answered your questions.
Okay.
Hello, Jihad.
Thank you for the speakers. Many thanks for you. Thank you.
Thank you,
Yes,
and
you're
thank
welcome.
you for to all the people who
Yes.
stayed until this very late hour. Thank you.
Thank you, Dr. Ali. Thank you, Dr. Ali. Merci beaucoup.
Thank you, Professor
Thank-
Muhammad. And nice to see you, Katya.
Okay, thank you.
Thank you, thank you. Thank you Dr. جهاد. Thank you Professor Katia. شكرا جزيلا لكم جميعا. ان شاء الله ده نهايه اليوم، وبكره ان شاء الله نلقاكم على خير 10 صباحا في هول A هول B. هول C الايوتا كورس هيبتدي الساعه 9 صباحا ان شاء الله. شكرا جزيلا.